Good morning, everyone. We'd like to welcome you to our annual research symposium. I think it's number 5, if I'm correct. This is our opportunity to take part into and to understand the hard work of our residents and faculty as they have engaged themselves in scholarly activity and in some cases clinical research. And what we want to have everybody know is that this is an integral part of our educational process for residents and fellows. And we are certainly happy to find out and curious about what you have been doing in the last year or two at least. I'd like to start by thanking those who have put this together, including Michael Jordan, who is not here today, but his team and our medical staff office team who worked hard to make sure that this has come together. And I'd like to talk a little bit about why we do this and the role of scholarship and research in our educational process. Our common program requirements in the section 4D speaks about scholarship. Medicine is both an art and a science. The physician is a humanistic scientist who cares for patients. This requires the ability to think critically, evaluate the literature, appropriately assimilate new knowledge, and practice lifelong learning. And if there's nothing else that you leave these hallowed halls with, is the concept that learning does not stop even when you finish your residency. In fact, it may intensify because you're going to be anxious about the work that you do and the patients that you're seeing and hopefully making the right decisions. The program and faculty must create an environment that fosters the acquisition of such skills through resident participation in scholarly activities. Scholarly activities may include discovery, integration, application, and teaching. And I know that you think of yourselves as learners when you're a resident, but you're also supposed to be teachers of those who are coming behind you, and even with your patients and their families. That's all part of the scholarly approach to evidence-based medical care. A little further on in the regulations, the scholarly approach can be defined as a synthesis of teaching, learning, and research with the aim of encouraging curiosity and critical thinking based on an understanding of physiology, pathophysiology, differential diagnosis, treatments, treatment alternatives, efficiency of care, and patient safety. And I'm sure you've heard something about all of these terms and activities throughout your time in residency. But again, to be curious. We want everyone to understand that curiosity is what doesn't necessarily kill the cat, but leads us to new learning, new ideas, new approaches, and that is very critical. Sorry. Now, as we begin today, we ourselves, who will be listeners, will be critically thinking about what you're presenting or what is being presented, because we want to learn what you have learned. And we thank you all for participating and for being a part of this very important activity. I also want you to realize that our God is a God of curiosity, a God of free thinking, and of scholarly approaches. And he says to us in Matthew 7, verse 7 and 8, ask, and it shall be given you. Seek, and you shall find. Knock, and it shall be opened unto you. For everyone that asketh, receiveth, and he that seeketh, findeth, and to him that knocketh, it shall be opened. So he too encourages us to come to him, not in just blind obeisance or criticism, but by asking him. And I love the fact that the word ask, A-S-K, ask, seek, knock. It's quite congruous. So with that, we'll bow our heads as we ask him to be with us today. Our Father in heaven, we are so grateful for these young minds and for the curiosity that has led them to activities related to research and to the care, improved care of our patients in this community and beyond. May this day be a day of enlightenment. May it stimulate us to further curiosity, and may we, as a result, leave with a better understanding of ways to take care of our patients and to be thoughtful about the various scientific approaches to the care of our patients. In Jesus' name, amen. So we welcome you again to being with us today. As is part of the normal process of life, we're going to start with OB. No OB, no peds. No adult medicine. No surgeries. Yeah, that's right. We've got to have OB first. So today we're going to hear from our OB young scholars and faculty, and we're going to invite Dr. Tin Young, our urogynecology specialist, who is a wonderful person who exemplifies the characteristics of research, works with our residents, and helps us to remember all of the various critical thinking. So, Dr. Young, please introduce those who will be presenting.
Dr. Reese, thank you for the very kind words. I'm always humbled when I sit there and listen to all your wise words. We have a very nice collection of presentations today from the OB/GYN department, some of which will cover gynecological topics as well as obstetrical topics. I think you all will be very enlightened by the knowledge that you will gain from these things. Without further ado, we will start off with Dr. Rosa Avila, who will talk to us about extragonadal teratoma in the pouch of Douglas with malignant squamous cell transformation, a case report.
No pressure, I get to go first. All right. All right, so I did a case report on an extragonadal teratoma in the pouch of Douglas with malignant squamous cell transformation. It was published in the Journal of Reproductive Medicine in their December episode or issue. This is my table of contents. All right, so mature cystic teratomas, or as we more commonly call them dermoid cysts, comprise about 10 to 25% of ovarian neoplasms in women of reproductive age. They're usually unilateral and found in the ovaries. If they're outside of the ovary, we call them extragonadal teratomas, and they're most commonly found in the omentum. If they're outside of the ovary, and other places include the head, the neck, the mediastinum, the retroperitoneum, and the sacrococcygeal regions. Very rarely, like in our case report, are they found in the pouch of Douglas. They're usually benign, and 1 to 3% of them can have malignant transformation. And if there is malignancy found at the time of this discovery, it's usually metastatic, aggressive, and with a high recurrence rate. We found 19 reported cases of mature cystic teratomas in the pouch of Douglas, the first one being in 1978, and only one of them had malignant transformation, and it was adenosquamous carcinoma. The case is of a 56-year-old G1P1 postmenopausal female. She initially presented with abdominal pain, pressure, constipation, urinary retention, so all the bulk symptoms of a very large pelvic mass. On exam, she had a large fixed mass in the pelvis. CT scan showed a bulky cystic lesion measuring about 25 to 15 by 18 centimeters that was compressing the uterus, bladder, and the colorectum. Tumor markers were normal except for an elevated CA-125 of 63.1. She underwent an XLAB THBSO and an en bloc resection of the pelvic mass. Intraoperative findings were of basically she had normal gynecologic organs and this big, large cystic mass that was in the pouch of Douglas. Histopathologically, we found that the specimen had ectoderm, endoderm, which is what we would find in a dermoid cyst. So she had skin, sebaceous glands, hair follicles, and respiratory epithelium as well. We did, on higher power, we actually found marked nuclear pleomorphism, prominent nucleoli, so things that were kind of suspicious for cancer. And with further staining, it was positive for a squamous cell carcinoma. And it was a high grade as the cells were found to be very haphazardly arranged. So there are a few theories on how extragonadal teratomas come to be. 3 of them, in fact, and the first one is of an audio amputation and reimplantation theory. So a patient comes in and has an ovarian torsion, and it's not recognized in time, and she just goes on to auto amputate a piece of her ovary, and then it goes off to implant somewhere else and builds the blood supply on whatever is nearby. 2 is basically the same thing, except it's due to an iatrogenic cause, like untreated PID or during gynecologic surgery, and it's not recognized. And 3, which is what we thought our patient kind of fell under, was that the germ cells during embryogenesis are displaced. So along where they're supposed to be, that's kind of like where it develops, and it's outside of the ovary. Next slide. Okay, there's no agreed upon treatment for these teratomas with malignant transformation, but the most agreed upon treatment is surgical staging with postoperative chemotherapy with a taxane platinum-based regimen or with an alkylating agent. And there's some other things here and there that people can try depending on if they want fertility sparing, or they also are recommended like radiotherapy, things like that. So some of our teaching points through this case report are that rare cases present a challenge to the most experienced physicians. We're here at White Memorial, we have a very high risk population, and the rare doesn't always feel rare to us because we see a lot of really high risk things and things that in the literature are not seen very often. So we have to kind of rely on, one of our medical librarians, shout out to Myrna, to kind of do a literature review and see what has been done in the past to help inform our clinical judgment. We are fortunate enough to have, a great pathology department and CT scans, MRIs, et cetera, like at our disposal to help us kind of figure out what to do. And as always, health equity requires timely access to care to, not just OBGYN, but all subspecialties. And those are my references, and that is it.
So we have 3 minutes for any questions that the audience.
I finished too soon.
Oh, well, yeah, an extra 10 minutes today, so it's plenty for you.
Oh no.
Any questions from the audience? Yes.
What would expect the teratoma?
1 to 3% is what we found in our literature. Oh, the question was, teratomas are often benign, and how often are they malignant? And it's about 1 to 3% based off our literature review.
Yes, sir.
And where do they commonly metastasize?
Oh, shoot. Dr. Young? I can't remember off the top of my head right now. Probably locally in the pelvis, so near other structures, wherever. Yeah,
it's always common. You think about local spread first, and then other common places where you get high blood flow, such as the lungs and stuff like that.
Yeah.
Okay. All right. Wonderful. Well, thank you again, Dr. All righty. So we did the program change? So can I just skip to the third presentation? Okay, wonderful. So our next presenter will be another gynecological topic. Along the similar lines, Dr. Cynthia Rose will talk about intravascular papillary endothelial hyperplasia. Say that 3 times quickly, Dr. Idris. I challenge you. But intravascular papillary endothelial hyperplasia of the bladder in a patient with cervical cancer. Dr. Rose.
So to start off with, I'm going to talk about a case report. So this is a 74-year-old G6P6 with a history of stage 1B2 cervical cancer, status post robotic-assisted total endoscopic modified radical hysterectomy, bilateral salpingo-oophorectomy, and bilateral pelvic lymphadenectomy with sentinel lymph node biopsy with subsequent adjuvant chemotherapy and external beam radiation therapy, and brachytherapy. So of note, only 4 cases of bladder involvement of what I'm about to describe have been reported in the literature, and it's found that all these patients had received radiation therapy. So with regard to our patient's presentation, she initially presented with a chief complaint of postmenopausal bleeding in the form of spotting. This patient was found to have a firm, irregular 1 to 1.5 centimeter white lesion on the ectocervix anterior lip extending to the cervical os on pelvic examination. She then underwent colposcopy with biopsies at 12 and 1 o'clock, demonstrating moderate differentiated squamous cell carcinoma, and then at 6 o'clock, cervical intraepithelial neoplasia, CIN3. She was diagnosed with clinical stage 1B1 cervical cancer. So, with regard to the surgical pathology, it demonstrated metastatic carcinoma in 1 out of 2 lymph nodes with moderate to poorly differentiated squamous cell carcinoma measuring 5.3 in greatest dimension and lymphovascular invasion. She then underwent chemotherapy, external beam radiation, and brachytherapy. So with regard to her post-treatment follow-up, approximately 1.5 years later, the patient was then seen in urogynecology clinic due to complaint of urinary leakage that was worse after chemotherapy and radiation. She actually saw Dr. Young. So at her subsequent follow-up appointment the following year, she reported a recent emergency department visit due to hematuria in the setting of a normal renal ultrasound. She underwent in-office cystoscopy and was found to have a 1 centimeter bluish red irregular round mass in the posterior dome right of midline. She then subsequently underwent exam under anesthesia, cystoscopy, bladder mass removal, cautery of the bladder lesion base. So this is a picture that we actually took during cystoscopy intraoperatively in this case, and you can see that this is a 1 centimeter, it's in the posterior dome mass with a regular border, and it's red and white and kind of dark in coloration. So this is what we see on histopathology. So in the first picture, the papillary endothelial hyperplasia, Dr. Tan was nice enough to kind of describe it a little bit more in detail for us. And you can see papillary projections with plump endothelial cells. And then in picture number 2, with the hemangioma, you can see anastomosing channels of vascular spaces and blood vessels. So what is intravascular papillary endothelial hyperplasia? Also, we can just say IPEH. So an alternative name for it is Massoon's tumor. It was actually reported in 1923, first in a hemorrhoid vessel, and was described as a thrombosed hemorrhoid by French pathologist Dr. Pierre Massoon. So it is a rare benign lesion that often occurs in soft tissue, and it can present with dysuria, pelvic pain, obstruction, gross or microscopic hematuria, or it can have no symptoms at all. So these symptoms that I'm talking about with regard to the bleeding are often how gynecologic and urologic malignancies can first present, and then this can require the patient to undergo a further, more invasive workup. And the thought process behind this is if we're diagnosing this, then the patient can get overtreated if this is thought to be something more malignant as opposed to benign. So histologically, IPEH demonstrates papillary structures coated with hyperplastic endothelial cells within a vascular lumen. Once the lesion is identified, IPEH is most often misdiagnosed as angiosarcoma due to similar histopathologic characteristics. And IPEH typically occurs in the head, neck, and upper extremities. However, like I said previously, in 4 case series in our patient, this was seen in the genitourinary system. What you will see with IPEH is that it's actually intraluminal as opposed to an angiosarcoma, which it would be extraluminal. So with regard to my discussion, the topic of IPEH of the bladder has been seen in rare cases involving patients with a history of radiation therapy for treatment of endometrial, prostate, and bladder cancer. However, our patient is a 74-year-old with a history of cervical cancer, and she presented approximately 1.5 years after she received radiation with the presentation of hematuria. She then underwent a subsequent cystoscopy, and the pathological specimen in the posterior bladder mass was diagnostic on histopathology of intravascular papillary endothelial hyperplasia. So it is important to differentiate IPEH from angiosarcoma because of the inability to make a correct diagnosis could then lead the patient to have to undergo unnecessary radiation and surgical intervention if it's thought to be malignant. So in conclusion, our case report is unique because no study, to our knowledge at least, has included a patient with a history of cervical cancer. It has been noted that IPEH was seen in patients with endometrial, prostate, and bladder cancer, along with cancers of the head, neck, and upper extremities. The common presentation of painless hematuria, as seen in our patients and also described by other authors like Tavora and Jazzarelli et al., presents a question of whether physicians should routinely screen post-radiation patients for painless hematuria. This screening could be performed to diagnose individuals with IPEH or angiosarcoma earlier, rather than awaiting the presentation of their symptoms. This is my work cited. And a special thank you to Dr. Young, Dr. Shamas, and Dr. Hayes Bautista. Oh no.
All right, Dr. Rose, as hard as you try, we have time for questions. Are there any questions from the audience for Dr. Rose? Doctor.
PIEH is consequences of radiation therapy?
So she believes that this disease, PIEH, is a consequence of radiation therapy. Is that correct?
So I think based on what we have read in the literature, it seems to be an association with radiation therapy. It's difficult to say if it's a direct causal relationship with it, but I believe so.
Yes.
My name is Eva in the Cancer Center, and we have 2 boards here on the campus twice a month. I'm wondering if your team would be open to presenting some of these cases at tumor board for statistical purposes and discussion and education of our medical staff here at the hospital.
Sure. So Eva wanted to know if our team wanted to present such cases at tumor board. And I believe we do go to tumor board twice a month and present predominantly cancer cases, but I don't know if there's leeway in time in presenting interesting findings such as these. So you all probably know better than I do.
I think that'd be a great idea.
Wonderful.
Okay.
I'm glad to link you in if we need to get it on the agenda.
Excellent. Thank you.
Thank you.
Any other questions? Well, wonderful. Thank you, Dr. All right. Okay. So we will now pivot to our other half, and for Dr. Reese, our better half, on obstetrical topics. Our first presenter will be Dr. Kiana Tang, who will talk about antenatal interventions to promote exclusive breastfeeding, a survey.
All right. Hi, everyone. I'm Kiana. So I did a little survey on antenatal interventions to promote exclusive breastfeeding with my attending, Dr. Denegi. So some background, ACOG recommends that we advise our patients to exclusively breastfeed for the first 6 months of life at least, with then continued breastfeeding in addition to other foods as long as mutually desired. So this is for a number of reasons. Breastfeeding provides complete nutrition for the babies as well as infection protection as mom passes along some of her antibodies during the first critical months of life for the baby. Breastfeeding also has significant health benefits for mother, including weight loss, as well as decreased risk of later in life diabetes, heart disease, and even cancer. However, despite all of this, according to the CDC, about 84% of women leave the hospital breastfeeding, which means we're doing a pretty good job recommending that they start breastfeeding. However, only 25% are exclusively breastfeeding at the recommended 6 months of life. So my hypothesis was that instilling visual breastfeeding educational materials throughout a clinic providing antenatal care would increase the rates of exclusive breastfeeding over routine care. So what I did was did a survey in our White Memorial OBGYN medical clinic, and we surveyed women receiving antenatal care there from September through December And then subsequently, I placed some of these educational materials in high visibility areas throughout our clinic. And then subsequently again surveyed these patients from January through April of 2022. And then rates of exclusive breastfeeding, mixed feeding, and exclusive bottle feeding were compared between the two. So this is an example of one of my educational materials that I put up. It lists a bunch of the benefits for baby of exclusive breastfeeding, as well as some of the benefits for mom. ACOG recommends that these educational materials that you provide diverse representation, as well as minimize product ads for things like formula and potentially distracting things. So I thought this was a great example of that. And then this has a lot of the same information, but in Spanish. And so here are my results. As you can see, exclusive breastfeeding went from about 43.75% to about 66% after the installation of the educational materials. So the blue bar here is before, the pink bar is after. Formula feeding did increase from 6.25% to 11%, but our mixed feeding is what significantly dropped from 50% to 22%. I also took some additional demographic type data, and the thing that stood out to me was that the parous women versus the nulliparous women. So P equals 0, meaning she has not had babies before, versus a P greater than 0, which means she has had one or more babies before. And so planned exclusive breastfeeding went from about 60% in my P0s to about 40.74%. Formula feeding, none of our P0s planned to formula feed at all, versus 7.4% who had babies before. And then 40% of our P0s plan to mix feed, and then our P greater than 0s, 51.85%. So my results, I think, suggest a few things. They definitely suggested a trend toward increased rates of exclusive breastfeeding, with education being provided during antenatal care. And then another interesting thing that I found was that a larger percentage of our nulliparous women who had not had babies before planned to breastfeed, suggesting that experienced mothers are moving away from breastfeeding. So I think this is for a number of reasons. First of all, breastfeeding is hard. And so this, I think, is a reason why women who have maybe tried it in the past are potentially moving away from it. And it also highlights a need for more antenatal education to be addressing exactly that breastfeeding is hard, and that we need to anticipate and plan for potential issues that mothers might have. And then also breastfeeding is even harder when you're caring for other children. So potentially another reason why our experienced mothers were moving away from that being their plan. Now, the limitations of my study, I forgot to mention this before, but my N of, or my total number of surveys before my intervention was 32, and my N after was 9. So I think that my study was significantly limited by survey uptake, and also potentially issues with administration of the survey, as our clinic actually sees 50 new OB patients per month, as well as 250 return OB patients, so 300 total patients receiving antenatal care every single month. So I would have expected a lot more survey yield over the course of 3 months, both before and after my intervention. And then also, this is just an observational study, but I do think that it leads us to lots of potential future directions. So obviously, adequately powered studies would be a potential future direction to evaluate more soundly whether providing educational materials antenatally would affect our exclusive breastfeeding rates or not.
And then also, this definitely points to other avenues where we could potentially provide our mothers additional support, including antenatal lactation consultations, as well as postpartum support, especially as, we've identified that breastfeeding can be really hard with, all of the demands of caring for other children as well. So providing postpartum support would also potentially help with that. And these are my resources.
You did such a wonderful time. We have 4 minutes for
wow.
questions.
Oh, no.
Extra questions for you. All right. So does anybody in the audience have questions for Dr. Tang?
Dr. Idris.
Of course. Of course.
I find the issue of breastfeeding a lot more complicated than simply education. Because the education that I get from my mom and grandma about raising my kid is a lot more significant than the education that my obstetrician is giving me during a 9 months of prenatal care. So I think the way we are giving education is not necessarily optimal. Does your clinic have any plan to have a specific lactation education classes for these moms?
You repeat that question, unless you want to.
No,
All right.
you go ahead.
So Dr. Idris comments that she finds that breastfeeding involves much more than just education. It's a complicated issue, noting some education she was provided by her mother, and wanted to know if that our clinic provided such education or such resources for the mothers.
I fully agree. I think that breastfeeding, what we've touched on today is just the tip of the iceberg in terms of, how complicated things can be, potential issues that mothers might run into that they might not have even thought about before when we are providing this antenatal care. And so, yes, I fully agree. We do provide our patients with referrals to WIC, which does provide that consultation, but our clinic specifically does not have any plans to provide that within our clinic at the moment. But I do think it's a good future direction for us.
Yeah. And there's probably a little bit of a washout effect with this survey because, as you know, our hospital adopted baby-friendly program. And so, prior to that, our breastfeeding rates were a little bit lower. And since adopting that program, they've risen quite a bit. So you might have a little bit of difficulty in terms of seeing a significant difference with the duality of the programs. Any other questions? All righty, Dr. Tang, thank you.
Thanks, Dr.
All right. Okay, our last presenter from the obstetric side of our program will be talking about understanding nonverbal communications in a pretty related population in this community, Latinas, OB patients. So Dr. Tiffany Yang will present her findings.
Hi, everyone. My name is Tiffany. I was really nervous the podium would be too tall. Kind of is. Great. Okay. It'd be great. Okay. Like Dr. Young introduced, I will be talking about nonverbal communication in this Latina OB patient population at White Memorial. So just some guide to talking about what we're going to speak about background first, the methods of my study, what we found, and what in conclusions we can draw. So some background, and this study was inspired by the Hospital Consumer Assessment of Healthcare Providers and Systems. Mara Bryant initiated this study initially to learn more about our patients' experiences and expectations at White Memorial, particularly on labor and delivery. To go over the goals of HCA-HPS, we want to compare patient experiences in different hospitals. There's financial incentive to improve the quality of the care we provide, and these scores that are provided by patients about our hospital are linked to reimbursement, and we want to increase the transparency. The domains that are assessed are the care that's provided by nurses and doctors and whether patients felt like they were treated with courtesy and respect, the hospital environment, the experiences patients had within the hospital when they left the hospital, and what their overall rating of the hospital was on a scale of 1 to 10. So the goals of my study are largely based in the patient population that we serve. So we serve 93.5% Latina patients, and this study was created in order to improve our hospital's ability to meet their expectations. We structured this study so that the patients felt empowered to identify topics and issues that were important to them in their hospital experience. Secondly, was to improve patient-provider interactions. I think it's true that patients and providers, whether that be physicians or nurses or whoever they come into contact with within the hospital, have to co-create a shared meaning about the health situation and what the plan is so that we can accomplish something together. And communication between the two parties is essential to producing shared meaning, and the quality of the communication that we create influences the achievement of the health goals. So ideally, we have good quality communication to enhance development of shared meaning, and eventually that strengthens the therapeutic alliance we create, facilitate shared decision making, and increases the adherence and health outcomes of our community. So the methods that I employed, or we employed to facilitate this study, was we created this qualitative design for a conceptual developmental study. There were 40 women that were placed in 11 focus groups. 19 of them were Spanish dominant, 21 were English dominant. The focus groups were facilitated by a bilingual, bicultural RN, and there were open-ended probes again to help encourage patients to talk about what was important to them rather than what we identified was important as hospital employees and administrators. And then we used a constructivist grounded theory method to analyze the results. Okay, so we were surprised to learn in our results how important nonverbal communication was to the patient population. During the initial stages of forming a provider-patient relationships, the participants described 4 dimensions that provided clues to a good relationship, one that was respectful and courteous between providers and patients. And those 4 were facial expressions, the tone of voice, bodily gestures, and physical touch. So in terms of Spanish dominant participants, they described looking at So in terms of patient perceptions across the board, they felt like they were being respected by providers when they were treated in specific ways. And the categories that we identified, I'm just going to say the ones in English because my Espanol is más o menos. So caring, kind, people who felt like they were cared for well or treated well and in a good way or with good treatment. And so those were very common themes across Spanish speakers and English speakers. And the dimensions, again, that we found were face, voice, touch, and physical stance or gestures. And then some of the properties that were associated with each are smiling, the tone of their voices, if they were speaking sincerely or what was perceived as being sincere, how they touched the patients during examinations, if it was in a good manner or not, and then whether they had physical presence in the room during their encounters. So these are just some examples that the patients brought up. These interviews were all directly coded for so that it was a direct translation from Spanish to English if necessary. So patients felt like facial expression was very important to their overall satisfaction and felt like they would better comply with follow-up and within the encounter. So an example one patient provided was, yes, the person was helping me. I tell you, they were very amiable. I never saw them with a bad face nor with an ugly facial expression directed towards me. And that was a positive experience that they had. So, sorry, one more thing about facial expression was that smiles were often described as an early indicator of respect towards the patients, whether it be from a provider, a nurse, or someone who checked that patient in. So another aspect that we looked at was tone of voice. So just the way that their voice sounds, because you can tell when either they are mad or trying to be nice to you. Hi, how's mommy doing? Are you okay? Do you need anything? How are you feeling? Like they sound happy when they're talking to us. And both Spanish and English dominant participants described a provider or staff member tone of voice as indicating how good the relationship was going to be. Touch. Procedural touch was also an addition to an overall perception of being an amiable relationship. So they should explain the procedure they're going to do here, and with good manners. It shouldn't be that they only come and give you a shot and they don't even say, hi, how are you? They should give you a smile. That way you can feel the vibe of the other person's humor. And then lastly is bodily gesture was also identified as a core category. The providers being physically present in the room was seen as an essential component of a respectful demeanor. And one Spanish dominant participant expressed her satisfaction at always having a provider or a staff member present in her room. An example they gave was, but I am content because ever since I arrived, they have never left me alone. They did not move me from the room. They never left me. There was always a person there from the staff here of the hospital to be with me. But on the contrary, there's also patients that experience disrespect and discourtesy, and they describe seeing providers or staff in a bad attitude and in the same dimensions, so in the face, the voice, touch, and physical gestures. And I'll go quickly through my examples of those. So Spanish dominant participants often looked at the face when they were evaluating disrespect, particularly because sometimes we don't have the ability to communicate in their preferred language. So facial expressions were very important to them. And some participants described expressions that indicated a near total lack of respect for the patient, and they described it as there are people who answer you with such a face as to say, if you're gonna, and they felt like if you're gonna have that expression, you better not come to work today. It's that sometimes there's nurses who provide their services in an unpleasant manner, and how do they describe it in an unpleasant manner was asked, and they said they do it in a bad manner and therefore it's bad treatment. Other facial expression thoughts were that they described it as una jetona. So I don't know what that meant, but they basically described it as kind of a frowning, like you come in with a frown, like you don't even want to be here. Today's just another shift. And then she rolled her eyes. So the tone of voice was also really important. They viewed staff members showing disrespect when they had a brusque, a cold, or an arrogant tone of voice. So they were just described as impolite. The form of talking, the tone that they use when they are speaking to someone, it tells you a lot. And nurses if they want to help a patient, they will. If they don't, and they're just doing it as part of their job, you can decipher that. And then touch. So the procedural touch also communicates a lack of courtesy to the patient when it's done very roughly or with a heavy hand without any regard for the patient's sensations. And one patient recounted having an IV administered in a mala manera, and rather in a way that would have made her feel better. So they hurt the patient or they have a heavy hand. And then lastly, bodily gestures. There are people who, when they're talking to you and they're about to ask a question, they just turn around and walk away. They don't even wait for your response. And I was about to ask a question, but they didn't even say, okay, is there something I can help you with? And they just walked away and they didn't come back. So some conclusions that we drew from our study was that there's a lot of verbal items and nonverbal items that can be associated with respect and courtesy as part of the HCA-HPS survey. And this study points out the value of understanding those nonverbal communications for courtesy and respect in order to improve our patient experiences, especially at White Memorial. And we hope that you will use these findings to provide actionable information and draw more like self-reflection on how you present yourself to patients and how we interact with those that we serve. And this is also an opportunity for us to think about what is the root cause of all of these negative nonverbal communications? Are there implicit biases at stake? Are there things that we need to just reflect on and work on and drill down on in order to cause quality improvement? Thanks for your time.
Dr. Yang, as hard as you try, we got donated time from Dr. Robinson to give you at least 10 minutes of questions from audience.
50.
So sorry, we have plenty of time for questions from our audience. It's a wonderful topic, and I think it deserves some attention. Audience members, any questions?
I inundated them. No. Okay.
Of course, you have to come and save the day. Question.
Well, it's a comment. Background, and we underestimate. We perceive what is not the same people. Sometimes we do things that are acceptable in culture, but not acceptable. The benefit of being at White Memorial is that 93 are Hispanic. So maybe what we need to do is take the time to learn the Hispanic culture enough to be able to understand what they perceive as acceptable, and know that it is different from my culture. If I go home and say to my kid or my husband this, nobody cares. I come to White Memorial and I tell a white woman, you did, and say, you're pointing your finger at me. And that goes across, and I think it's a very important research for us, because we are into customer service now, and our patients need to be able to trust us, and they trust us better if they feel we respect them enough. So.
Yes.
I didn't have a question.
But thank you very much for the comment. Dr.
Underappreciated. 70% of our communication interaction, and when you're from another country or you don't understand the language, or even if you do understand the language, we're always reading people's faces, especially when we're under stress. We look at the physician to see, are they not telling us everything? Can we trust what they're telling us? I'm really afraid. And if I sense or see those gestures in the face, then I'm getting cues that something is not right. Long time ago, I was trained to watch babies who are exposed to cocaine. And we were trained to look at facial expressions and shifting of the eyes, the grimaces, because babies can't talk. So all that we could depend on was those very subtle cues that you have to be trained to catch, because we can sort of not see them. So I guess, you know, what Dr. Yan presented here is so important. And it's so important that we kind of step back and watch ourselves reading other people's nonverbal, so that we can practice how it is that the other person who's receiving those messages might be also interpreting our messages to them. Thank you.
Thank you for your comment. Yes.
Yeah, I was actually so one thing is as you get can be fairly one of the things I think that's pretty basics. Standing up, take things your body. And like this. try to. Even if you're not. Those are also not there. So we all do it. Not looking for. No, there's no phone call unless somebody's. This is phone up. Surgery. If they need us, they'll call into the OR. Phone call if you need to answer my home. Simple thing. You know, these are like nonverbal with your staff too, but like sitting down, not crossing your arms, smiling. Say something like, "How's your kids?" Sometimes there was a whole article in Proximity about asking people about pets. How would that stuff? Crazy. Once you get to another thing like, "Oh, this person." These are little things that kind of personalizes or personalizes what you're doing. These are key. You know, I think the culture of things all the time. This is certain culture is bad. They can to a certain culture.
All right. Thank you very much, Dr. Newman.
Very easy to talk. Read reviews like this guy. And you don't even know shit. So these are important. But as you know, presence and it's very important to sit down. Ask something. Be a position. Not just this, but this that helps.
Okay. Thank you very much for the comments. I do actually have a question for you. So this was a huge undertaking, a very important topic, transcended several residencies, classes. What's the next step? These are wonderful findings. What's next? I mean, we have Mara in the back there, and I'm sure she wants to take these findings and make it useful, make it purposeful for our patients.
So I think that, or I don't have to repeat the question, right? Okay. So I think that given the fact that we've been able to break down to very concrete ways that we can, I guess, train ourselves to communicate well non-verbally, we can set up practice sessions in order for us to be more aware of what we're doing with our nonverbal communication, especially for providers to kind of have a simulation or just to educate everyone who does interact with patients in order to really be specific in what we're doing in our actions and how we present ourselves as providers to our patients on a daily basis.
Thank you.
So the first thing I'm going to do is smile. You may not want to see my teeth, but anyway. And I think all of this is so important because, you know, I don't know, in my own now 50 years of practice, I've had many patients say to me, you know, you're the first doctor that has taken the time to just talk to me and explain what's going on. And I think that's quite an indictment on our profession if patients feel like those who are taking care of them don't really care. All right, so we're going to switch gears and do a little orthopedic presentation. And we're privileged to have Dr. Isaac Manapudi and Dr. John Itamura to present their work and research today. Dr. Manapudi is a research fellow in the Curl and Job Orthopedic Clinic, and so we're anxious to hear what you have to say.
Just to clarify, I'm not actually a doctor. I just graduated from undergrad this past year. So I'm Dr. Edamura's research assistant. So yeah. So today I'll be presenting the long-term follow-up of patients that received a custom glenoid implant in reverse total shoulder replacement in order to treat severe glenoid bone deficiency. So to start, Dr. Edamura has no deals or financial interests with Zimmer Biomet. So in the world of total shoulder replacements, there's the conventional method that mimics anatomy, where you have a prosthetic ball that's placed on the end of the humerus, which in turn sits in a glenoid implant. And the reverse method is essentially where these two prostheses essentially switch locations. But as you can see, regardless of the method used, there needs to be an adequate supply of bone in order to get good screw fixation. And the key anatomic structure to pay attention to is the glenoid, as seen there. It's in light blue. And on the furthest to the right, there's this Antuna classification system. And as you can see, someone that had a combined defect in the lower right-hand corner, it'd be very difficult to get good screw fixation if someone had a glenoid that looked like that. So how do orthopedic surgeons get around this bone loss? Well, they essentially fill the hole or defect with bone. And they can do so by, if they haven't had a shoulder replacement in the past, their primary patient, this procedure often involves cutting off the end of the humerus, and this can be used as a rich supply of bone. If these patients have had a shoulder replacement in the past, then orthopedic surgeons have to become more creative in their methods of extracting bone, and they can do so by taking bone from the pelvis. It's called the iliac crest bone graft. They can take the end of the clavicle. It's called a distal clavicle excision, or they can actually take bone from the femoral neck or head, as seen on the right with the X labeled. You can actually see where the bone is placed into the glenoid. So this is a difficult technique to actually rebuild the surface of the glenoid. I included this algorithm that was provided by the Mayo Clinic, and what orthopedic surgeons have to consider when rebuilding the glenoid is the actual positioning of the graft, whether it's healthy or it's going to deteriorate or it's going to incorporate well with bone. And then after they've rebuilt the structure, is it sturdy enough to withstand and sustain implantation? And any of these factors, if at any point in rebuilding this glenoid something goes wrong, glenoid component loosening can happen and subsequent failure could arise. So the literature actually reinforces this occurrence of failure. So I've included these 4 studies just to support the conclusion that certain structural allografts to treat severe glenoid bone loss can lead to suboptimal patient outcomes, particularly with clinical and radiographic failure. The first study by Ho 2020, 25% out of 44 patients had complete radiographic failure. And the next study by Osger 2016 looked at the femoral neck technique in general, and only 7 out of 11 allografts survived a year. This study by Jones 2020 showed poor rates of graft incorporation. And finally, Iannotti 2012 showed high rates of graft deterioration, poor rates of graft incorporation, and the implants that, or the glenoids that actually had to be drilled into with screws, 7 out of 9 actually failed. So this is just to give you a visual of what it looks like when the glenoid component loosens. As you can see, that's a very painful looking x-ray. And a conclusion from Iannotti, the last paper I described, says that the results of the study suggest the need for better methods of management of severe glenoid bone loss. So this change in thought is these suboptimal clinical outcomes that led orthopedic surgeons and experts within the field to reevaluate their approach when dealing with severe glenoid bone loss. And the proverbial concept of seeing a glass of water as half full or half empty analogously represents this change in thinking. So this is a landmark paper published by Williams and Iannotti that calls for this change in conceptualization. And they state that it may be useful to think of the glenoid in terms of what is left for support and fixation rather than what is missing. And therefore they modified that. They advocated for a modification in the Antuna glenoid classification system I showed prior to describe the presence of available bone rather than to describe the defect. So where does that leave us today? Instead of this approach of rebuilding the surface of the glenoid, we actually altered the implants so that they fit within the defect. They're essentially keeping the defect. And as you can see on the left side, this patient's glenoid has some posterior wear. These are called off-the-shelf metal augments, meaning they have a degree of inclination or angle to them to account for specific patterns of wear. So for instance, this patient has posterior wear on the left. You can see right here that there's this angle right here that actually enables to compensate for this loss of bone. Or you can use patient-specific implants. So what are patient-specific implants? How are they made? They use a combination of computer-aided design and computer-aided manufacturing technology to create implants that directly correspond to the anatomy of given patients. So Dr. Itamura will upload CT scans into a 3D rendering program called Blueprint and essentially assess how these off-the-shelf implants fit in the glenoid. And if there isn't good fixation and he tries out various implants, then a specific PSI will need to be made. So this is just a good visual to see. This is actually within the program Blueprint. You can see the key metric to look at is right here. It's base plate seating. So this is the actual glenoid implant and how well it actually sits or fixates in the patient's native glenoid. And so if a patient fails to get at least 50% base plate seating with the native glenoid, then they are considered for a custom implant created by the Vault reconstruction system. So what is the VRS? It's a patient match 3D custom titanium printed, 3D printed custom titanium implant that's engineered to address the severe glenoid defects. And it's the only implant that is commercially available. However, few publications exist investigating the long-term follow-up. So the purpose of this study was to present the 2-year minimum clinical and radiographic outcomes of patients that actually received this implant. So this is a retrospective study of patients undergoing this procedure here at White Memorial with a 2-year minimum clinical and radiographic follow-up. So between September of 2017 and March of 2020, 50 patients received this implant, and of those 50, only 13 were unavailable for 2-year follow-up. It leaves us with a total of 37 patients. So data was collected pre-op and at each post-operative visit, and we did a full range of motion workup, which includes forward elevation, abduction, external rotation, adduction, and internal rotation. And we used 6 shoulder functionality scores: DASH, disabilities of the arm, shoulder, and hand; CONSTANT, which is a clinician-assisted exam; ACES, the American Shoulder and Elbow Surgeon Score, simple shoulder test; and then 2 subjective measurements, one being their overall subjective rating out of 100 of their shoulder, and then a visual analog scale, which is just a pain reading on a scale of 1 to 10. And Dr. Itamura and his fellow would assess each radiograph at each follow-up visit to see if there's evidence of scapular notching, loosening, or other signs of implant failure. So here's the entire cohort data to show there's 37 patients, average follow-ups 35.7 months. Here's the statistical analysis. When evaluating the entire cohort, each metric that we evaluated showed a statistical significance at an alpha of 0.005. And here's the primary patient data: 15 patients, follow-up 34.73 was the average length. This, however, the statistical analysis of the primary patients and external rotation was the only metric that did not meet clinical significance. However, the p-value was 0.06, and we anticipate as we get more patients in the study that this will approach significance. This is a revision patient data. There's 22. Average follow-up was about just over 3 years. And again, all measures evaluated showed clinical significance. So there were complications in 7 out of 37 patients. However, of these complications, none of them actually were related to complications of the glenoid. There were 2 failures. As you can see, this right there, the screw broke, and that was an actual glenoid implant failure. And then up top was a patient that got infected shortly after surgery, and it was pretty intense looking. And you can see the VRS implant shortly after. And so in this study, I had a true glenoid failure rate, Dr. Itamura, of about 2%. So in terms of access to these implants, Dr. Itamura fought against the state of California's workers' comp board for 2 years in order to make this implant accessible to anyone that displayed a clinical need as opposed to their financial standing. And at least 4 patients in the study were able to receive this implant with workers' comp insurance. So as described with the presented literature, the current methods to treat severe glenoid bone loss with methods of bone grafting have led to suboptimal clinical outcomes. And this is partly because this technique of actually rebuilding the glenoid is difficult to do with severe defects. They have to think about high rates of graft reabsorption, how the overall graft is positioned, and whether or not it's actually incorporated with the bone. And this summary statement is helpful to kind of conceptualize the state of the field. We're saying techniques are currently limited by the surgeon's ability to create and fix bone grafts and the relative lack of customized components that could make the procedure more reproducible. And the VRS is one of those customized components. So in sum, the VRS is a good option for treating severe glenoid bone loss. However, it is expensive and logistically difficult to implement. It costs about $13,000, which the hospital then gets reimbursed through patient insurances. It does take a long time to be made, for it's made by engineers in Warsaw, Indiana. And just last night, Dr. Itamura let me observe a VRS surgery. And the time from which the implant was made, the patient's glenoid actually deteriorated even further. So the implant actually didn't fit. So that is potentially moving forward. We have to think about the timing of when these custom implants are made so they're truly custom and actually fit in the patient. And it does require a degree of technological literacy and technical training to run these preoperative programs and provide the best outcomes for their patients. So the overall conclusions, the long-term results using the VRS and reverse total shoulder replacements have shown sustained and promising results in treating severe glenoid bone deficiency. And this is supported by clinically significant improvements in all measures except for external rotation. However, this was a subgroup sample analysis of the primary patients alone. As an entire cohort, everything displayed statistical significance. And the radiographic evaluation, there was low glenoid complication rates, broken screw with an unknown cause, giving a percentage of 0.0027%. So just food for thought. In fact, Dr. Itamura has had only 2 out of 135 cases that have a true glenoid complication. And of course, that includes all the patients not that weren't included in the study. This is the total amount that he's done, giving a total failure rate of 0.014%. Thank you.
Questions?
Yeah, so, looking at this study compared to the previous studies that showed much higher failure rates, what are we attributing the prior failure rates to? Was it a vascular issue? Was it a graft versus host issue? Was it just a poor fit issue? Because if it's a poor fit issue, the time to placement issue of this graft is going to be a problem, obviously, at the end, because by the time you make this very difficult thing to create the titanium, it may not fit so well. So where do we stand from that perspective? And why these other studies show such poor failure rates and your study showed such great failure rates?
Other studies used allograft. So if you have an irregular defect. So the question is, why do other studies show high failure rates? So number one, you're basically trying to contour allografts into a complex shape, and unless you're very skilled with a saw, you can't do that. So one of the benefits of using 3D printed titanium is you can take the CT scans and they'll actually print the defect exactly. So it's like if you had a toilet bowl that somebody broke, you can print that and rebuild your toilet bowl from the inside out. So in that way, 3D printing technology has really evolved so that we can be very precise. Obviously, in the 2 cases that we couldn't get it to fit, we kind of pushed the limits. Even though the FDA allows you to use it for 7 months, I was just telling the manufacturer this morning on a phone call that I think we should probably not go more than 5 months because I think the contours will change. The issue is getting a CT scan requires a whopping dose of radiation. So if you look at the literature, just because you get a CT scan doesn't necessarily mean you're going to get low radiation exposure. In the 90s, one of the Cedars machines malfunctioned, and they had a high cluster of neoplasms from that. So obviously, even though I used to get lots of CT scans, there are definite side effects to getting that. But I think the reason why this works is because we're using metal instead of bone. So when I argue with my colleagues at meetings, they're like, well, why do you spend all this money? I said, well, it's still cheaper to spend $6,000 to get something printed than to take patient back again when that fails. And the problem with the shoulder, the socket is like, I consider it like a potato chip with a little piece of bone on top. You only get so many hits, attempts to make that right, and there's no more bone, and then that's it. There's no more option. So the glenoid is a very small bone, and it's not that easy to get good exposure. Luckily, that's one of my specialties, is doing revisions of revisions of revisions, but it is a complex area. I think that we're trying to cut down the time to get quicker 3D printing. There are some companies that can actually, they're thinking that they can probably get this done in 2 weeks, which means there'll be very little difference. But the biggest issue with this is cost. The issue with MRIs are not as good for bone. So you actually need very thin slices. So you need 1/4 millimeter slices to recreate all the variations in topographic deformities. So there are some companies, one of the companies I'm working with, trying to do MRI renderings, but it's just not the same resolution as CT scans. And because there's typically implants in, you get a hardware artifact, which makes it very difficult to evaluate and calculate the defect. Any other questions? So I'd like to actually thank White. White supports my office. I'm one of the weird guys that actually is a Cedars physician, but White's always given me support. And with Isaac here, we're able to pump out papers. This takes a lot of work to do patient-reported outcomes. So just getting patient-reported outcomes, we do 6 different outcome measures. It's a hassle to do all these things. And having hospital system support you so that you can actually get this data is so helpful, because otherwise I would not be able to do this. So I'd like to definitely thank White, because without this, we wouldn't be able to publish papers from my office. Thank you.
Oh, this way a little bit. Is that better? Keep going. That's good. Are we good? Oh, okay. Okay. My name is Dr. Jose Ponce. I'm the clerkship director of the Podiatric Medicine and Surgery Residency Program. Today we have 2 of our residents that are going to be presenting. First is going to be Emily Shibata, and she's going to be discussing the application of indocyanine green fluorescence angiography in limb salvage. And then also one of our first-year residents, Armin Dadka, he's going to be presenting on diabetes-related major and minor amputation risk increased during the COVID-19 pandemic. And both of our residents worked closely with their attendings, Dr. Jaminelli Banks and Dr. Stan Mathis, who's our program director. So I'll go ahead and leave the floor. Emily, we'll go ahead and start here.
So my presentation today will be about the application of indocyanine green fluorescence angiography used in limb salvage. And so I'm going to be talking about a little introduction of diabetic foot ulcerations, the fluorescence angiography, and its application. And then I'll be presenting a case report of 2 patients, the results and conclusions that we drew from the use of the fluorescence angiography. So diabetic foot ulcerations, they are complex and lifelong conditions for patients with diabetes. They account for over 20% of diabetes-related costs in the United States, and over 2/3 of them typically take greater than 12 months to heal. And unfortunately, recurrence rates are around 65% at 5 years after healing. Infection and gangrene typically are the conditions that follow diabetic foot ulcerations and are the leading cause of amputations, and are very early markers for macro and microvascular disease. So in the cases of diabetic or vascular disease and limb salvage, there are traditional means for assessing perfusion. One of them is ankle brachial index, also known as ABI, arterial duplex ultrasound, transcutaneous oxygen pressure, CT angiography, which are all very useful tools for assessing the perfusion of a patient. But currently they are lacking ways to demonstrate micro perfusion at the region of interest. And so indocyanine green fluorescence angiography, which I'll be referring to as ICGFA throughout the presentation, allows for a rapid and qualitative assessment of tissue perfusion, and it can serve as an important adjunct to these traditional means in order to help guide therapy and outcomes. And so this is basically the fluorescence angiography system. The one at white we have is called the SPY Elite, and it's made by Stryker. And this system has commonly already been used in GI cases, cardiothoracic cases, as well as plastic cases. And they use this intraoperatively to help visualize the microvascular flow. So it consists of an imaging head, which is equipped with a charge coupled device, camera, a laser light source, and a distance sensor. And this machine is used in conjunction with the indocyanine green dye, which is a sterile water-soluble dye. It's a safe dye for patients, especially with renal disease, because it's cleared by the liver and excreted into bile unchanged. And so how this works intraoperatively, you would inject this into the patient's IV, the dye, and then place the area of interest underneath the camera. And then around 90 seconds is when you have max perfusion, max uptake of the dye. So at that time, this whole thing is being recorded. So you can see, if the area of interest actually has good microperfusion intraoperatively before you decide to make an incision or for any treatment outcomes. And so, the majority of literature so far using this system in the lower extremity have been in conjunction with revascularization procedures and vascular surgeons. And so this was a good study that helped guide our research question, the 2017 article by the World Journal of Surgery. And the aim of the study was to examine the usefulness of the fluorescence angiography on the quality of revascularization. And so this study had 104 limbs with critical limb ischemia. And they used the fluorescence angiography pre and post revascularization to see, if they were successful. And then the parameters they used to see if they were successful was the maximum intensity of the uptake of the dye, as well as the rate of uptake of the dye. And so this was they did conclude that this was successful in determining the quality of revascularization and did help guide treatment outcomes for these patients, as well as possible if the limbs were salvageable or not. And so this did guide our research question into podiatric medicine. So we decided to use this intraoperatively to see, will this patient be able to heal at this incision site, or is it non-salvageable? So for our case report, we have 2 patients with complicated diabetic foot infections and vascular compromise. We use the fluorescence angiography using the SPY Elite system as part of our intraop assessment to evaluate the extent of malperfusion and to decipher whether the patient had surgical site healing potential. And so what we decided intraoperatively, if a patient did have good perfusion, we would offer them primary closure, which means closing it immediately in the operating room with sutures. So that would place tension on the wound edges. If it did not show good perfusion or uptake of the dye, then we would offer the patient delayed primary closure with a wound vac application. So in our thoughts would, so our goals of this was to see if the less tension on the skin edges would allow for healing and less complications in the long term. And so that's our hypothesis. So we did hypothesize that If there's good uptake, we would perform the primary closure. If there was poor uptake, we would perform a delayed primary closure with the wound vac application. So for our first patient, 67-year-old male with medical history of diabetes, hypertension, hyperlipidemia, and gastritis, who was status post partial first-degree amputation in November, and he presented back with this chronic wound to the surgical site on the right-hand side is what he presented as on his second admission. And so we did get arterial studies on him. He showed that, he had good perfusion in his leg. His foot perfusion was fairly well, except for the biphasic flow to the dorsalis pedis artery. The patient did have stenotic flow in his digits, but there's no evidence of occlusion noted. And so we did consult vascular, and they did say that, the patient does have adequate flow, so no intervention was indicated at this time. But, you wanted to see, though, at this area of the chronic wound, would this patient be able to heal a revision, or would we need to go, more proximal in the foot? So this is the patient intraoperatively with the SPY. So at 15 seconds, you can see that there's no areas of immediate ischemic regions. And all the way to 90 seconds, there's no areas of necrosis noted. And so if there were areas of necrosis, it would show up as a, necrotic area with poor uptake of the dye, but this is not showing any areas of necrosis. So we decided the patient could benefit from just a revision and a primary closure. And so that's what we did. The patient has been being followed up closely with my attending closely in clinic. The incision is almost completely healed with primary closure, and currently has no post-op complications. And he is currently walking in a custom shoe right now. So I did support our hypothesis of the primary closure for this patient. Our other patient is a 72-year-old female with past medical history of diabetes, hyperlipidemia, and she was admitted for right hallux wet gangrene. And so because her infection was pretty extensive, we had to perform this in 2 stages. First was to get rid of the infection. So we did perform a hallux amputation first to do source control. Oh, I'm sorry. And we also got Dopplers on her vascular studies, very similar to the first patient. This person had very good flow, normal flow in her leg. The same vessel, the dorsalis pedis artery, did show some blunted waveforms. And again, all digits were stenotic in this patient. But again, no occlusions were noted. Vascular was consulted and deemed that no intervention was indicated at this time. So here are the intraop images of the fluorescent angiography. And you can see the dark ischemic area is the area of ischemia. Immediately, we see it at 15 seconds. And at 90 seconds, which is the peak perfusion time, it does show a distinct area of ischemia. So, based off our hypothesis, we decided that this patient probably could not handle a primary closure. So we did resect the areas of ischemia and all necrotic tissue and left the skin defect. That was pretty large, but we put a wound vac on in hopes the patient would granulate over time. So this is her post-op follow-up. The defect does look pretty large, but the skin edges and the granulation tissue is actually all healthy. She has been granulating over time, has not had a recurrence of infection, no necrosis noted, and no complications at this time. So she's doing well. It does look large, but patients with a wound vac can granulate over time. So though we only had 2 patients, this was a case report. You would definitely hope to get more patients over time to create a larger study to support our hypothesis. But based off what we have so far, the addition of the IGCFA for assessment of tissue perfusion in cases of diabetic and vascular wounds can assist with surgical decision making and deciding whether a wound will heal primarily versus delayed primary closure intraoperatively. And it's a safe, quick, and user-friendly procedure with minimal risks, and it's a great resource for podiatric surgeons. These are my sources, and that's it. Yeah. Any questions? Thank you. All right. Okay. Thank you.
That technique diabetic people before they begin to have ulcers to anticipate the risk of having ulceration?
Yeah, so the question was, can you use this for patients with diabetes pre-ulceration? So kind of to indicate if there's already areas of ischemia. We haven't done that yet. I think we could definitely use it on a patient, maybe if we think that they're putting a lot of pressure on an area, or there's areas of high risk for ulceration, like a lot of the bony prominences. So I think, in conjunction with the Doppler studies, I think that could definitely be a good resource to use along with that. Yeah. We haven't done it yet, though, but that's a great idea. All right. Okay. Thank you.
All right, so continuing on the theme of diabetic foot ulcers, me and my co-resident Salem did some research on the topic of looking at trends in diabetes-related major and minor amputation risk during the COVID-19 pandemic. So with negative impacts from the pandemic on the management of wounds through delays in access to care, one would expect to see increased amputation rates, and we wanted to see if this was observed specifically in our community, as well as looking at what literature was saying about some of the other communities. So we'll start off the presentation with a literature review of papers that have explored these trends pre-COVID, during COVID, and post-COVID wave 1. Afterwards, we will go over these trends that can be specifically seen in our local community through analysis of consult data that we have been collecting here at White Memorial. So in this first study, Casiato et al. Performed a retrospective study analyzing a podiatry consults in a level 1 trauma center in central Ohio. And what they found was that the odds of undergoing any level of amputation was 10.8 times higher during the pandemic. Of the patients undergoing any amputation, the odds of receiving a major amputation was 3.1 times higher. And they also found that the severity of infections increased during the pandemic, and a larger proportion of these cases that were coming in were emergent. In this next study, Valabji et al. Performed a retrospective study of all hospital admissions in all of England, and they were looking at amputation rates from January 2017 all the way to October 20. And during COVID, they found that rates of major amputations were actually 7% lower, and minor amputation rates were 21% lower. And they didn't notice any rebound in these amputation rates after the first wave, but they didn't really account past October 20 to see if there was any more delayed rebound. And they kind of just explained the reduction in the major amputations. They attributed it to the age group being greater than 65. So they were thinking it was COVID-related mortality that may have contributed to this drop in amputation rates. The authors hypothesized that the reduction in minor amputation rates may have resulted from lower ulcer incidence due to reduced ambulation in the context of home confinement. Lastly, in this last study, Caruso et al., they performed a retrospective study looking at the clinical features and the amputation risk of individuals with these diabetic foot ulcers being admitted to a tertiary care center during the lockdown compared with a population that was admitted 5 months prior. And during COVID, what they noticed was that the proportion of patients coming in from the outpatient clinic was significantly lower, whereas the proportion of patients being admitted from emergency was significantly higher. They also found a significantly higher prevalence of gangrene during COVID, as well as a higher proportion of patients requiring amputation. And the findings in this community reflect that poor access to outpatient care and delayed presentation to hospitals were contributing to greater amputation rates. So getting into the methodology of how we collected our data here at White. So all consults over the past 3 years were collected via Excel spreadsheet and electronic medical records. We excluded trauma consults in this review in order to focus our data toward our population at actual risk of amputation. So any ankle fractures, we didn't include those. Excluding all that, a total of 849 consults were identified for use in the study. 356 consults were included for 2019, and 493 consults were included for 2021. We also noted any surgical intervention that these patients underwent while admitted, whether it was by us or the vascular team for a major amputation. Of note, the rates of amputations were explored categorically. So for major amputations, we included BKAs and above. Moderate amputations, we included TMAs, Lisfranc amputations, and CHO parts. And for the minor amputations, we included digital and partial rate amps. So this graph here illustrates the number of consults and podiatric surgical interventions and readmissions that occurred here at White by month during the year of 2021. 42% of the 493 consults required surgical intervention from our service. The data on this slide summarizes the amputation rates that we observed during that year. The total amputation rate in relation to consults was about 32.45%, with minor, moderate, and major amputation rates at 19%, 5%, and 9% respectively. And 38 of the 42 patients who received major amputations at White were seen by our service at some point during the admission. Here we have a table of the frequency of each specific amputation type compared in 2019 and 2021. So the total number of amputations in 2019 was 132 as opposed to 160 in 2021, representing a 21% increase in absolute number of amputations. We want to look at how the relative distribution of the types of the amputations changed between the years, and as depicted by this graph comparing the relative frequency of the different amputation types by year, there wasn't much change in the amputation types. So minor amputations, the relative frequency stayed the same. You saw the same amount of moderate and major amputations as well. Notably, there was a 38% increase in the number of consults received following the pandemic, but only a 21% increase in the number of amputations during that time. So that suggests that the relative rate of amputations in our community actually decreased following the pandemic. These are our 2021 and 2019 graphs side by side, comparing the surgical interventions relative to the total consults received. The rate of patients consulted by our service requiring any surgical intervention decreased just slightly, about 2% between that time frame. And for this slide over here, we have our overall amputation rates and how they change between the years. So in 2019, we went from 32.45%, scratch that, from 37% to 32.45% in 2021. So it fell about 5%, the total amputation rate. And similar decreases were seen in the minor, moderate, and major amputation rates, respectively, as well. So overall, our exploration of consult data had a couple of interesting findings. While there was a 30% increase in the number of consults during the time frame, presumably contributed by an increased demand at the hospital as well as rebound in demand for the service, there was only a 21% increase in amp rates, which suggested a decrease in relative amputation rates of about 5%. And taking a look at those distributions of the types of amputations, we saw that there wasn't much difference, which compared to the literature that we saw, which saw a lot of shifts in those rates, it may reflect that disruptions in the outpatient care being community dependent, and they've been more controlled in our community here in Boyle Heights. We tend to see a lot of our consults being sent into the hospital early from our outpatient clinics during weekly checkups to either receive early IV antibiotics or minor amputations. And it may be that this continued close follow-up in an outpatient setting has allowed our amputation rates to improve despite the effects of the pandemic in our community. Now, it's important to note that this is a very simple preliminary analysis of the data, and further formal regression analysis and calculations of incident rate ratios is needed to confirm any statistical significance of these trends. And we're also continuing to collect consult data this year to explore how these trends hold up. These are our references. Any questions, comments? Yeah.
In post-surgical use of wound vac, what parameters are being considered for diabetic management and blood protein losses from wound vac? Have you considered nutritional process / protocol for treatments? Repeat the question.
Yeah, so the question was regarding wound vacs and the nutrition status of some of our patients and how we're deciding if we're going to be taking a look at that. So In terms of wound vacs, we typically use it in cases where the vascular status of the patient is compromised or there's concern for any residual infection. I do think that in terms of nutritional status, that's something that we're not very particular at this hospital. It's not something we're actively tracking or looking at in our patients. I think we could do a better job of that in deciding whether we want to perform a wound vac or even supplement their nutrition in terms of getting these wounds to heal. All right. Thank you.
Good morning, everyone. My name is Priscilla Su. I am the Associate Director for the Pharmacy Residency Program. Today is my privilege to introduce our next speakers from the Pharmacy Department on their quality improvement projects on medication management. The first project would be on VTE prophylaxis, dosing, and anti-tanning monitoring in a special population. This project is done by Dr. Claire Pamin-Tuan. Unfortunately, Dr. Claire is not able to join us today due to conflicting obligations. So this project will be presented by Dr. Tung Nguyen, our pharmacy manager. So welcome, Dr. Tung Nguyen.
Hi. Thank you. My name is Tung. As Priscilla had already introduced, I'm the pharmacy manager. It is a privilege to be here today to present on behalf of Dr. Claire Pamin-Tuan and then Dr. Tao Nguyen, our director of pharmacy. So today we will be discussing on a quality improvement project on VTE prophylaxis dosing as well as anti-10A level monitoring for special patient populations. I'm not really going to dive deep into our table of contents, but essentially introduce what VT prophylaxis as well as agents being used, such as enoxaparin, what anti-10A leveling is like, and we start diving deep into the methodology, the results, the discussions, and clinical impacts, and how it affects our future practices. So VTE is an umbrella term for DVT and PE, also the third leading cause of vascular disease in the United States, also impacting us economically and readmission rates for our hospitals. For this reason, our system as well as market level has gone together and have task force with the goal of no patient harm for VTE due to VTE. So system has created guidelines for both enoxaparin dosing as well as anti-10A level monitoring. So when we look at enoxaparin and anti-10A level monitoring, and we look at as it pertains to this study or project with special patient population, enoxaparin is a low molecular weight heparin, and as it sounds like, it is essentially a shorter strand of an unfractionated heparin, right? So because of its short chain, it is longer acting and it has a more predictability in the body. So the way it works is it inhibits the anticoagulation cascade by binding onto antithrombin and then causing a conformation that accelerates the inhibition of the factor 10A. Right, and that's why we are monitoring anti-10A level and essentially monitoring the activity level of enoxaparin. So the reason why we're taking a look into our special population, which includes our underweight, our morbidly obese, as well as renal failure patients, is because we want to ensure and validate that our system's guidelines doesn't lead to improper dosing strategies and adverse effects such as underdosing that would lead to VT occurrences, as well as overdosing that would lead to bleeding. So by definition, or the inclusion criteria rather, for underweight would be females who are less than 45 kilo, males who are or less than 57 kilo. Patients who are overweight would be considered for patients who weigh greater than 110 with a BMI of 30 regardless of gender, or weigh greater than 150 kilo regardless of BMI or gender. Our patients who are renal failure would be for patients who have creatinine clearance of less than 30 and or on dialysis. So this here is a table of our system guideline. Right? I'm not really going to dive deep into it, but what we really want to note here is what drives our dosing recommendation. And the two criteria we see here is the renal function and weight. So our anti-10A level monitoring from a system standpoint is to monitor 4 hours after the third dose, once weekly after a dose adjustment, and the goal is to be between 0.2 to 0.4. So it makes sense that if your level is less, then you want to increase your dose so that you want to prevent VT reoccurrence. But if your level is high, you want to decrease the dose to prevent bleeding. And usually the recommendation is to increase or decrease by an increment of 10 milligrams. So the study methodology is for this study is to utilize our platform, which is through Vigilance, right? And so Vigilance is actually part of our pharmacist workflow. We use that to create clinical interventions, documentation, as well as capture those patients who meet our exceptions. And in this case, and in this study, we are capturing the inclusion criteria, which would be patients who are on Lovenox for VT prophylaxis, and patients who are in the special patient population group, which would be underweight, overweight, as well as renal, who have renal failure, right? So, renal failure. So we have here a list of rules, and the way it works is our pharmacists are capturing them on a daily basis through a workflow queue. They address them, intervene as necessary, and then our residents are actually capturing them through an ad hoc report, pulls the report straight out from Vigilance, and then deciphers or extrapolates the data onto what would be our discussion today on this project. So as we break down the result, we look at the baseline demographics of, due to a short period of time during March 1st to April 14th of 2022, we were able to capture 39 patients. Of the 39 patients, 62% of those patients were male, 38% of those patients were female. And when we look across the median of for the baseline demographics, we see patients who are about 88 kilos on averaging with normal renal function. But what we really want to capture is the range, right? Because the range is what depicts the group that we're trying to as part of our special patient population. So you can see here the range, patients who are truly underweight and patients who are really overweight, plus or minus whether the patient has normal or renal failure. Of the 39 patients, we were able to determine that 14 patients followed the system guidelines. Of the 24 patients, 62%. Of the 24 patients, we had 58% of those, or 14 patients, who required anti-10A level monitoring. And when we break down even further, looking at anti-10A level monitoring and who required dosing adjustments, we found that in March, 22% of those patients, 6% of those patients actually required anti-10A level monitoring. In April, we found that 8 patients required, or 47%, which is an increase from March. Even though we ran a p-value, we found, and it was not statistically significant, we wanted to essentially demonstrate that there is clinical implications and furthering of this study. We looked further into dosing adjustments. In March, we found that of the 6 patients who required anti-10A level monitoring required a dosing adjustment. In April, we found that from the 8 patients who had anti-10A level monitoring, 1 patient required level adjustments. So earlier we saw from that table, we saw that 4 patients required some type of dosing adjustment. We broke that further because we really wanted to see who our patients were, right? What was the first anti-10A level monitoring? What was the dosing adjustment recommendation? And then what was the outcome? So then we saw out of the 4, 2 patients were morbidly obese, 2 patients were severely underweight. Of the morbidly obese, we anticipated the anti-10A level to be low due to body distribution. So our pharmacist made the recommendation to increase 10 milligrams. A week later, we found that the anti-10A level was then within range. Of the 2 underweight patients, one of the patients was found as expected an increase or over or outside the anti-10A acceptable range, 0.45. So our pharmacist made the recommendation to decrease by 10 milligrams. A week later, found that the anti-10A level was within range. Another underweight patient, also due to renal failure, had an unexpected anti-10A level of 0.15. Again, outside the acceptable range, also unexpected. However, our physician did not accept the recommendation to increase the dose, but later found out a week later that the anti-10A level was within range. So what we see here, if I can get to the next slide, is, again, this is a quality process improvement. We see that there is improvement in post-implementation with the appropriate education and in-service. We saw that with awareness, our pharmacists were able to make an impact and an impact in those special patient population. But with awareness and education that allowed our pharmacists to really be equipped with the necessary tool using our system guideline to take the right approach. However, with this, there are some limitations. One of the limitations was a small sample size due to such a short period of time when we are monitoring this patient. So in conclusion, the clinical impact that was mentioning earlier is that we were able to validate that our system guideline truly can benefit patients who are underweight and overweight, and that our pharmacists can take the necessary means to approach with and tools to approach with these patients when it comes to VTE prophylaxis. Our goal is to get our pharmacists, regardless of whether the patient is in a special patient population or not, is to target at least 80% and to utilize our system's validated tool to ensure that all patients are addressed appropriately as far as VT prophylaxis. But more importantly, of those 80%, we want to ensure that 90% of the time our pharmacists are taking the level when it is necessary. And we want to definitely give a special shout out to Dr. Batista, Michael Jordan, Edith Muradian, and Priscilla Liu for really contributing to this project. Thank you.
Presentations, we're going to switch gear and survey another highly scrutinized and highly focused process improvement in medication management, which is antibiotic stewardship. Dr. Tuan Dang will be presenting on optimization of meropenem use at the community hospital at White Memorial.
Thank you, Priscilla. So on behalf of the group, including myself, Tuan Dang and Thao Nguyen, I'm going to present the optimization meropenem use at a teaching community hospital. Here's the table of contents. I would like to start with the background introduction. So unnecessary excessive use meropenem use linked to global increase of the meropenem resistant Enterobacteriaceae and Clostridium difficile, as well as the multi-drug resistant organisms. So the antimicrobial stewardship program at Adventist White Memorial, we have the SP program. So we have the SP committee chaired by Dr. Byron Williams, and we have the team, SP team. We do the ASP flow, I will present in the later slide, and also the ASP daily rounds with the clinical pharmacist and the IED specialist. So the goals of the ASP program at the White Memorial is to prevent antibiotic overuse and also to prevent and to optimize the drug therapy. The tools we use at the White Memorial ASP policy. And we also, based on the system antibiotic use guidelines, which follows the IDSA guidelines. So besides of these policies and guidelines, we also use the two tools, the applications. One is vigilance, the critical decision support application, and the Cerner. In that, we can use a critical pharmacist work list related to the EMARC. So at the Adventist Healthway Memorial, meropenem use is restricted to indication and to bacterial susceptibility, as well as the infectious disease specialist consultation. However, with the policy and the guidelines leading, but we still have barriers to the SP program at White Memorial. What are they? They are over-prescribing by physicians and underutilizing of the Adventist Health antibiotic use guidelines by pharmacists. So the consequences, the over-increase in meropenem use, increase in number of days of therapy in 2021 versus 2020 and over 2019. That will be explained in this slide. So we see here, this is a band in two rows. That's the days of therapy of meropenem usage from the 1st of January 2019 to the end of 2021. So we see here, that's the band, including here's at the upper line, is a 60 days of therapy or DOT per 1,000 patient days. And lower here we have a 40 DOT per 1,000 patient days. We say in 2019, within the range here. In 2020, it's increasing. This is almost within the range, a little bit lower. But in 2020-21, we see it increasing a lot, especially when I started the project around the October. I see it's that high. So that's why I came up with the idea and discussed with Taiwan, our rapidly to possibly to do this project, the objective. So it's aimed to decrease the suboptimal use of meropenem for hospitalized patients at Adventist Healthway Memorial by strengthening the SP review process using the approved system HP core guidelines. And that will be implemented by the SP team, including the pharmacist, and also with collaboration of myself, the pharmacy resident. And here's the design. So this is a quality improvement project using SP Plan Do Study Act, or abbreviated by PDSA cycle, to test whether improving compliance with the HASP core guidelines optimize the meropenem utilization. I explained a little bit about what we're doing in PDSA plan. Sorry, improve meropenem use by enforcing the SP policy and using decision support application monitor meropenem use, and to encourage implementation compliance with the SP core guidelines study. This is the key part. I would like to compare the patients in October 2020-21 that we see the higher DOT per 1,000 patient days. I compare it to March 2022 patients. And the act is assess if strengthening adherence to the system HP guidelines will improve meropenem use. And this is a procedure, a little bit about the workflow of the pharmacy. So we use the vigilance, that is a decision support application, and also linked to the Cerner by another some way that we can calculate the DOT. That means that the day of therapy per 1,000 patient days. So every day, the vigilance, they have created the auto-generated list for patients on meropenem, and the pharmacist workflow will review the meropenem use, apply the system HP's core guidelines, and discuss with prescribers and document the intervention and what they do during the review. So I explain over here, this is part of the pharmacist workflow, but also from the resident, because I facilitated that process to help enhancing the process. So that's the clinical cases for renal dosing, for timeout, for the escalation, and therapeutic duration. The timeout is 48 to 72 hours after starting the meropenem use, first dose, to see if there is a drug mismatches or the indication is appropriate. And escalation, that means that we can discontinue the medication, we change to another medication that's not restricted. And therapeutic duration is appropriate time of the duration of the antibiotic use. So that is a facilitation. And after this, I will provide therapeutic recommendation to the pharmacist, so the pharmacist can do the workflow and contact with the prescribers. That is the beginning. But until the end of the academic year, so as myself, I was trained early enough so that I can do it by myself too. The population, so inclusion criteria, so that also adult patient admitted to the hospital and was treated on meropenem. Exclusion criteria, so in case of no cultures collected before meropenem administration from outside hospital, to exclude the transfer patients from outside hospital without any cultures, and patient already on meropenem. A one-time meropenem administration, that means that the primary physician recognized that it is not the right appropriate indication and they stop it by themselves. Immunocompromised status, HIV infection, absolute neutrophil count less than 1500 per cubic millimeters. And when, that is when the October 2021, before stranded adherence before the residence facilitation, and compared to March 2022 after strengthening adherence to the SP core guidelines. So the interventions, I will recognize that the intervention into 3 groups. I would like to define a little bit. So the pharmacist flow will be, after the work, comparing the 2 group of patients, we will see if the divided the group into accepted groups, rejected, and continuation. Accepted groups of patients who is a SP team, the recommendation and the physician agree and change the medication, discontinue or de-escalate. Rejected group, that means that the physician rejected the pharmacy recommendation, and continuation group, that means that we keep the same, agree with the original regimen recommended by the physicians. The endpoints, so the final endpoint is to different compare the day of therapy per 1,000 patient days in October 2021 compared to March in 2022 to see if there's improvement. And we also want to determine and compare the results of interventions by the pharmacist recommended to the physician to see among the 3 different groups. And for analysis, I use a MEC-CAL version 20106 to test the normality and to use a t-test or chi-square test where appropriate. And for vigilance, to calculate the DOT per 1,000 days of therapy per 1,000 patient days. And here are the results. So October 2021, we have totally 107 patients, included 30, including 77. And in March, 61 totally, excluded 20, included 41. And this is the reasons I already presented in the exclusion criteria. So this is not the updated one. Sorry about that. I think that I submit the link to the cloud link, so that would be the whole updated with the tables. So far we have the demography, and we have results. We have the different tables presenting the demographic of the 2 groups, 2021, October 2021 and March 2022. We see that the males patient compared to in the two groups almost the same. It's around 30% of the total population. And we also study to look at the different basic guideline, basic characteristics, such as the patient's underlying diseases, cardiovascular diseases, pulmonary diseases, and diabetes mellitus or other diseases. And we see that I do the p-values almost less than not less than 0.05. That means that the two groups between the 2021 October 2021 and March of 2022, they are almost the same, except for one thing, that is if the patient has a respiratory disease, that's a different. And also consider the difference between the isolates of the organisms. So we have the gram-negatives and gram-positive, and I don't see the difference between the two groups of 2001 and 2022. And after that, I do the interventions. I see that interventions, I see the continuation accepted, rejected. So there is the p-value less than 0.05, showing that this is the significance. That means that the interventions of the pharmacist recommended to the physician show the significance difference. So that's the improvement from March compared to October. But when I want to do more, I do it in pairs, continuation, and accept it, and reject it, or accept it, reject it. So we want to see this one, and we see that there is also the between the accepted and rejected, we see the significance. So that what does it mean? That means that that means that the intervention of the pharmacist and myself, the pharmacy resident, to contribute to the ISP program that can improve the use of the meropenem at a white. And here it shows from today's therapy, we see that after we applied enforcing of the system SP guidelines, we will see that the days of therapy is decreasing in February and in March. So we see that comparing from the October is 85.09, and it's go down to 40.58 in March, showing the improvement. So, sorry, this isn't. It's not the right one. So the intervention. So that so far as a discussion, we see that we have contributed to the improvement of the meropenem use at White Memorial, but we still have some limitations. A small sample size. The time study is limited. It's just we just compared the 2 months. October 2021 compared to March of 2022. And also there is some multifactorial that we didn't study, like the severity of the patient cases, or we didn't follow up the patients about the critical outcomes of the patient or rehospitalizations rates. So the future directions is we are going to continue the workflow with the pharmacy resident to facilitate the pharmacist to do the SP rounds and to do the work for to discuss with the ID specialist to make to keep continuing that. And also we in the future for study we will conduct a study about the future with the extended study, like in 6 month or 1 year study, and a larger sample size. So for conclusion, strengthened adherence to the system HP guidelines, which follows the IDS-8 guidelines, has contributed to improvement of meropenem use at White Memorial. Here's the references. And we also would like to acknowledge the Dr. Bautista, Dr. Byron Williams, Dr. Priscilla, Edith Murarian, and Myrna as medical librarians. So thank you all. Yes.
When I look at your graph of the use of meropenem, it seemed to be that it peaked at May of 21 and then started going down. I think the time period that you're studying is kind of skewed population, because that's the peak of COVID when people were afraid to come to hospitals. They are at home. By the time they presented to hospital, they were extremely sick. And that influences what antibiotic a physician would order. A person that comes in shock, where I'm going to throw the kitchen sink at them, is different than a person that comes with an ear infection. So I think that kind of put your data a little bit, and there is some bias in it. And also, even with the explanation of the one-time use of meropenem, a lot of time clinically, speaking for the physician here, the way a patient presents makes a difference. And by the time it takes 24 to 72 hours to get sensitivity and actually ID of the organism. So I may use a big gun antibiotic on presentation because there's an infection, but I don't know what it is. And I would change that as the data become more available. So I really think that the time of the study seemed to be kind of good a little and does not necessarily indicate a long-lasting trend. That's my personal.
Yeah, thank you for your comments. We also recognize that when we did the project, so we also come up with the questions of would it be related to the COVID time in 2020, 2021? That is one of the, thank you for your comments. We also recognize that. We could say that probably because of the COVID, so that the physician have to train to prescribe more meropenem. But when I look, I'm sorry that today I have at the table, but it's not updated here. So I also look at the underlying disease on those patients and so indications. So for example, for indications, we have a different indications like but I just want to focus on the patients for pneumonia indication or use of medication of meropenem because of pneumonia. And I saw that the two groups in October 2021 and March 2022, just one case of COVID patient for each. The other cases are not related to COVID at all. There's another indication. It's proven by the pneumonia with bacterial pneumonia, and that's proven by the by the tracheal cultures or with the blood cultures. So, but I don't see I just see one case for it. But you're right, because I just focused on 1 month of 2021 and 1 month 2022. Does not represent the whole time and the whole population. Yes, sir.
To continue this process to see if there's actually a change in the adverse effects of meropenem on reducing. If you're reducing the use of meropenem, are you affecting, for example, meropenem resistance?
Yeah. Yes. Thank you for your comments. I also have looked at the study one more time. Unfortunately, it does not show here. I look at the resistance, the isolates of the bacteria in the two groups. It was October 21 compared to March 22, and I see that in October 21, there are some isolates of the carbapenem resistance organisms. We have 2 cases of carbapenem resistance. We have a couple of ESBL, carbapenem resistant ESBL. We also have one intrinsic meropenem resistant is a Staphylomonas maltophilia. But in March of 2022, we have no cases of carbapenem resistant organisms. But for sure that in the future, we have to look at that and in the extended time. Thank
This
you.
will be an ongoing.
Yes, sir.
Be able to get a larger timeframe.
Yes, sir. Thank you. Any more questions? Thank you, everybody. Thank you.
I guess now it is time to have our keynote speaker, Dr. Teresa Ku-Borden. She has a big resume. She's quite an impressive person and quite an advocate for women everywhere. She graduated magna cum laude with a BA from biological science from USC, and between medical school and undergrad, she did urban ministry internships. Then she went to USC Medical School, after which she went to residency to Ventura Family Medicine, and then Greenwald Fellowship in High-Risk Obstetrics. She is accomplished in many areas beside medicine. She has a publication on Voices Rising, Women of Color Finding and Restoring Hope in the City. She has several posters and presentations. She has several awards, including USC Renaissance Scholar, Walker Scholarship recipient, Sanford Bloom Excellence in Family Medicine. I'm not sure I'm doing her justice in all this, but she joined our family here at White in 2015, and she has been quite a leader to our residents. She is an associate program director for the residency program, and she has been a big person in what they call integral and diversity, equity, inclusion into the family medicine curriculum. She hosted many community events, including QA sessions for COVID vaccines with the community. So in other words, if you haven't gotten this yet, she is a big advocate for women everywhere. And I don't know where she is. It's a great pleasure to know you, and please. And for the record, I was more nervous introducing her than she is.
Thank you, Dr. Idris, for the introduction. It is an honor for me to be here today. Thank you to the research committee for putting on this wonderful program and for inviting me to share a few words. And thank you most of all to the scholars in the room who submitted your projects. Your hard work is apparent, but more importantly, I see the passion behind your work, your desire to improve patient care, and the system of care our patients must navigate. If you told me I'd be giving a research talk even a few years ago, I would have never have believed you. 7 years ago, I was fresh out of fellowship, and I was also having my first baby. I was ready to be the full spectrum family doc I was trained to be, on the ground, seeing patients in clinic, rounding in the hospital, delivering babies. And then I became a mom. Being a mother consumed me for a while, not only because of that normal transition of becoming a parent, but my son was also born with biliary atresia, a congenital and progressive liver condition, a disease that most of us have only heard about in medical school. Because I couldn't control anything related to my son's condition, I couldn't control the multiple results of the nuclear scans. the blood tests, the huge surgery he had at 5 weeks of age, washing and hoping that his stool would have some pigment to it. I couldn't control any of that. So I poured myself into giving my son the best nutrition that I could, breast milk. I learned everything that I could about breastfeeding. I joined social media groups. I worked with lactation consultants for hours. I worked through pain and cracked nipples, oversupply and scheduled pumping when he was NPO and in surgery. Breastfeeding and biliary atresia are pillars of motherhood for me, and I bring these experiences into the care of my patients, into the care of new mothers worried about their baby's yellow skin, scared that their baby won't eat, or they won't produce enough milk for them. So when I went back to work as a physician mother, I wanted all my new mothers to breastfeed, and I wanted all the babies to get that liquid gold. I quoted research studies of lowering the risk of breast cancer, of childhood obesity, of diabetes in the mother and the child. But when my patients said that they couldn't breastfeed, or they didn't want to, or they didn't have the help or support, or it was easier to get formula, I became frustrated. Not at them per se, but hearing their stories, we learned that the problem was bigger than them just not wanting to breastfeed and not accessing the support that was available to them. There was a problem in the system of care in our communities. I learned about a time when the government agency WIC was handing formula out like water, and a whole generation of mothers and grandmothers stopped breastfeeding. And these mothers and grandmothers are mothers and grandmothers of my patients. Through our patients of African ancestry, I learned that enslaved women, after having their own children, had to nurse their white masters' babies, leaving their own babies to starve to death. This historical context, the generational trauma, the priorities of local and federal government agencies, the system of care of how most providers aren't formally trained in breastfeeding medicine, and how lactation consultants aren't covered by insurance or Medi-Cal, and how these communities of color are portrayed by the media, all of these factors played into the barriers of breastfeeding. The problem was bigger than just the patient not wanting to breastfeed. Becoming a physician mother in this community gave me a window through which I learned more deeply and more personally about the barriers to healthcare, social determinants of health, and healthcare disparities. Every mother wants to give their child the best nutrition, no matter where they live or how much money they have. And it is this lived experience that motivates me to continue working with our breastfeeding improvement project to address the systemic barriers and improve the breastfeeding rates in our community. And I love that there was a project on that this year. So this is my story. That's my son having his first taste of breast milk after his Kasai surgery. And then last year, during Black History Month, we had our first exclusive breastfeeding collaboration. So these are my goals and objectives for this talk. So I want to identify barriers to research in a community setting and during residency. Encourage a new framework for scholarly activity, specifically for diversity, equity, and inclusion and health disparities. I want to help us find our passion and joy in medicine and allow our lived experiences inform and drive our scholarly activity. I want to help us understand that scholarly activity is a way to drive meaningful change in the work of DEI. And finally, offer tools and practical steps in corporate research that are enriched by DEI practices into our daily professional lives. And I want to say that this is simply my story, my own journey of learning to embrace scholarly activity. And it's not going to have all the answers. It's not a formula for success. It's just one way to incorporate scholarly activity into our busy lives. So before I go into the barriers, I want to offer a word about our posture towards our community. We are in a rich community, rich in culture and knowledge of strength, courage, and resilience. We are in a resourceful and creative community that is able to thrive in spite of the disparities and discrimination that I talked about earlier. We have a lot to learn about our community, and we must learn about the patients we treat. If we are not from this community, then we are guests. And if you are from this community, we want to listen and learn from you. If we come in with a prescriptive idea about how to best treat the patient, we are setting ourselves for failure. But if we come in with an open mind and a humble posture, we allow ourselves to be changed and transformed, and this allows us to offer better care to the patient. The first barrier is our own bias, our own misconceptions and prejudices about this community. We are all healthcare professionals, and we've been trained and taught to see patients in a certain way. Medical training has historically placed so much responsibility on the individual. We are taught to believe that the onus is on the patient to address their condition. We're taught to say, you need to take your medicine. You need to change your lifestyle. We're taught to recognize patterns, schemas, case scenarios. How many of us have been asked the question, 40, female, and another F word I won't use, comes in with abdominal pain. What is she most likely to have? Many of us haven't been taught to ask, but where does her food come from? And why does she work 2 jobs? And the only time she can eat is at the fast food restaurant by her house when she gets off of her first job and is on her way to her second. We're taught to recognize patterns, keywords, key characteristics that might point to a diagnosis, but pattern recognition is just stereotyping if we don't ask why, if we don't listen to the whole story. Pattern recognition can get us into trouble sometimes. And for the sake of being efficient, we only see a constellation of symptoms or of ailments in front of us and not a human being. Pattern recognition is just stereotyping if we don't ask why. Before we make conclusions about our patients, let's ask questions first. Let's listen to their answers. Scholarly activity that is humanistic and compassionate comes out of asking why. Another huge barrier is time and energy. Our practices are busy. Residency is busy. Most of us are not compensated for doing research. And do we even have time to ask why? Maybe we know the answer to that question of why that female patient has to work 2 jobs. It's because she's not documented. And maybe we don't want to know the answer because it's a window into a bigger, more unsolvable problem. We barely have time to explain what gallstones are, what caused them, what's the treatment, answer their questions, let alone address the problem of finances and food insecurity and her fear of accessing government support. We don't have time for patients. How do we have time for research? For many of us, our energy is spent helping our patients navigate a complex healthcare system. And if you work here at White Memorial, I know that you're not here because it's just a job. I know you're here for more than that. You care deeply about your patients. The tragedies and trauma that many of them have endured affect you, and especially after the COVID pandemic, we don't have the emotional capacity to do much else. The next 2 barriers are common and understandable. We're not paid researchers, and research was just part of our formal training. Publishing and presenting posters can be intimidating and takes a lot of work. And we have people telling us, you have to see more patients. You have to do more procedures. And if you're like me, I went into medicine to take care of patients, not analyze data. And lastly, this list is not exhaustive, but our framework of research, the way we view how research fits into our professional practices, is a barrier. We compartmentalize different parts of our job. We take care of urgent patient care needs, which is really important. And in the back of our minds is that little voice telling us to do research. And if you're faculty like me, we're required to report our scholarly activity every year, and programs get cited for not doing enough research. Maybe you've given a little thought in between running between seeing your patients and you feel frustrated about access to, to a treatment. And you say to yourself, this would be a great project if I had time. For many of us, research is always on our to-do list, but somehow we never get to it. I was stuck in this rut too. For years, it was always on the back burner for me. What helped me move forward was changing my framework, how research fits into my practice. We need to start by asking different questions. Not what projects can I be a part of, or what projects interest me, which you can do that. But if there isn't a project that interests you, we have to start by looking inside of ourselves and ask ourselves, what do I want to learn? What brings you joy in practicing medicine, in pharmacy, in podiatry, in nursing?
and your specialty? What are you curious about? Do you have moments in your daily life where you're seeing patients and there's a spark or stirring that bothers you, that excites you, that exasperates you? What is your lived experience? And by lived experience, I mean, what is your story? How have you learned to navigate the environment uniquely as you, with all of the experiences you've had? How might you want to improve the path for others wanting to go into your field? Is it partnering with a local organization, working with students, and offering your expertise and influencing the next generation? Those of you who I've gotten to know in my years here have amazing stories. I see your passion projects. I hear in your voices when you present at meetings, making a difference in our community. There are rich projects right here waiting to be presented at conferences and published in journals. And some of us don't need to look for content. The content is inside of you. What do you want to become an expert in? What are you already an expert in because it is your lived experience? Is it physician wellness and mental health? Is it sharing the experience of being a woman or person of color in medicine and noting what kind of microaggressions we experience? Is it an education and training? Is it implementing an effective and innovative curriculum in diversity, equity, and inclusion, social determinants of health, or another area? Is it improving communication between faculty and learners and giving feedback? Is it inpatient care? Is it learning about shared decision making and how that might improve patient and provider satisfaction, even when it might take more time? Is it improving access to mental health in our community? Is it ensuring access to follow-up appointments after hospital discharge? Or is it an area that is hidden and often unnoticed? Is it looking at healthcare provider perception on disability and noting what kinds of hidden disabilities affect our patients, our learners, and our colleagues? Is it adding pronouns to the demographics in your EHR and seeing if your patients feel more safe and included? By looking inside of ourselves, we find that inner drive, that inner motivation, that inner fire. And when we start asking that question, we start kindling that spark. Looking inside is the first step, and it sometimes might be the hardest step to take and take the most courage. Because some of these questions have answers we might not like. Some of these answers may make people uncomfortable and upset. The answers may lead to changing policies. Change takes work, it's not easy. So after I took my first step of changing my framework, I knew I couldn't do this alone. I needed a team. I needed to set some goals. I needed to ask for help. And I needed to stay on task. Here's a deeper look into some of the next steps I took. So first, you want to gather your team because we can't do this alone. Who are the people around you who have the same passions as you, who are asking similar questions? Who are your colleagues that share the same frustrations or that you vent to with your frustrations? Find people with the same joy, the same passion, those who can help make your spark a little brighter and kindle it. I want to share a few stories about teams that I've been a part of. This first project was not my own project. It was a project that I worked on with a team. And doing this together showed me that a group of motivated people with the same passions can make a project take off and succeed. I was invited to participate in a project on educating physicians about trauma-informed care in our unhoused OB patients. And this was with a group of OB and family medicine residents, some of which presented today, Dr. Yang, Dr. Simcoe, and Dr. Cortez. There was a need to provide education about trauma-informed care to healthcare providers. And so in 5 weeks, we came up with an educational intervention, gave 2 presentations, one to OB residents and one to family medicine residents, conducted a pre and post survey, analyzed the data, and submitted an abstract to a national meeting and was accepted. Super impressive. And this was a resident-driven project during a very busy schedule, busy time. Sometimes the sparks of others can kindle your own spark. It can help you overcome that threshold and activation energy of doing scholarly activity. I knew that I loved taking care of OB patients, and I believed in the trauma-aware and trauma-responsive models of care. And this project solidified my passion for both of these. And this process also showed me that if I had an idea and could gather the right people, maybe I could also submit something. And this is why I love working with residents, because many times they are the spark that keeps us going and encourages us to try new things. So next year, I was working with our family medicine residents in our DEI committee, and we were talking about how to incorporate DEI topics and education about healthcare disparities into our curriculum. We asked the question, what if every family medicine lecture had a slide on health disparities and DEI topics? How could we make that happen? This began our DEI and didactics project, and asked a few people to help, including Myrna, our wonderful librarian, and Dr. Maria Hayes Bautista, as well as a few residents and faculty, Dr. Haugen, Dr. Lodi, Dr. Park, and Dr. Lopez. My team came together to send articles to lecturers. Every lecturer was sent an article, or we tried. And we created a virtual DEI library of many different topics, where if you click on a folder, you'll find articles on health disparities in all of these specialties. Here's a little closer look to some of our topics. Our goal is to ensure that over 70% of all family medicine lectures will incorporate these articles so that residents aren't just learning about health disparities in 1 or 2 lectures in a year, that they're learning about it throughout their 3 years here. Lastly, as you're thinking about who to include, consider forming a team of diverse perspectives. If you're looking at an intervention to patient care, would you consider inviting a patient to help you design your intervention? In answering your question, whose voice is not represented that could help you find your answer? Who are those you trust that can challenge you and give you constructive feedback? So I gathered our team, we split up our tasks, and we needed to set some goals. And we set the goal of that 70%, but we also set the goal of submitting an abstract to a conference. We talked about our own personal goals and shared new ideas with each other. We set monthly meetings so we could stay on task. What is your goal? What question do you want to answer? And who needs to hear your answers? You might have to set some smaller goals, such as finish writing this section on this proposal, or talk to someone with more expertise and experience to get ideas. Do a literature background search on your topic. I ran cross country in high school, and I remember during a summer practice when we were all trying to get back into shape, and I was trying to run up this really long gradual hill. My coach ran up next to me and just told me that as I was gasping for air, she said, you need to set small goals. Like you need to set a landmark like this light post, and when you get there, set the next one like this tree. And so that's kind of how I've seen my research journey as well. There's a big picture, but then there's some small goals to achieve. Maybe your goal has to do with more funding toward an initiative or an area of patient care. Could you publish or present your data on it so you can make your case? Is there a conference you want to present at? Look at their deadlines and start planning ahead with your team. Start early and set small goals. Schedule regular meetings with your team so you can stay accountable to your tasks. The next step is to ask for help. I've hit many roadblocks. Times when I have to focus on other more urgent issues, where I've had to slow down, when I get stuck, when I lose sight of the big picture. Remember, I didn't go to medical school to conduct research or analyze data and publish papers, and that's definitely not my area of expertise. And I can't expect myself to learn this on top of everything else. I have to acknowledge my limitations and ask for help. And there are individuals here who can help you, whose knowledge and training are in research, collecting and analyzing data. And this is where your team can come in too, because sometimes it's just helpful to share that you're stuck and that you need some help. You need some help with next steps. I want to take a moment to recognize the hard work of Michael Jordan, our former director of research here at White Memorial. This day could not have happened without his dedication and passion. And I know there are folks in this room, teams who have presented today, myself included, who have been encouraged and helped, whom he has encouraged and helped us with next steps. There are projects today that would not exist without his presence, his expertise, and encouragement. And I will definitely miss his passion for research and promoting cultural humility at our institution. And there are others as well. We have a research and publications committee led by Dr. Idris and Dr. Patel. We have Dr. Maria Hayes Bautista and Myrna Huenko Harus, our medical librarian. And from personal experience, when I felt lost in my project and my spark is getting dim, Dr. Hayes Bautista will send me an email and it'll kind of give me that spark to keep going. And when I ask Myrna for articles for a literature review, she'll send me articles at a request and then more articles on that topic. It's just like someone's thinking of you, someone's thinking about you, and when you hear from them, it's like some more energy to keep going. So I encourage you to find your support and ask them for help, those with expertise and those who can help you keep going when you're running out of steam. Try to keep yourself accountable. We can help each other reach our goals. Set your internal deadlines, talk to someone when you're stuck. And also remember that it's okay to take a break. Maybe even schedule a break, a week off from thinking about your project. Think of yourself as an artist painting a large painting. You take time to plan it out, buy your materials, and then you start sketching and you start painting. And then you let it dry and maybe you paint some more. Maybe there's an area where you feel like you need to fix, so you let it dry and then come back to it. And maybe sometimes you just need to step back and look at it and remind yourself of the big picture and come back to it later. Breaks are important too. I also want to take some time to acknowledge the hard work of our residents, nurses, pharmacists, attendings, and everyone else whose projects are being presented today. Thank you for taking the time to ask your question, design your project, work on a team to find the answer, and summarize your findings for us. Many of you are residents, and completing such a task in the midst of caring for patients during pandemics and surges, meeting clinical and procedural requirements almost seems impossible. So I want to congratulate you on a job well done. We asked all of our presenters to submit an answer to the question, how does your project promote diversity, equity, and inclusion, and/or address health and healthcare disparities? Because if we're going to commit to a meaningful and sustainable and integrated change, I believe that all projects done here needs to be viewed from an equity lens. DI work and practices are not a box to be checked off, nor should we rely solely on a committee or a department to do the work. We are all responsible to embrace diversity, equity, and inclusion, and to promote it. And today is the beginning of doing that work. So I read through all your statements and abstracts, and I hope the audience takes the time to think about how these projects work towards a goal of caring for our community in an equitable way. And this is really amazing work. There are projects on patient beliefs and perceptions and how knowing these may help improve the care we provide them. We heard from Dr. Yang today already about addressing implicit bias and patient perceptions in patient perception of nonverbal expressions from providers. Another project by Nicholas Garcia addresses health beliefs in Hispanic men and their willingness to participate in health promotion programs. Dr. Valencia and Dr. Zapata's project is on patient perception of advanced directives and destigmatizing goals of care discussions. There are also projects on patient engagement and health literacy, such as Dr. Tang's breastfeeding project, Dr. Lee and Dr. Koh's project on medicine reconciliation and an interdisciplinary approach, so patients know what medications they're being discharged on. Dr. Ahmed's and Dr. Hernandez's project on increasing awareness of contraception care, Dr. Sanchez's project on an educational tool in controlling diabetes, and Dr. Wilkerson's project asked patients living in skilled nursing facilities the question, what gives you strength? There are projects addressing healthcare disparities. Dr. Arias and Dr. Hiramura looked into the patients who leave against medical advice, identifying patterns in patient characteristics in order to decrease these types of discharges. Dr. Sanchez and Dr. Nguyen looked at colon cancer screening disparities, identifying systemic factors that delay patients in getting their colonoscopies. Dr. Itamura's team fought to get custom glenoid implants for the patients in our community, and research has shown that patients in community like ours rarely receive this standard of care. And finally, there are projects that address the wellness and cultural humility of the healthcare professionals in our community. Ginny Nguyen and Heidi Ziegler's project highlights how organizational and institutional culture and authentic leadership contributes to workplace well-being. And Dr. Nwachukwu's project discusses the training of resident physicians in cultural humility. Even the case reports, by highlighting a patient's story with their consent, we can bring education and awareness to healthcare providers, and it may also change the way a condition is taught during training. When we have a human face and a story to learn from, we can begin to understand more fully how a condition affects the patient. Maybe some of these projects have sparked your interest. Designing your project with an equity lens can keep you on this path of learning about our community, about those who care for our community, and ultimately improve the care overall. The tools I've offered you are the same principles that I've learned in my own journey in DEI work. Scholarly activity should reflect DEI principles, and in turn, DEI work should be included in scholarly activity. Addressing health and healthcare disparities is scholarly work. These are the same principles that I just shared earlier. Include diverse perspectives on your team, folks who will challenge you, get you to think. Think about the voices that are not in the room or at the table. Surround yourself with support because this journey is hard with unexpected roadblocks. If you don't know, ask for help and be open to correction. You don't have to be the expert in everything, and you shouldn't. We are lifelong learners and we need to be humble about what we don't know. Keep yourself accountable. We need to stay on this path of learning, of discomfort, of opening ourselves up to new ideas, new ways of thinking, and to change. I want to close by saying that your story is important. Your voice is important. Your lived experience is valuable to the larger community of medicine and of medical education. You are doing meaningful, beautiful, and purposeful work. I am still on a journey and by no means an expert in scholarly activity. And I used to think research was something that I could never attain and wasn't interested in. But as I moved through my career, I realized I have questions every day. I love my job, but there are some things that make me frustrated too. And I want to be able to change things for the better. If our research and our questions come from who we are and our own experiences, it may feel less like another thing we have to do. It may feel more meaningful, more attainable, and more authentic. As we continue on this journey of lifelong learning, we will become experts at something. So let's be intentional about it. I hope that today I was able to encourage you to share your story and your patient's stories through scholarship, and that this can be another impactful way toward meaningful change in the work of diversity, equity, and inclusion. May we go even further to ask the hard questions, the questions with answers that might make us uncomfortable, the questions we might be too scared to ask, the questions that might lead us to do more projects and more work. Let's have the courage to ask why, even when we don't like the answers. Let's sit in the discomfort with each other. Let's become the experts in asking why. And together, let's hope that the answers will lead us toward meaningful change. Thank you.
Okay. I'm Dr. Barrio. I'm the internal medicine program director. Thank you, Dr. Ku-Borden, for that wonderful speech presentation. It is my pleasure to present the next few, the internal medicine projects. Two are in collaboration with pharmacy as part of our multidisciplinary efforts. The first one, which is going to be by Danny Lee and Dr. Eric Hillian, is a project that is near and dear to me, given that inaccurate medication reconciliation is responsible for many patient safety errors throughout the nation. Is something that we have taken head on here at White. And I'm proud to say that we are leading the charge here to make sure that we get the patient's medications correct on every admission every single time. So I look forward to this presentation. It's something that we've been doing as part of our own residency QI meeting every single month, and presenting the ongoing results of this project. The next one is, unfortunately, it could not be presented, but it involved looking at hyperglycemia and looking at management of hyperglycemia with three different groups: endocrinologists, pharmacists, and primary care, and comparing the management by those three groups and looking at outcomes. I won't spoil their results, but the poster is right as you come in. You guys all walk by it, so take a look at the poster. It's a wonderful study, and it's looking at the control of hyperglycemia during the Delta variant surge, which we all remember too well. And then the next three projects are by internal medicine physicians. The first one is by Dr. Kajani and Dr. Bowie, looking at bilateral lithotripsy prior to TAVR. The next one is by Argan Haratunian and Pardis Afshar, which is a project that I'm very excited about. It's a finding of an incidental lung nodule that was missed on X-ray, but was found on point-of-care ultrasound, which is one of the initiatives that we want to bring into our own residency. And then the last one is by Rafik Mugnetsian and Rahil Kajani, looking at this disseminated candida parapsilosis in an ICU patient. So wide variety of topics, and I look forward to all the presentations. Thank you.
Thank you, Dr. Barrio. My name is Danny, one of the pharmacy practice residents, and this is Dr. Kellyan. Oh, sorry. And we'll be presenting on medication reconciliation quality improvement project here at White Memorial. Just want to give a special acknowledgement to our contributors also on this project, Dr. Kim Ko, Dr. Jennifer Oster, and of course, Dr. Priscilla Zhu and Dr. Maria Hayes Bautista, who made this interdisciplinary project possible. Just some disclosures, none to disclose, no conflict of interest, no sponsorships. Here's our table of contents briefly. Just going to be going through these main points. So just some background, as we all know, medication reconciliation, or MedRec, is recognized as a very powerful and necessary tool to prevent med discrepancies and also to prevent patient harm during their transition points. And there's a lot of literature and studies showing that a lot of the med errors are occurring and attributed to inaccurate and incomplete medication reconciliations that even began from the prior to arrival med list for the patients. And there is also plenty of research that shows that pharmacy-led derivatives and pharmacy-led MedRec interventions reduce medication discrepancies.
So what is the significance of medication reconciliation? First and foremost, it's a huge healthcare cost. Discrepancies do cause longer hospital stay and do cause frequent readmissions. Some areas where it is important is at transition points. Let's say from admission standpoint, home medications to admission medications is a point of time where it is often missed. A transition from unit to unit, transition from floor to ICU, from ICU back to floor, and then discharge to SNP. Some transition points are where medication reconciliation is often missed. What is important? Important is communication. A lot of patients come in with language barriers, let's say, or don't come in with their medication list, and there's some reasons that will go in further details as communication stands, why medication reconciliation is missed. What are some steps to reconciliation? First and foremost, it's gathering the accurate list of medication, which includes talking to families, talking to the patient, gathering the list from the database, medication database, and coming up with the most accurate list that the patient's actually taking. Then you go to transitioning to what the patient should be in the hospital, because some medications shouldn't be taken while they're in the hospital. Then goes steps to unit transition. There's some medications that should be taken only in ICU and should be dropped when they're transitioned to the floors. And the other last step is prior to discharge. Some medications should be taken only in the hospital and shouldn't be taken when they're at home. So the other step would be coming up with the correct list of medication that the patient should go home on and communicating that with them so they're clear and understanding what they should go home on. Timing is another factor here, because sometimes it takes time to get the appropriate list. Sometimes it takes time to get it started, and the sooner it's done, the more accurate it will be. So upon admission is when we aim to get all the reconciliation done. Challenges to medication reconciliation. So one of the challenges could be time limitation. There are a lot of hospitals that have designated person who does medication recording in the ED, which we do not actually have. So at this point, we have the clinician who has to do all the work as well as all the medical work of treating the patient. So timing can be off limitation. Sometimes patients are unsure of their medication list. So how do we get the accurate list? Sometimes families have to provide the list. Occasionally we have to look at the database and try to come up with it. Occasionally we have to call pharmacy to see what was the last list that was given. And then occasionally it could be a challenge when they come nighttime, for example, or weekends, because nighttime the families are not available. Weekends, pharmacies might not be open to get the list. So timing could be a challenge. Some patients who have multiple hospital visits, that could be an issue because medications keep on getting changed and patients get confused. What should they be on now? Did anything change? And not understanding fully the details of what they should be taking at that point.
So like from here, we wanted to really explore the different workflows of both our departments, the internal medicine team and the pharmacy team. Starting from the pharmacy, basically our involvement and participation in MedRec here at White, we have our decentralized pharmacist who is responsible for obtaining accurate medication histories, as well as they do internally refer any complex patients with polypharmacies or some difficulties to our transitions of care pharmacists or TOC pharmacists. Also internally, we do any ICUs, any transition points like ICU step downs, like discontinuing drips, IV to PO as appropriate, restarting their home meds if appropriate as well. And also more formally at our SNF and rehab units, we do our N2 medication review processes.
So risks for hospital readmission, because that's something we truly want to avoid, right? Readmission because of medication discrepancies, a big problem. So health literacy is an important point. A lot of patients don't have that, so it takes long time to explain the details. For example, they don't understand why they have to be on a blood thinner because they just got diagnosed with, let's say, a thrombus. So health literacy and teaching your patients is very, very important to avoid a hospital readmission due to medication discrepancies. Sometimes polypharmacy. When there is too much to take, patients could skip medications or take too much. So that's another risk factor for hospital readmission. Prior hospitalization is itself a risk factor for readmission. There's some medications that are known to be problem medications because they could cause, for example, lightheadedness, and that could be a reason for fall and readmission. So that's another thing to be careful for prior to discharge to avoid readmission. And some diagnoses itself are risk factors for readmission because they could be something that predicts that it could worsen and cause readmission. Pharmacy care. So
yeah, essentially, ideally, we want to capture all patients that come through, but more importantly, we want to capture the high-risk readmission patients. And how we do that is pretty complex. The system has a very complex algorithm. As you can see, over 700 factors that are analyzed, ranging from demographics, patient's history, medical history, medications, etc. But this pictorial is really just here to show you that how our system stratifies high-risk readmission patients.
Medication reconciliation discrepancy. So what are some discrepancies? Let's go into further details. So some medications could be there with no indication. For example, patient no longer needs it and they're still taking it because they don't know any better. So that's one way there could be medication discrepancy. There could be an untreated condition. We diagnosed DVT and they're not on an anticoagulation. So that's another discrepancy. There can be incorrect therapeutic interchange. There could be ICU-specific indication that shouldn't be on a floor. There can be inappropriate dosage, frequency, time, route of administration. Any of this could be an issue. Inappropriate duration of therapy. Some people should be on only 3 months of therapy, but they do not stop and continue it forever. So that's another discrepancy. Therapeutic duplication often happens because, let's say in the hospital setting, there is a different medication they use that's equal and patients go home on it and they keep taking their old medication as well. So there's one example of duplication. There could be drug-to-drug interaction that we often ignore. There could be drug monitoring and other things that altogether combine to cause medication discrepancies.
And just to add on to that as well, discussed in the future slides, from what we've seen, the most common ones were probably the inappropriate dose, incorrect dose, and then frequency, and probably it's not probably untreated condition because there was a lot of missing meds, undocumented medications that patients on but not documented. So yeah, we'll go into those in a little bit. So essentially what we wanted to do from here was to identify any med discrepancies during MedRec steps and to assess if pharmacy interventions leads to fewer discrepancies. And how we did that was we used our pharmacy vigilance monitoring tool to retrospectively chart review specifically these high-risk readmission patients. And then additionally, we're going to be trying to do MedRec analyses at admission and discharge, and to also assess the pharmacist intervention during the med history reconciliation steps as well. And we kind of did that by comparing what's documented and reconciled already on the patient profile and comparing it to what the patients actually picked up from the external pharmacies and the external histories. And then ultimately compare that to the number of discrepancies with versus without pharmacist intervention. And these next two phases of results, phase 1 and 2, we really want to explore any holes or lacking steps in our current medication reconciliation steps. So the first phase, we kind of explored the ICU unit, predominantly because our internal medicine team services that unit, and we identified 37 patients using the filter that I just described with high-risk readmission, etc. And unfortunately, 26 of those patients were deceased, so we kind of had a difficult time analyzing the discharge reconciliation. But more importantly, we found that there was 2 cases where pharmacists did intervene, specifically the med history reconciliation part around the time of patient's admission, and they were able to document additional home maintenance meds that were missed by the initial nurse or the physician. And these include stuff like statins, insulins, hugely important maintenance medications, calcium channel blockers, chronic pain medications. So from here, we were like, okay, we're maybe onto something, kind of hone in on somewhere we can go into. So we're going to, so some of the limitations we found within these patients were the large portion of deceased patients, and as well as the high acuity level of these patients made it very difficult to obtain medication histories accurately. So the phase 2, against exploratory phase, identifying problems, holes in our processes. We just did the same thing, but explored the 2 med-surg unit. And similarly, we found that same thing. We found a lot of maintenance meds missing. We found that some of the meds were incorrect, like there was a valsartan hydrochlorothiazide combo that the patient's on, but it's actually just documented as the HCTZ. So now we've identified, like, hey, look, maybe let's focus into the med history reconciliation steps and move on to what we can do from there. And so we really wanted to revisit the med-history steps from the pharmacy side, as well as assign process owners from both departments, internal medicine and pharmacy. One thing we noticed was the pharmacy communication orders and the consult orders are heavily underutilized. And actually, when I spoke to some of the medicine residents, they did not even know those were an option for them to utilize to communicate with us. So again, identifying process owners, utilizing consults and referrals. So that's exactly what we did. Dr. Ko, in the month of March, Dr. Ko would send me referrals for any patients she thought like, hey, we need some pharmacy eyes on this med history rec. And also she was a process owner of that. And then I was a transitions of care resident for the ICU for the month of March. And so we did the same result, filtering things for the month of March, but we found that way higher number of accuracy. So there was, out of 15 patients reviewed in the ICU, 7 of them were high risk. And then out of those 7 patients, 5 had totally complete and accurate medication histories. 2 of them were nothing was documented. And I kind of looked into it. It was a weekend where it was the patient's ICU course where I was not there on the ICU floor. Additionally, I was able to do med history rec for 15 additional patients. And I found that 14 of the 15 patients there were discrepancies that I lifetime reconciled during the patient's admission. So clearly there is some improvement with some process owners and the steps that I described.
So discussion for future direction. What should be done? So now understanding the importance of medication reconciliation, who should be documenting initial medication list? And that's a question. Could it be a pharmacist? Should it be a pharmacy technician? Should it be a clinician? And each hospital has their own way of doing it, but there should be a leading person assigned to document it. And there should be an interdisciplinary team approach. Like the tool was described to utilize pharmacy to document it appropriately should be highly used, and it's something that should be more available to all of us, and physicians should be aware that this exists. And altogether, cost of medication errors, that should be definitely taken into account, because medication discrepancies, as we said, is a huge hospital cost, and we should take into account and try to limit discrepancies.
And just to close it out here, just as it relates to our patient population specifically, really highlights the importance of accurate MedRec as our patient population, experiences prominent health gaps and health disparities. So we're continuing our collaboration with the internal medicine team, figuring out ways to do it. I think process owners of the residents from both units, as well as utilizing the communication orders and the referrals. Thank you. Clicker.
Hello, everyone. Thank you guys so much for coming, and thank you to everyone who's tuning in virtually. My name is Rahil Kajani. I'm one of the third-year internal medicine residents. Today, I'm here with Dr. Brian Bowie. He's one of our first-year internal medicine residents, and we're going to be discussing a case that we did with Dr. Kirmijian. It's a bilateral lithotripsy prior to transcatheter aortic valve replacement, also known as TAVR. So here's a quick overview of our presentation. So we'll just touch up based on what exactly TAVRs are, talk about them, then go into our case, followed by our discussion, and then we can open it up to questions if there are any. So just as an introduction, what is a TAVR? So as you can see on the slide over here, TAVR stands for transcatheter aortic valve replacement. It's also known as TAVI, transcatheter aortic valve implantation, and it's a minimally invasive technique that's used to treat aortic stenosis. Prior to TAVRs being implemented and studied, SAVRs or surgical aortic valve replacements was the gold standard. However, over time, we've been able to learn about the benefits of the TAVR compared to the SAVR. In fact, a 2016 meta-analysis study compared the TAVR to the SAVR and found that the TAVRs had associated with a significant survival benefit throughout the 2 years of follow-up, as well as a 13% relative risk reduction irrespective of the TAVI device. Now, when it comes to who qualifies for this type of procedure, again, we're talking about patients who have severe high gradient aortic stenosis, and they tend to fall into two different categories, one being symptomatic patients and the second being asymptomatic patients. Symptomatic patients usually have things like dyspnea on exertion, difficulty completing their activities of daily living, sometimes will have chest pain. Those patients can proceed with the procedure right away. However, with asymptomatic patients, they have to meet certain diagnostic criteria, including an ejection fraction less than 50%, having a decreased exercise tolerance or fall in systemic blood pressure, and they must also have that high gradient velocity, jet velocity through the aortic valve of greater than 0.3 meters per second per year. And so now we'll talk about the contraindications with Dr. Bowie.
All right, so for contraindications, it's usually separated into two different categories, absolute versus relative. And absolute means that if they meet any of these criteria, means that they cannot undergo the TAVR procedure, while relative means that if they do meet any of their criteria, then they have to go through further evaluation to see whether or not they qualify for a TAVR procedure. And so some absolute contraindications are if the patient's life expectancy is less than 12 months due to any non-cardiac comorbidities, then they're likely not going to be a candidate for a TAVR. Same as if they are not going to have a quality of life improvement with the TAVR procedure, and if they have other severe diseases in their valves that are a main contributor to their symptoms. Another thing is they're looking at the annulus size if it's a native valve and it's less than 18 millimeters, and if it's a surgical valve and it's less than 17 millimeters, then they're not a candidate, and even if it's too large at 30 millimeters or greater. And of course, if there's any infection of the heart, endocarditis, then they're not going to receive the procedure. When we look at relative contraindications, we look at if the patient has had an MI within the past month, if they have untreated coronary artery disease, if they require any medications to keep their blood pressure up, if they have been mechanically ventilated within the past 30 days, and most relevant to our patient, if they have any contraindication to the access sites. And so this is a quick diagram of the TAVR approaches. And the most common is the transfemoral approach, which is on the left-hand side. And it's been shown to be more beneficial for the patient, less risk, as well as higher success rate compared to transapical and transaortic. But of course, the transapical and transaortic procedure approaches are there in case there's any contraindications to transfemoral approach. And so moving on to our case presentation, we have a 75-year-old female. She has a past medical history of COPD, coronary artery disease, status post quadruple bypass. She also has carotid artery stenosis, status post carotid endarterectomy, and breast cancer status post right mastectomy remission. She has also diagnosed a moderate aortic stenosis with a New York Heart Association scale of 3, which is essentially her symptoms. And she's coming in because she's referred by a cardiologist for worsening episodes of acute dyspnea related to her aortic stenosis. And so when we think of aortic stenosis, we can use the acronym SAD, which is patients experience syncope, angina, as well as dyspnea. And she has one or two of those already. And so she was seen by the cardiologist prior to admission, and she noticed some worsening of her symptoms, and she had some dyspnea on exertion, some chest pain, as well as difficulty sleeping, as well as gasping for air in the middle of the night. And on physical examination, it's pretty much unremarkable besides her cardiovascular exam. When we listened to her heart, there was a 3 out of 6 crescendo, decrescendo, systolic murmur in the aortic band, which is essentially on the right sternal border on the second intercostal space generally. And there's no JVD, but she also has 2+ bilateral lower extremity pitting edema. And in the emergency department, she was afebrile, heart rate was within normal limits, blood pressure was normotensive, and she's actually sitting well on room air, 95 to 99%. And when we look at her chem panel, she has a little bit of a drop in her hemoglobin, which was her baseline, and elevated BNP of 565, which could indicate some type of CHF exacerbation, and her TROPS was negative. In EKG, she had normal sinus rhythm, some left axis deviation, as well as left atrial enlargement, which is quite common with patients with moderate to severe aortic stenosis. Looking at her chest x-ray, some mild congestion and cardiomegaly, and she did receive a dose of Lasix, for her possible CHF exacerbation in the ED and was admitted for an expedited TAVR procedure. And so 2 of the procedures that she received when she got into the hospital was an echocardiogram, which showed an ejection fraction of 35 to 40%. She also had, more notably, a very heavily calcified severe aortic stenosis. It's severely stenotic as well as moderately regurgitant. And looking at the peak transaortic velocity of 3.9 meters per second, that is the upper limits of moderate to severe at 3.9. And she also has pulmonary hypertension. And looking at her Lexis scan shows a AV mean gradient of 47 millimeters of mercury and a peak velocity of 4.3. And so some of the things to risk assess the patient for a TAVR procedure, we'll look at the PFTs, which showed, or pulmonary function tests, which shows severe bronchitis, emphysema, and mild restrictive pulmonary disease. She also has a carotid ultrasound, which is completely unremarkable, and a CT angio of the abdominal aorta, coronary arteries, the celiac artery, and the common iliac arteries. And so just going down to she doesn't meet the minimum diameters of as the common iliac artery is noted to be 5 millimeters on the right and 6 millimeters on the left, which is too low to meet as an access site for the TAVR procedure. And so there are other approaches to the TAVR, but they were considered, but given her extensive surgical history as well as comorbidities, there was a decision made by Dr. Ku-Borden to improve the femoral access with a lithotripsy on the bilateral external iliacs and femoral arteries. And this way it would ensure luminal gain for better passage through the TAVR, for the TAVR catheter. And so this is a procedure summary of the bilateral lithotripsy, but essentially he inserted catheters between the left and right common iliac and external iliac segments. And he also did an angio at the same time, and the angio showed a heavily calcified disease with 80% luminal stenosis in the left common iliac, and in the right side it showed 85 luminal stenosis.
Now, looking at the results of the lithotripsy, the mission was accomplished. So following the lithotripsy, the stenosis was improved by about 30%, which was enough to allow for the TAVR delivery system to be used transfemorally. Associated with that improvement in stenosis, was the improved blood flow through both the common and external iliac vessels. Now, 2 weeks after this bilateral lithotripsy, the patient underwent the transfemoral TAVR. Immediately following valve deployment, the TEE, or transesophageal echocardiogram, was done and showed an EF of 25%, as well as regional wall motion abnormalities. 1 month later, however, the repeat echo was done and showed an improvement of the EF to 32%. And then 1 year later, a repeat echo was shown to show that the aortic valve was still functioning in place and the EF had improved dramatically to 50 to 55%. So almost a double improvement in the EF starting from, end stage heart failure up to a low normal ejection fraction. Now, the significance of this case is that we were able to find a patient who wasn't a surgical candidate and wasn't a candidate for the transfemoral approach of the TAVR. And by utilizing the lithotripsy, you had a low risk of vessel rupture while helping accommodate the TAVR catheter delivery system using the transfemoral approach. Because of that, the patient went from having very difficult options with high risk to having the best option, the gold standard, with decreased risk, including decreased morbidity, decreased mortality, shorter length of stay, and reduced costs. And so this allows us to examine how we look at patients with severe aortic stenosis moving forward, and seeing, even if they aren't ideal candidates for the transfemoral approach, perhaps they can have this lithotripsy done prior to that and allow for better outcomes moving forward. And so just moving on, this is our references, and we'll open it up to questions if there are any. Thank you.
All right, good afternoon, everyone. I'm Argan Artunian, second year internal medicine resident, and I'm here with Dr. Afshar, first year internal medicine residents. And we are presenting an interesting case here, which we found, we utilized a bedside ultrasound, and we found a lung nodule, which was missed on a chest radiograph. And I'll later on discuss why I think it's important for incorporating into our practice.
All right, thanks for all being here, and thanks for those virtually listening in to us. So we're going to start by introduction. So basically lung ultrasound, also known as thoracic or pulmonary ultrasound, is being more frequently used in both affluent or resource-limited settings to guide patient management. Lung ultrasound has been shown to be more accurate than standard chest radiograph and physical examination in many pulmonary pathologies, such as pulmonary edema, pleural effusion, pneumonia, and pneumothorax. One study has showed that lung ultrasound was actually effective in reducing number of chest x-rays, relative medical cost, and radiation exposure in critical care settings without any outcome without affecting basically patient outcome. Many studies have showed that there has been many studies that focused on efficacy and accuracy of lung ultrasound on detection of pleural effusion, consolidation, pneumothorax. However, the role of lung ultrasound on detection of pulmonary nodules are not well defined. Now we're going on our case that shows the importance and basically the utility of using POCUS on pulmonary nodules. In our case, basically the patient is an 80-year-old female with past medical history of coronary artery disease, heart failure with biventricular AICD, type 2 diabetes, hypertension, who presented to the ED with foul-smelling urine, jaw pain, and generalized weakness for 2 days. On arrival, patient vitals were significant for temperature of 102, heart rate 112, respiratory rate of 20, blood pressure of 127/72, and oxygen saturation of 94% on room air. Initial lab workup were significant for leukocytosis, BMP of 1050, lactic acidosis, and elevated glucose. UA was done that was significant for cloudy urine, positive for glucose, trace leukocyte estrays, white blood cells, RBC, and few bacteria that were consistent with urinary tract infection. Blood cultures were drawn and chest x-ray was done. As you see on the image here, patient chest radiograph shows the biventricular pacemaker in the image, and also borderline cardiomegaly, and some atelectatic changes in the lingula, and very mild pulmonary edema, pulmonary congestion. Patient was evaluated at bedside by the primary team, and physical exam was done that was significant for +1 bilateral lower extremity pitting edema up to her shins. We also went ahead and did an routine point of care ultrasound at bedside of the lungs that revealed B lines at multiple areas of the lung bilaterally, which are consistent with pulmonary edema. Ultrasound also revealed an incidental hyperechoic irregular oval-like structure behind the rib at the right mid-axillary region and was measured to be 1.5 times 1.5 centimeters. Due to size, suspicious echogenicity, and shape, a chest CT was also ordered. As you see on the image, the chest CT showed the right middle lobe lesion measuring at 1.6 times 1.6 times 0.8 centimeters with irregular margins and speculation. Patient at this point did not have any history of any lung nodules or was not aware of it being there. She was consequently undergone CT-guided biopsy of nodule, and it showed benign lung parenchyma with some inflammation without any evidence of malignancy. Other etiologies for the nodule, such as HIV, TB, and other pulmonary infections were also ruled out during the hospitalization. She was eventually discharged on IV antibiotics for MSSA bacteremia secondary to jaw abscess and was instructed to follow up with repeat CT of the chest in 4 to 5 weeks after the resolution of the bacteremia.
So I think this was a very interesting case that we presented from the standpoint of doing a point of care ultrasound. I think this is something that being really underutilized. Point of care ultrasound, it's a very evolving basically tool and modality that not too long ago, thanks to our residency, we've been to an ACP conference, and it's a very growing field. And I think our hospital and the residency can benefit a lot. And one aspect of it is doing ultrasound of the lung. So lung ultrasound shows to be very cost effective. It's very quick. It's very safe. There is no radiation. You don't have to worry about the patient having an insurance, underserved community, anywhere it can be done, easily accessible. And when they compared to the chest X-ray and CT scan, it showed that it was a lot more sensitive in a lot of cases when it comes down to like pulmonary effusion, pneumonia, pneumothorax, and edema. However, there is a lot of lack in evidence in literature when we come to assess the the role of effectiveness of a lung ultrasound in detecting a pulmonary nodule. So the case that we presented, it showed that the nodule with the irregular shape that was clearly missed on the X-ray that we basically presented to you guys. And I think this might be one of the few cases that we can just publish it somewhere else, and this will open up the gate for doing more accurate research and see if we can replace. We know a lot of times people come here, they get unnecessarily exposed to CT radiation, whether in the ED or once they're hospitalized. So our goal by presenting this case is see if we can basically team up with the hospital, do more research, and try to just cut down on unnecessary CT exposures and all those radiations, which also can be very costly for the patients. Some other things, it's the chest ultrasound also has been shown to be very effective in differentiating different types of tumors, such as neurogenic tumor versus vascular and other types. There is a lot of studies showing the endotracheal ultrasound that is very helpful. As we know, that's the standard of care for doing biopsies of the lung nodules. However, there isn't much done for the point of care or bedside ultrasound. That's something we are hoping that we can achieve in the next couple of months and years. So again, the whole point of this case was to show the importance of doing a bedside ultrasound, and we are working with the hospital in the near future to incorporate that into our residency programs, both internal medicine and hopefully family medicine. And we can basically provide a better patient care, decrease the cost, and also the amount of radiations that our patients unnecessarily are getting for different reasons. In conclusion, that's basically, it shows that the lung ultrasound have a very good potential in detecting lung nodules, which can be done both in inpatient and outpatient for the very reasons that I explained: cheap, cost effective, and there's no radiation. And the sensitivity and specificity has been shown to be much higher than regular chest radiograph. Just for the sake of time, I think just made this a little bit shorter than what it should be, but that was the main point. And if you guys have any questions or anything, I can answer here or later on, because I know people are waiting for it.
I have a quick question.
Yes.
Quick presentation. Was just to clarify, was the ultrasound done just to confirm the pulmonary edema initially?
So yeah, patient, once he came in, she was having some dyspnea and shortness of breath. So as a general point of care ultrasound, the standard, we do like 6 points of ultrasound, and that was incidental finding. So we were looking for it, which Dr. Afshar mentioned. We did find some B lines, which is suggestive of pulmonary edema. Okay, thank you. Yes.
I find that in X-rays are more accessible than ultrasound. A lot more accessible. You could do portable X-rays and they come within seconds, as opposed to ordering an ultrasound that needs done. But more importantly, also ultrasound need more skill.
Absolutely.
There were so many times where you would order an ultrasound for a specific thing simply because the literature says they are better. And then the radiology department would call and say, we don't have anybody to read this. We recommend a different kind of study. So ultrasounds are not, I see your point. I'm not an internist, so I believe what you said is 100% correct, but I think it needs more training and more more expertise than a simple chest X-ray would offer.
Sure, that's a great comment. I'm glad you brought it up. I'm just going to keep it short because I know we are very short on time, but I don't know if you listen our presentation at the beginning, it's a bedside ultrasound. That's completely different than what you order, and there's an ultrasound technician comes. This is for us as physicians being trained. So I have it, it's a handheld, it's like 2 seconds, I just do it. So you are getting trained to do that. You're not dependent on any ultrasound technician and the radiologist to it. So we did this ultrasound at the bedside, quick, and we read it, and we were like, there was a suspicion, let's do a CT. So, but that's a great point. And the whole point we're trying to do point of care ultrasound, it's you have it as a physician, as a provider, and you can perform it at the bedside with the patient, and you can interpret the imaging right there. So you're not dependent on anyone. No, it's not. No. Yeah. Okay. Thank you, guys.
Thank you.
Hello again, everyone. My name is Rahil Kajani, third-year internal medicine resident. Today, I'm going to be discussing a case that we did with Dr. Rafik Mugnetsian, one of our first-year internal medicine residents who couldn't be here, unfortunately, and then Dr. Arturo Vega, one of our critical care doctors here in the ICU. So just going through an overview of the presentation, we're going to talk about disseminated fungal infections, talk about the case, and then go into the significance of the case, and then we can open it up to questions after that. So here we're talking about disseminated fungal infection. So what exactly is a disseminated fungal infection? As you can see on the slide, disseminated fungal infections are noted by the presence of a fungal pathogen in the blood and or any other sterile deep-seated tissue or structure because of hematologous seeding. So essentially the fungus is in the blood causing the infection, and it spreads to multiple organs within the human body. Now, when it comes to which types of pathogens cause these types of infections, we're looking at three main species of fungi, particularly the Candida species, the Aspergillus species, and the Cryptococcus species, with the Candida species being the leading fungal pathogen causing these disseminated fungal infections. Amongst the Candida family, Candida albicans accounts for the majority of the Candida infections. However, there are no known cases of Candida parapsilosis causing disseminated fungal infections, which is what makes our case so interesting. And in the image over here, you can see the different types of Candida, with the Candida albicans being at the top in the green and the Candida parapsilosis being white at the bottom. Just a little bit more information about this type of Candida. Candida parapsilosis is a yeast that's been known to cause infections, specifically in immunocompromised patients, like patients who are in the ICU. It's been known to be found on the human skin and can grow in patients who are receiving TPN or total parenteral nutrition, and it can form biofilms on catheters and other implanted devices, which makes it kind of difficult to deal with if those biofilms are formed. Now, going into our case, we have a 41-year-old female with a history of diverticulitis that was complicated by a bowel perforation, leading to the patient requiring a colostomy bag, which was placed in October of 2019. The patient also has this history of a symptomatic fibroid uterus, about 22 millimeters in size. With abnormal uterine bleeding. The patient was treated with hormone therapy for about 1.5 years. However, patients still continue to have heavy menses, using up to 8 pads per day. The patient came to White Memorial to have a total abdominal hysterectomy, bilateral salpingectomy, as well as a possible bilateral oophorectomy. And that case was to be combined with the colostomy takedown. Of note, the colostomy takedown was supposed to be done 2 weeks prior. However, during the pre-op labs, the patient was found to have a hemoglobin of 5.2, likely from these heavy menses. And so the patient was admitted at that time and transfused 4 units of blood, which we'll find out and talk later on about how that can cause a little bit of an immunocompromised state. So at the current hospitalization here at White Memorial, the patient was in the operating room when a code blue was called due to cardiac arrest during the procedure, right towards the end of the hysterectomy. The ICU team arrived to the operating room. ROSC was achieved after 4 rounds of CPR, and the patient was upgraded to the ICU and was already intubated because of the procedure. At that time, code hemorrhage was called because the hemoglobin was found to be at 4.0, and a massive transfusion protocol was initiated. Additionally, the patient was found to be in DIC and hemorrhagic shock and was being treated with fluids, blood products, broad-spectrum antibiotics, and multiple pressors. You can see this patient was very, very sick. In fact, post-operative Apache score, which can indicate how likely a patient is to survive a procedure, the postoperative mortality for this patient was actually 88% with an Apache score of 39. So the odds were stacked against us. Overnight between on the day of the code and the next day, the OB-GYN team went to explore the abdomen and bedside. No source of bleeding was found. However, the abdomen was packed. The next morning, Cordis catheter was placed and 4 units of blood were transfused within a span of 15 minutes, allowing the patient to go from 4 pressors to only requiring 1, which allowed for any sort of procedural intervention to be done. At that time, the interventional radiology team here decided to proceed with a internal iliac embolization. The patient was found to be extravasating from the left uterine artery, and coils were placed, and the bleeding was successfully controlled. However, the patient was so sick at that point, and I believe up until that point of the embolization, she had received about 26 units of blood, which is a very, very high amount. Moving forward, just touching on the highlights of the patient's hospital stay. On day 2, the patient was found to have no flow in one of her hands, which would end up becoming infected because of the ischemic gangrene that was caused. Additionally, because of the cardiogenic shock, the patient's kidneys were not functioning correctly, and the patient was started on hemodialysis on day 5 with a Quinton catheter placed at that time, which again kind of increases her risk of having these infections. Day 6, TPN was started as the patient's bowels were not really working and she was not tolerating tube feeds. But despite being on full treatment in the ICU, the patient's white blood cell count was increasing to 40 without any known source. So the next day, patient underwent, or on day 8, patient underwent a bronchoscopy at bedside and was found to have these diffuse white mucosal plaques that were very easy to scrape, with underlying mucosa that was very friable and would bleed very easily. Cultures were taken at that time and some specimens were drawn during the bronchoscopy. And here we have a video of it. I was wondering if we could get a little help. There's a play button on the bottom left. Okay, so here you can see the first bronchoscopy. We're looking at inside the patient's lungs, and you can kind of see these white plaques on the walls, and you can see the mucosa seems very irritated, very irregular, and so we were able to get a good, adequate sample out of this. For the interest of time, I'm going to proceed to the next slide. On day 9, the beta-D-glucan was found to be over 500, indicating this patient had a severe fungal infection. Mycofungin, which is a broad-spectrum antifungal agent, was initiated. On day 20, we finally saw the culture growing this rare bacteria, this rare fungus, the Candida parapsilosis. However, after being on mycofungin for about 3 weeks, a repeat bronchoscopy was done, and we saw marked improvement of the mucosa, and you can kind of see it here. And so you can see much better. Here we're looking at the carina of the lungs. I know just from a gross inspection, you can see that it does look much healthier compared to the diseased bronch that was done 3 weeks prior to this. And so there was a marked improvement and clearing of all those whitish plaques, with the only residual finding being some endobronchial mucosal thickening, which we were very happy to see those results. So here's just an overview of all those broad spectrum antibiotics the patient was on, just to give you an idea that they were on very, very large doses of high, like the big gun antibiotics. And now looking at the patient, she actually did survive and was able to be discharged eventually, was weaned off of her trach tube. And thanks to the great team that we have here at White Memorial, we were able to help prevent this patient from passing. However, the patient is still requiring dialysis at this time. Moving into the discussion. So part of the reason why this case is so significant is because not only did we have a patient who had a high risk of postoperative mortality, but we also had this very, very rare infection that spread throughout the body. And so when we're looking, although it was very interesting to see a case like this, we have to examine how did we get to this place, and how do we prevent this from happening. And so looking at some risk factors that are studied about what can cause disseminated fungal infections, you see surgery, TPN use, fungal colonization, renal replacement therapy, or hemodialysis, infection and or sepsis, mechanical ventilation, diabetes, and a high Apache score. Our patient had every single one of those except the diabetes. Moving forward, we can kind of discuss how do these different risk factors cause a patient to be immunocompromised. So some studies show, again, having on day 6, the patient was started on hemodialysis. Again, we kind of talked about dialysis requires insertion of a catheter, and we have this fungi that grows on the skin, and so that could have been a potential introducing point for the infection. Additionally, hemodialysis does put the patient at an immunocompromised state. Furthermore, if you look at some studies, the use of HD, TPN, and broad-spectrum antibiotics, which our patient had plenty of all three, increases the invasive candidiasis rate to 16.6%. Additionally, our patient received not only 26 units of blood products plus FFP and platelets during the hospitalization, but also received 4 units prior. And so some studies show that blood transfusions are immunosuppressive and can affect post-operative immune function. And so having known that piece of history, perhaps early antifungal prophylaxis could have been started. Additionally, the patient was intubated and mechanically ventilated for a long period of time, and that also increases the patient's risk factors. So here are some of the references. I'm open to questions at this point.
Besides of the long course of microfunction, the patient continues to have a positive fungal culture. So was there any point in time there was a consideration of changing agent?
So I believe. So I think based on the timeline of events, so the results of the culture were found out about a week or two after the cultures were done. That initial culture was taken during that bronchoscopy. And so after the microfunction was initiated, we did see an improvement of the white count, as well as improvement in some respiratory status. And I think for that reason, it was why we continued with the microfunction, because we felt that progress was being made after we identified, why was this patient having such a high white count when we saw all those white plaques on the bronchoscopy the first time. Any other questions?
What bacteria did you culture? She obviously was on significant antibiotic, but I didn't hear any bacteria.
Of course, yeah. So actually looking back at the hospital course, so on day 33, we did see the respiratory cultures did grow Pseudomonas, as well as Stenotrophomonas, and as well as the rare Candida. And so that was the reason why some of the antibiotics were continued. And as you can see, some of them were stopped, and then others were initiated, looking at like Clinda, the Miro, and the tigecycline being used in the last week and a half or 2 weeks of the patient's hospital stay.
I think it is important to recognize that those organisms, Pseudomonas, Stenotrophomonas, Candida parapsilosis, they're all obtained in the hospital. She didn't come in with that. She came in because she needed a hysterectomy, and she ends up with this life-threatening organism. So going back to the initial presentation on meropenem, I think that really highlights the need for antibiotic stewardship, right? Because we sometimes put people on broad-spectrum antibiotics, I think almost, because, maybe we're not sure they have an infection, but we just want to cover it just in case, and they come in for something completely different, and then they end up with these life-threatening infections. So I think that this case also really highlights the importance of antibiotic stewardship.
Yeah.
Of course.
Is the renal failure due to the hemorrhagic shock, or is it because of multi-organ involvement with infection?
Absolutely. So the renal failure we most likely think was from the hemorrhagic shock. At a certain point, the patient was on 4 pressors, and code discussions were had about this patient that is approaching the end stages of life, especially with the DIC happening. And so with the lack of renal perfusion for almost those first 12 to 24 hours, I believe the lack of perfusion is what caused the kidneys to fail at that time. It depends. It depends on how much the patient is able to recover after that point in time. I believe the patient did start making urine after being anuric for an extended period of time. However, last update we checked, she is still requiring hemodialysis, and so I think I would have to touch base with the nephrologist to see, what the recovery and what the prognosis is of her renal failure at this point moving forward.
It's probably not reversible.
Yeah.
I'm going to say it's been so long. I mean, even in community who recovers fully, once they are this long, it's just a bit too long.
Yeah, most likely not. But again, I didn't want to make a definitive statement without absolutely knowing. And again, just wanted to touch base. Thank you again, Dr. Barrio. Again, this signifies about how great of a case is. Not only did we have a patient who had a high post-operative mortality that we were able to help save, but then also this provided us a learning opportunity of how to improve care moving forward for our especially sick patients, including things that happened before the hospitalization. Thank you guys so much.
Good afternoon, everyone, and thank you, everyone, for hanging in there. I know we're running behind, so I'll try to be expedient here. I have the pleasure of introducing not only our family medicine residents, but also our one visiting from Hanford and Glendale. I will say I got to give them all props in that we are in the middle of board exams, and so they all got their projects in and are presenting, basically circling their board exams, and so that's another stressor that I'm glad they're happy to be done with soon. I have been requested by admin here to try to limit the questions just because we are so behind in time. So we're not saying don't ask questions, but perhaps not as long so we can catch up and get this day on track. So from our program, we have several topics, mostly because family medicine, we're focusing on a lot of preventative topics. We're starting with Dr. Ulysses Hernandez and Shah Mahmoud, who are talking about basically how to address conception care in our women of procreative age. Going to be followed by Dr. Rogelio Sanchez and Tran Nguyen, who's going to be talking about time to colonoscopy from FIT screening. We know that has been an ongoing challenge here at White Memorial to get that in timely. Then we're jumping to some hospital medicine where Dr. Arias is going to be covering how do we have best outcomes for our patients who elope. It happens all the time. We had one not too long ago. And then we're going to go back to the real preventative. We can't prevent death, but Dr. Valencia Sanchez, Marvin Valencia is going to be talking about how do we address this to our patients in the clinic level so they could have their wishes fulfilled as they reach the end of their lives. From there, we jump to our neighbors to the north in Hanford. And we have Tamara's Mateen coming in, who's talking about a rare case of Burt-Hodge-Dubé syndrome, which should be very interesting. And then we just jump a little bit northeast to Glendale. We're going to have Udani Mawachaku, who's going to be presenting remotely. She pre-recorded. And then also Maria Teresa Sanchez and Daisha Ortega, who are going to be talking about a diabetes self-care management program. And lastly, followed by Molly Wilkerson, who'll be talking about improving a family medicine's experience in SNF, how to take care of SNF patients. So without further ado, Dr. Hernandez, Dr. Ahmad.
For having us here. My name is Etisham Ahmed. I'm a third-year family medicine resident here.
I'm Dr. Ulysses Hernandez.
And today we'd like to present our intervention, increasing awareness of contraception care for female patients aged 21 to 45 during our Well Women visits. The impact we hope to address in our community, the impact of a lack of broad-based access to contraceptive care is felt worldwide. And no matter your personal beliefs, we felt addressing the need of contraceptive care was a worthwhile endeavor to reduce the gap in health disparity affecting women of reproductive age in our local community and especially our clinic here. A little background. So nearly 1 in 2 unintended pregnancies ultimately result in abortion. Estimates can be up to 61% globally. And so really our goal is also to prevent unnecessary abortions, which also have like a 13% mortality rate for mom and baby. Additionally, statistics also show that unwanted children have a greater psychosocial impact, and these things affect them throughout their whole life. And, these high-risk gestations are also highest among the poor and low-income women, especially like in our community here. And so these populations also have a disparity in access to prenatal care. So these are the kind of interventions we're kind of hoping that we can make an impact. A large proportion of our reproductive age women are in need of contraceptive care, as evidenced by an across-the-board low rate of women having received counseling or even information related to birth control. In LA County, some estimates show like just even up to 40% barely have received counseling or access to care. So, our next slide. Okay, so contraceptive medical care is pretty much patient-centered counseling and delivery of contraceptive care based on the needs and goals of the patient, which is to delay or prevent unintended pregnancy and achieve healthy spacing of births. So things we like to discuss during our routine well woman visits include family planning, contraception prescriptions, including emergency contraception, and achieving or preventing pregnancy. And these discussions usually will be documented using a Z30 ICD-10 code. Next slide. So contraception care discussions, we can provide access to patient-centered counseling. For example, with our predominant Latino population, studies have shown that different populations have different values and needs, and they respond differently to the way you present your information. And so our effort is also involved in both a systems-based and physician-based improvement and intervention.
So for our methods, we use the PDSA method, plan, do, study, and act. For our clinic patients, only 18.2% of patients seen by residents in our clinic have documented contraception care discussions during woman visits. Thus, basically our goal is really to increase the rate of contraception care discussions, and we will document that by really using a Z30 code during these visits. So for this, we did use, we basically created a guide to kind of a handout to guide discussions regarding this, and also provide them a list of contraception options. And basically for the study, after we implemented this change, increasing the amount of basically having this handout was between 328 and 429, basically the previous month. And the results, we did get an increase to 29.7% visits that included the Z30 codes. So it was definitely an improvement from previous. So for moving forward, I think we could really expand the kind of the counseling to other visits, and not only well woman visits. And also, I think it'll be beneficial for residents if we, for the family medicine residents, if we have kind of formal training and having more formal training and having these discussions. And so this is kind of the handout that we made. So family planning as patient-centered contraception counseling. So some questions, basically a questionnaire. Are you looking to prevent pregnancy now? Are you currently on birth control? Are you happy with your choice? Do you have any preferences? Basically yes or no questions. And if they are interested, we ask them the following questions to make it more appropriate when to start the contraceptive method. And we also made a handout, or this was actually from the FDA. Basically, we highlighted all the different contraception methods, their effectiveness, their use, and kind of side effects. So it's very personalized to the patient option. So in conclusion, I think it definitely helps having high quality care for our patients and developing a meaningful patient and physician relationship. And this increases the likelihood that the patient will initiate birth control method that meets their needs and their goals and their values and preferences. Questions?
Comments?
Yes.
Well, I believe yesterday the Supreme Court is changing their mind about abortion and the legal states. How much would that influence your conversation with your patient about contraception?
I mean, I feel like this is, no, I mean, I think regardless of your personal beliefs, I think providing this high quality contraception care that meets the needs of our patients is something that's really impactful for their health. And independent of what you think or believe, like I feel this, doesn't hinder that. And this is just a.
I believe this is the law.
Mm-hmm.
Or they're leaving it up to the state. I think it's that.
No, that I believe that's for abortion, but I don't believe that's directly impacting like the birth control.
Mm-hmm. I think at the end, it will make definitely these conversations more important and maybe more valuable. And we may even have an increase. Maybe some patients will come maybe with more questions. Yeah.
Thank you for having us.
Good afternoon, I'm Rogelio Sanchez Jr.
And I'm Channy Nguyen.
So we're going to be talking about evaluating the time to colonoscopy after an abnormal fecal immunochemical testing. This is our table of contents. We're going to discuss background, methods, results, and conclusions. So a little background. So the CDC reports colorectal cancer as the third most common cause of cancer death in the U.S. It constitutes approximately 10% of new cancer cases and approximately 8% of all cancer deaths in the U.S. Age is a major risk factor for colorectal cancer, as well as environmental and genetic factors. Although the incidence rates of colorectal cancer have dropped over the past several decades in older adults due to detection of disease at an earlier stage, the incidence rate in people younger than 50 has actually increased with a gradual shift toward right-sided or proximal colon cancers. Given the increased incidence of colorectal cancer in younger people, the U.S. Preventative Task Force, American College of Gastroenterology, and American Cancer Society now recommend screening adults with an average risk for colon cancer beginning at the ages of 45 to 75 years of age. Some screening tools include colonoscopy, flexible sigmoidoscopy, fecal immunochemical test, and fecal occult blood test. A positive screening test besides colonoscopy requires a prompt follow-up colonoscopy. So the European and Canadian guidelines recommend follow-up colonoscopy within 31 days and 2 months, respectively. In the US, there's actually no guidelines to follow up to colonoscopy. So previous studies with follow-up colonoscopy starting at 7 months showed an increased risk of colon cancer. A systematic review to assess the association between time interval from positive fit to completion of colonoscopy and colorectal cancer outcomes showed colonoscopy performed beyond 9 months was significantly associated with higher incidence of advanced colorectal cancers, so stages 3 and 4 at diagnosis. Therefore, in such cases with positive fit, timely colonoscopy is recommended to rule out presence of cancer, to detect it at an earlier stage, and remove polyps in an effort to ultimately lower the risk of subsequent colorectal neoplasia and death from colorectal cancer. Delay to best practice timelines in getting the colonoscopy can be impacted by a number of patient, physician, and system related factors. Some examples of patient factors would be like fears, no history or no family history of colon cancer, issues with compliance, and socioeconomic issues. Physician factors would be like delay in referral, delay in workup, not educating patients on the importance of screening adherence and follow-up. And then system-related factors would be like limitation in the capacity of the colonoscopy resources, issues with referring specialists, like unable to schedule or canceling of appointments, insurance issues, and the COVID pandemic was actually a unique event that caused major delays.
So the purpose of our study is to evaluate for possible delay in completion of colonoscopy after a positive fit, and whether this delay is associated with an increase for risk of colon cancer.
So our study is a retrospective study consisting of 337 medical records from our resident clinic with ICD code Z12.11 for screening for colon cancer, R19.5 for other fecal abnormalities. Age ranges were from 45 to 75 years old, and the timeline was from January to December of 2021. Screening results were categorized as FIT positive, negative, or pending. Colonoscopy normal, abnormal, or pending, history of FIT positive, and refusal of screening. Our results with positive FIT were analyzed for time to GI referral, GI evaluation, and completion of colonoscopy. Colonoscopy results were also documented. So these are our results, colon cancer screens from January to December of 2021. We had 8 positive FIT results, 2 history of positive FIT, 96 negative FIT, and 94 FIT pending, 10 normal colonoscopy, 12 abnormal colonoscopy. We had 114 pending colonoscopy and 1 refusal. So a total of 337 patients were screened from January to December. Out of the 198 patients who were screened with FIT, 104 or 52.5% of the patients actually completed the FIT testing. 94 or 47.5% of patients have not completed the screen. We had 8 positive results, and that was only 7.7%. During our study review, we had 2 patients with a history of positive FIT back in 2017 and 2020. They had recurring colonoscopy referrals, but still no specialist follow-up. So this is a table showing our data for time to GI referral, GI evaluation, and colonoscopy. For time to placement of GI referral ranges from 2 days up to 64 days. Time to evaluation by GI ranges from 47 days to 293 days. Time to colonoscopy was from 76 days to 346 days. So the result were primarily internal hemorrhoids and polyps. Average time overall for placement of the referral was 18 days, 148 days for GI evaluation, and 201 days for colonoscopy, time to colonoscopy. So we had 50% of the patients who had a positive FIT were actually evaluated by GI and completed colonoscopy. So in conclusion, our study did show there are delays in obtaining colonoscopy after a positive FIT result. Multifactorial factors, including placement of the referral in a timely manner, patient adherence to follow-up appointments, and we do not have a system to monitor the completion of colonoscopy. So we propose a TICO system in our clinic to monitor for this completion. Limitations of our study includes small sample size and short follow-up interval. Due to these limitations, it still remains unclear if the delay in colonoscopy results in an increased risk of colon cancer at this time. And these are our resources. Thank you.
Good afternoon, everybody. Today, I have the pleasure of presenting a project that was, we titled it Reducing Rates and Improving Outcomes in Patients Who Elope or Leave Against Medical Advice. This project is a collaboration between Dr. Chris Kimura, me, Victor Arias, Michael Jordan, and we also had the collaboration of Mr. Paul Vega and Apurva Shah. Well, the table of context for this presentation, we're going to state our key problems and objectives. Number two, we're going to state our patient population and demographics. We also are going to delineate our process and methodology. We're going to emphasize our key learning points, the challenges of our current project, and the next steps moving forward. Ultimately, it is important to emphasize about the background and the problems that are aroused from leaving against medical advice. On our literature review and search, we did conclude and have several conclusions about that were shared by many articles that we cited. Number one is that leaving against medical advice discharges have been associated with deleterious health and health services utilization outcomes, including lower rates of attending follow-up appointments, higher rates of readmissions, increased mortality, and subsequent further leaving against medical advice events. Empiric studies have also demonstrated that patients who leave against medical advice have higher readmission rates and may have increased risks of adverse health effects. Leaving against medical advice discharges represent relevant medical problems with impacts on patient safety and potential medical, legal, and socioeconomic consequences. I believe it's a good idea to delineate the difference between a technical difference between elopement versus leaving against medical advice. Elopement is defined as an unauthorized departure of a patient from an around-the-clock care setting, such as a hospital. Now, leaving against medical advice is, in a generalized definition, can be defined as the patient's decision to leave the facility after having been informed of and having the ability to appreciate the risk of leaving without completing treatment. These are the key problems that we delineated part of our project. Patients who elope or leave against medical advice have worse clinical outcomes, increased cost of care, increased malpractice risk, and sometimes can be, frustrating for both the patients and the care team. There are certain non-modifiable patient demographics that we seem to notice that can increase the risk for leaving against medical advice. There are wide-ranging possibilities of factors that contribute to leaving medical advice discharges, and identification of those factors that occur most frequently and have the greatest impact on patients' decision to leave against medical advice need to be identified to improve those major factors. Therefore, this is the objective, or became one of the objectives of our project. Number one, to seek and to identify if there are cultural or other specific differences in the community served by Adventist Health White Memorial Hospital compared to the literature related to leaving against medical advice. This QI project, it was important for us to better understand the characteristics of patients leaving against medical advice in this hospital. And eventually, once we have defined the most frequent issues that contribute to leaving against medical advice discharges at this hospital, we will incorporate evidence based on best practices to create hopefully a tool that will utilize physician, nursing, and social work interventions for patients that to address common leaving against medical advice issues that will hopefully result in a decrease in these type of discharges. This is a little bit of demographics of the patients that we initially screened into our project. The demographics that were reviewed, we have age, gender, ethnicity, the payer, point of origin, the service line, marital status, and length of stay. These were exclusion criteria. So number one was we defined hopefully the length of stay had to be less than or equal to 1 day
to exclude ER patients. Number 2 was the line of service. We excluded OB-GYN, behavioral health, and emergency department services, and we also excluded minors. The time frame that we utilized was from January 2021 to January 2022, and we were exempt from IRB review as QI. Originally, the amount of charts that were reviewed and congregated before the exclusion criteria amounted to around 335. After application of exclusion criteria, we had a total of 146, and about close to 50 charts were more intimately analyzed. Our process and our hope was for us to determine a possible reason for the patients to leave against medical advice, either determined by direct documentation on the chart, or if we couldn't find one, we would assign as an unknown reason. This is just some graphs delineating the distributions of their population based on demographics. Number 1, we have age distribution. Number 2, this is the male to female distribution. We have an ethnicity distribution as well as the payer distribution. And of course, as I said, the higher the percentage is basically the amount of people that were registered to leave against medical advice during the time frame that we analyzed these charts. The point of origin, home or self-care, seems to be the highest. Service line was general medicine, to seem to be the highest as well. Marital status and length of stay seems like the highest one was around 2 days. Overall, the key points that we wanted to emphasize after the study, after a review, was that we noticed that there is an opportunity to hopefully improve electronic medical record documentation regarding leaving against medical advice and elopement related to location of documentation. Another key point that we found out is there is an opportunity to develop a leaving against medical advice / elopement template in the EMR that hopefully can give us a little more information about the characteristics of the specific case. Another thing, unfortunately, we were also able to notice that EMR documentation inconsistently identified causes for leaving against medical advice, and there was really not that much documentation about what attempts were done to prevent that. And also, we had some another point that was brought out in our more intimate review was that documentation rarely explained the patient reasons for leaving AMA. So based on those key points, we do have these challenges and limitations to our project. Number 1 was our challenge in making a retrospective determination for LMA just based on the review charts. Number 2, there were some challenges in locating the documentation of why the patient left AMA on the EMR. And number 3, there was a subjective determination of possible cause of leaving against medical advice by us, the investigators. So next steps, we are still continuing to complete and summarize our findings. We want to see if we can collaborate or some type of leaving against medical advice development team. Our hope is to develop a multidisciplinary plan to decrease leaving against medical advice that incorporates best practices, and also to develop a plan and a solution that addresses maybe the limitations of EMR and the opportunities that EMR can bring to improve quality and location of documentation for topics relating to leaving against medical advice. This is our sources.
Were these only elopements or AMAs on the family medicine service or across the hospital?
This was across the hospital.
There was some graphs, the last one which went by fast, and I just noticed mostly everyone was single. Okay, you're right there. So I have you guys like got to correlating like
single men.
Well, no, could be single mom, right? She got lots of kids or something. I don't know, I'm just curious.
And the age also, what is 57, that an impress. Maybe up to 57.
You got a question about that? Oh.
Yes.
There's a point in one of the slides that said the subjective by investigators. Can you talk a little bit about that? What do you mean by that?
Correct. So as we pointed out on this slide is that it was we had a very tough time identifying the actual reason, as in the patient is not really directly asked if they have a reason of why they're leaving against medical advice. We do look at some notes that are put into the EMR where, you know, they explain that the patient was given the explanation of what are the risks and benefits of staying in the hospital versus leaving against medical advice. However, they never state directly from a, let's say, a statement done by the patient where they say, hey, I'm leaving because this is taking too long, or hey, I'm leaving because I have these other things going on outside the hospital. And the reason why I said, why we said there's a subjective determination is that the investigators, us, by looking at maybe the hints from the EMR, from the notes, we came with maybe a possible subjective determination of maybe why the patient left, but not, it's an assumption, unfortunately.
The question is comments?
Well, no, we're questioning the charts because we don't have a direct statement from the patient. Yeah.
Like, what I'm trying to say, relate here.
Yes.
When a patient comes in and you ask them what's happening, that's subjective, right?
Correct.
This is, and an investigator asks the patient why you're leaving. Well, that's subjective too.
Correct.
So, I mean.
Yeah, I agree. Now, what we're trying to point out is that this were not questions that, or the answers to these questions were not charted in the EMR. Yes. Hi.
Very nice. Into this. I review all the there is a DC Keynote.
Correct. We did.
I think
yeah.
Not an AMA unless.
Mm-hmm.
Something else. We always want to make sure that these AMAs are safe.
Mm-hmm.
So we're not punishing patients. So if we can provide their DC, prescriptions in each bed, the equipment, and the taxi, that's what we. An ambulance for a non-ambulatory patient. But what's requested? Yeah, we don't want people crawling out of here either. So that's.
Thank you. Yes.
Are we differentiating between AMA and elopement, or are we combining them together? Because I could see why in elopement, I'm assuming the patient just leaves. So
Correct.
there's no conversation. So you would never be able to find out really why that patient left objectively. Since they just,
yes.
So it's not fair to lump them with the against medical advice. They're completely separate groups.
I don't think it sounds like they separated them out, but you'd be surprised at how close many of the elopements are to.
because it's not, there are very few, a handful that are true locums who walk in the room, with their warm breakfast and they're gone. There are not many of those. They're really telling you, I'm leaving, I gotta get out of here. And you don't have time to get a hold of the physician to talk to them. They're not gonna wait. And hey, I got him on the phone, talk to him. No, I'm not talking to him. That's a locum.
All right, thank you.
All right, hello everyone. I'm Marvin. I'm one of the family med residents here. And my project is on the perceptions of death and dying and establishing advanced directives on senior patients greater than 65. And I also had the pleasure of doing this with Dr. Zapata, who helped me with this project as well. So a little bit about what we're going to be talking about. I mean, just a background, method, screenings, essentially what this project's about. To kind of start off a little bit on background, the reason why I wanted to do this project was because of our pandemic. We had to discuss about end of life kind of options and a lot of just like code status. And I think too many times we're talking about this way too late. Often we were fortunate enough to have the conversations with the patient still able to make the decision. However, a lot of times we were having these conversations with the family who had no idea what the actual patient wanted themselves. And so just kind of getting a poll that I got from the University of Michigan essentially found out that 59% of those who have talked with someone about medical treatment, they do not want it. They're seriously ill. Of those, 29% did so in the first 3 months of the pandemic. And then 46% have a medical durable power of attorney or an advanced directive. And of those, 7% completed them in the first 3 months of the pandemic. And to kind of expand on that, some more articles that I found that about a third of people have advanced medical directives. And I guess one way to look at that is that that's great. We have a third, but we also have 2/3 of older adults that do not have these advanced directives. And at very least in this poll of 796,000 individuals, so 2/3 of those did not have these. Another one from the AARP pretty much found out that even the pandemic wasn't necessarily helping people make a advanced care planning essentially for our older populations. So obviously, anecdotally and seeing it from articles, we have a lot of work to do with regards to discussing this important topic with our patients. That is in particular is those who are over 65. So some definitions. An advanced directive is the document that pretty much has like the living will, power of attorney. It's legal document. So pretty much it just tells us what kind of treatments the patient may or may not want to receive in a medical emergency, and then who would be the surrogate and decision maker if they're not able to make that decision. And in the hospital, we have a POLST, which is kind of an adjunct to it, and it just kind of helps determine, pretty much at the end of life, are they wanting, like in terms of feedings, in terms of how comfortable they want to be, whether they want intubation or not as well. Some other definitions as well, code status, pretty much what interventions you want the patient wants to have. So if you're full code, you want all treatment, which includes medications, compressions, defibrillation, intubation. Being no code pretty much means you don't want any of these heroic or aggressive measures. And limited code, which can be a little bit confusing, a little bit more difficult. Sometimes it's kind of like they want one or they want the other. Sometimes they want medications only, or they only want compressions, but they don't want intubation, or vice versa. So pretty much the goal of my study was kind of like, how do we improve the patient's awareness of these options for them? How can we find out how they're making these decisions for them? And then how do we improve us as providers? How do we improve this discussion with our patients? Because it can be kind of difficult to have with them, either language barrier or just difficult kind of conversation to have with them. So the way I did this is I got the patients that are 65 and older in my panel. Some of us kind of share some patients, but the ones that are under my name, I had 21 patients of these. And then of these, their average age was approximately 72. I have 12 females and 9 males of these patients. Unfortunately, I was only able to get 11 of them to actually help participate and have this kind of conversation with them. And so pretty much qualifying criteria, they had to be over 65, they had to be in my panel. And I kind of thought of 6 questions to ask them in regards to like what their thoughts are originally about advanced care planning. And I'll show those in a second. And after I had these questions with them, I tried to schedule an inpatient appointment to kind of discuss this with them. And also try to encourage them to have family members with them if possible. And that's because of advanced directive purposes. It's good to have some witnesses to also sign these documents as well. And so it's actually the 5 wishes document. So that was also used to help facilitate this discussion. And I'll go over that as well. So my questionnaire pretty much asked them very simply, do you even know what an advanced directive is? And if so, have you filled one out? Have you thought about or discussed with your family about advanced care planning? Why or why haven't you not had this conversation? And how do you feel about talking about it? And do you have 2 individuals that you can bring for your witnesses? So this might be a little tiny. Oh, not yet. Okay, so of these, 82%, so 9 of my 11 participants did not know what an advanced directive was. Of these individuals, they were all very interested and very encouraged to actually start talking about this. Only 2 of them actually knew what it was. I only had 1 patient of mine that actually had one. They just need to bring it in. So it's very small, but I'm trying to highlight some of the things, but pretty much, well, kind of the stuff that we went over. Some people just forgot. They've talked about it a little bit here and here. They casually had this conversation. Some people just do not want to talk about this whatsoever. I think a lot of times you'll find out that people just think when you have these kind of conversations with them, they think like, what's going on? Like, am I dying? Essentially. And I'm asking them this in an outpatient setting and they already think that something's wrong because I'm having this conversation. And that goes for either patients or their caretakers as well. So some of the things that I was kind of hearing, like I said, was, they would not have the conversation because it was in God's hands. Or sometimes they would say, oh, I don't want to have any aggressive measures because I don't want to be a vegetable. They'll be talking about their mother and say like, oh, they thought about dying, but they don't want to talk about it. It's taboo. And I had one patient tell me that, he kind of sometimes just ignores it a little bit and just thinks that, he going to go on living like forever and he never thinks like he's going to die. And so some people just kind of like ignorance and bliss a little bit about it. So in terms of how advanced directive, in terms of advanced care planning goes, you complete an advanced directive, you can update it, you can change it anytime you want to. And then once you go into a hospital because of any illness, you can complete a pulse form at this time. And then you can update the pulse form at any time as well. And then you go about honoring the wishes at that time. So this is the document that I used to kind of help guide and facilitate this. The 5 wishes was very, very helpful. Initially, I thought about trying to make some sort of a script on my own, but this essentially had everything in there. The 5 wishes include who is the person that you want to make the decisions for you, the kind of treatment that you want or don't want, how comfortable that they want to be, and how I want people to treat them, and what I want my loved ones to know. And amongst these 5 wishes, the first 2 are the legally binding ones. They're the part of the advanced directive itself. And so this just kind of goes over what each one of them means. But like I said, the first 2 are who's the medical decision maker, and then the second one is what kind of treatment they want in terms of when they're hospitalized. And this is the pulse form that we've kind of all seen over here, essentially what kind of interventions we want and so forth. It's supposed to supplement our code status and advanced care planning, and I'm sorry, and an advanced directive as well. And so there's also this website as well, just to kind of give you guys some more information that kind of helps to start talking to our patients about advanced care planning, so they can help you make an advanced directive, keep a record of it, like having all the information in terms of like what medications you have, and who are the ones that are supposed to help you with the decisions if you're not able to make it as well. And so additionally, some of the things I also found out is once you're over 65 per Medicare, you can actually bill and code for advanced care planning. For under the diagnosis, you would just type in advanced care planning, and then the CPT codes would come out for it. And so we're allowed to have an appointment. Our first appointment's 30 minutes. You can have the discussion with them about it, and then after that, you can have an additional 30 minutes afterwards if you're wanting to actually like fill out any paperwork or make any changes to any actually paperwork that you do have itself. So those are the codes. So pretty much. To conclude with mine, I think overall, I only had 11 individuals, but just knowing that there's 9 of them that did not know about advanced care planning and actually having discussions with these patients in the clinic, they truly do not know in terms of like what the process is. And I think it's important that, in the future we find some way to better facilitate this discussion with them. Obviously, the 5 wishes form is a very good way to do it, and pretty much highlights all the important topics that we need to cover with our patients. I think this is very important, obviously, in the state that we were in a pandemic itself, but I think it's important for normal, even before we get to the hospital as well. And so I guess, so these are my references, but to kind of highlight a little bit more, like, not only do we need to find a way to have a better discussion with them, but I think in terms of me and this project and what I'm hoping for in the future, I'm hoping that we can, how do we find a way to actually have these discussions? How do we make appointments with patients just to discuss this? Because this was just something I kind of did like on my own time, and then I would schedule some appointments. So how do we incorporate this into our clinic and into our practices? But yeah, that's it. Yes, Dr. Idris.
That conversation with people younger than 65, let's say 30s, 40s, they have the same attitude.
So, I guess for me, in my experience, I guess when I've admitted these patients, this is like the one time that you have these conversations because you have to, but not in terms of my clinic itself. I haven't had that discussion with them. I think for the purposes, it's just like over 65 was that kind of cutoff number for our senior patients.
Just seeing that if they hear the conversation at younger age, as this is a conversation to have with your doctors, go out and have a car accident.
I agree.
But by the time they're 65, they're more open to having the conversation for real.
No, I agree. I think some of us have encountered like very young patients, like in their 30s, who don't want any heroic measures done, at least when we see them hospitalized. But yeah, I think that's one way of expanding on this project is, after 65, you get your over 50, and then after that, you're over 30 and so forth.
Around the specific topic between the ages of 85. Okay. Thank you.
Now I just think.
Hi, everyone. I'm Tamoris Mateen. I'm a PGY1 intern at Adventist Health in Hanford, California. For those of you that don't know where Hanford is, it is in Central California. Today, I'm going to be speaking on a rare case of Birt-Hogg-Debay syndrome. Thank you. Very happy to be here. Financial disclosures. I have no financial disclosures or relations to disclose. These are my objectives. Take a minute to look at them. Okay, so abstract. Birt-Hogg-Debay syndrome. For the sake of this presentation, this case report, I'm going to say BHDS a lot because it's a bit of a tongue twister. It's a rare autosomal dominant inherited disease. It comes in a form of triads. It doesn't have to be in a triad, but it's seen in a triad at times. Skin tumors, pulmonary cysts associated with spontaneous pneumothoraces, and renal masses that can lead to renal cell cancers. BHDS is a germline mutation. It's due to the follicular code gene on the FLCN gene. It's approximately seen on 600 families so far worldwide, and it's not in relation to any ethnicity or race. Introduction. It was discovered in 1975 by Dr. Hornstein and Nickenberg. However, unfortunately, Dr. Birt, Dr. Hogg, and Dr. Debay wrote a paper 2 years later, and they got the notoriety. So the big issue with BHDS is there's a delay in establishing the correct diagnosis, and I'm going to touch base on that later. Different specialists treat different clinical features of this disease, and that leads to also a delay and leading to a delay in diagnosis of BHDS. And the common presentation of Birt-Hogg-Debay syndrome is a spontaneous pneumothorax. So my case is a 47-year-old patient that was admitted to the family medicine team at Adventist Hanford, which I managed the patient from admission to discharge with my team. She's again, 47-year-old female. She came to the ED complaining of shortness of breath for 2 days. Prior to that, she had gone and seen her primary care doctor. And when she'd seen him, he did a chest x-ray. By the time the chest x-ray came back, it was about a day and a half later that confirmed that she actually did have a pneumothorax, and she complained of having a rattling noise and shortness of breath. So her primary care sent her into the hospital. She was admitted under the team. We on the ED repeat chest x-rays were taken, and repeat chest x-rays did in fact confirm a 30% pneumothorax on the left side. So a little past history on her, past medical history. She does have hypothyroidism. She is status post thyroidectomy in 1997 and secondary to a papillary thyroid cancer. She had 2 right-sided pneumothoraces back in 2014, which she received a paradesis of the right lung for. Outside that, family history, colon cancer in uncle and aunt, parents, diabetes type 2, both. She's not a smoker, no drug use, and no alcohol use. I just want to take a minute and let you know her BMI is actually around 31. So she's not your skinny, average, tall woman that you would expect to see a pneumothorax with, and no recent travel history. Review of system, she complained of having a shortness of breath. On physical exam, there was diminished breath sounds on the left lung, and there was actually a chest tube placed when we saw her in the ED. Vitals, they were stable. She was placed on 2 liters oxygen. She was sitting at 98%. Lab, CBC, CNP, unremarkable. On imaging, I mentioned earlier, 30% left pneumothorax. They did a chest CT also on her. The chest CT showed bilateral multiple cysts within the lower lobes of the lung field and moderate left pneumothorax. So here's an image of the chest x-ray that you could see the pneumothorax on the left side and the CT also. There were also blebs in the CT. It's a little hard to see in this image. BELP, sorry. Okay, hospital course. So patient required pigtails in the ED. Again, she was admitted under the family medicine team. Pulmonary was consulted. They recommended VATS and left pleurodesis. CT surgery was consulted. VATS, a resection of the lingua, was completed with left lower lobe wedge resection and left lower lobe the left lower lobe segment. Patient tolerated the procedure well. Chest tube was placed again and pleurodesis was completed.
Surgery reported findings of spontaneous pneumothorax with multiple bullae noted in the lingula of the left lung and of the left lower lobe of the lung. Post-op chest X-rays series were completed that demonstrated resolution of the pneumothorax. Patient was discharged home and she was stable on discharge. So our main differential for this patient was Birt-Hogg debase. And this was done after further questioning the patient, understanding that multiple family members of hers actually had the same issue of the spontaneous pneumothorax. And multiple family members of her were actually being worked up for BHDS. So we recommended for her to follow up with a geneticist in City of Angels for further examination of mutation on the FLCN gene to confirm the diagnosis of BHDS. Discussion? Oh, I don't know what happened to the slide. Sorry about that. BHDS, again, rare autosomal inherited disease. It comes in the form of triad, skin lesions, lung cysts, and renal tumors. It's the mutation on the FLCN gene that's found on chromosome 17p11.2, known as the tumor suppressor gene. And not all three triads need to be present for the diagnosis to be made. And our patient actually, back in 2014, when she had her right lung pneumothorax, this was done at a top 10 university program where she was seen for it, and the diagnosis was missed until we saw her in 2020. And this is a common thing with BHDS because it presents in a triad or one of the two triads, and it's not well known. It leads to underdiagnosis of it and a big time frame. The earliest BHDS has been diagnosed has been 2 years, and it goes upwards of 14 to 15 years. So our patient, 2014 to 2022, you guys can do the calculations, a few years there. Most common presentation of BHDS, the lung cyst. 80% of the patients have this. That leads to the pneumothorax. CT imaging is the most recommended imaging to look at the lung cyst to be able to differentiate if the pneumothorax was secondary to the lung cyst. And in order to reduce the spontaneity of the pneumothorax to reoccur, pleurodesis is recommended. Discussion in regards to skin manifestation. Here we have our skin manifestation of, on the right image, you could see fibrofolliculomas, trichodiscomas, and on the bottom image, you could see acrocodons. The fibrofolliculomas occur in the age of 20 years old. It's actually becoming a little bit more popular in the derm world, where when they see patients with fibrofolliculomas, they are actually very concerned that this could lead to different manifestations of BHDS. And they do recommend further follow-up with renal imaging. And the acrocodons you could see down there too on the neck, where they're a form of skin tags. And the treatment for this is ablation. For a renal cell, renal issues with this patient, our third triad of this is renal tumors that are found on the kidneys. These renal tumors can eventually lead to renal cell cancers. 6.5 to 34% of our patients can develop with renal cancer if having these renal tumors. So it's recommended that they get annual MRI surveillance with these tumors. And if the patient's tumor is greater than 3 centimeters, it's actually recommended to get nephron sparing surgeries. And if it's smaller, we're going to continue evaluating the patient. My healthcare disparities and my DEIs. Unfortunately, more times than not, this disease does go underdiagnosed. As primary care physicians, being able to identify BHDS will have life-saving effects. Timely diagnosis can lead to better patient outcome. And in Central Valley, where we practice, we have an increased rate of patients being in middle-aged and elderly migrant populations. If we can diagnose this disease at an earlier rate, we could prevent renal cell issues that can lead to renal cell cancers. Go ahead.
Average age at presentation.
So average age in regards to skin presentations is about 20 years old. The pneumothoraces is around 40 to 45 mid-age. And then with the renal tumors, they come about mid-age to a little elderly age. Around 40 to 50 is where you see the renal tumors, and around 50 to 60, they can progress to cancer. Conclusion, BHDS is a rare autosomal genetic disease seen on the FLCN gene. It comes in a form of triad, but does not always have to be presented in the form of triad. Pneumothorax is the most common manifestation. The diagnosis can be confirmed with genetic testing, and early diagnosis can have life-saving impact. These are my references. Sure. Go ahead.
Population, how far back could you go back in terms of the history with the family?
With the family, I don't have a specific answer to that. I know it was discovered in 1975. So, yeah, but this case, this one was her aunts that actually had it and her cousins that had it too. Yes, so 2 generations. Go ahead.
So would you do some more extensive workup for any young person that presents with?
Yes. Yes. Well, if there is no other, if she has no other risk factors and we don't know, then this is definitely extensive. We do definitely do extensive workup for this. But part of the extensive workup is getting a detailed family history and seeing if there is any prior history of this happening to anyone else, seeing if the patient had any prior pneumothoraces. And if you're still thinking this could be the case, you could definitely do gene testing to see if there's a mutation on the FLCN gene. Go ahead.
HDS, once you go ahead and make the diagnosis, I was intrigued by the fact that usually you figure out pulmonary cysts, and that's probably incidental in nature that you find this on X-ray or such.
On CTs, yes. It could be incidental, but most of the patients that get the CT after the pneumothorax, they link the pneumothorax to the pulmonary cyst.
Subsequently, you go ahead and screen these people for renal cell carcinoma. Is it recommended that you image them once a year or what?
Yes, that's a great question. It just depends on the size of the renal tumor. If it's recommended that you do anyone that's diagnosed with BHDS annually to screen for the renal tumors. But if the size is greater than 3 centimeters, then you're going to an event and have a procedure done, surgery done for that. But if you're sitting at 2.5 centimeters or 2.8, then you'll go ahead and probably do a biannual screening with an MRI.
Thank you.
Go. Another one? Go ahead. None? Okay, done. All right, great.
My research project was on creating a curriculum. I worked alongside Dr. Jen Cunningham and Dr. Jim. The reason for my project is that due to the recent social events such as the Floyd, Ahmaud Arbery, and Taylor, disparities in our society have occurred, especially in healthcare and how certain social economic groups, ethnic groups face adverse health outcomes. I wanted to be able to create a curriculum that allowed us to be socially aware of our part in closing the gap. So, as you all know, this is Reverend Martin Jr. And this quote, which I found very pertinent in this presentation, is the one where he says, of all the forms of injustice in healthcare is the shocking. Racism results from generational trauma and poverty, which unfortunately is linked to higher rates of illness and death in our Black and Brown communities. The trauma of this racism adds to the historical injustice that have disproportionately faced our communities of color. For example, in terms of life expectancy, a study in 2014 showed that Black males and females have lower life expectancies compared to their white counterparts. This corrected for factors such as education and socioeconomic status. In terms of higher blood pressure, in the same study between 2013 and 2014, 42.4% of Black males had high blood pressure compared to 30.2% in white males. And during the same period, 44% of Black women also had the same condition compared to 28% of white women. So, some factors that may contribute to adverse health outcomes in our communities of color include implicit bias, which are basically biases that are subconscious that causes people to act in certain ways that they don't even realize, which then result to adverse outcomes. It's present in all facets of life and it is subconscious. So even if you may not think that you have implicit bias, we all do. So in a study in 2016 by the University of Virginia School of Medicine, this study was published in the journal called The Proceedings of the National Academy of Sciences, basically studied residents and medical students' perception of biological differences between Blacks and whites. In this study, they were given true and false statements where they had to guess whether it was true or false, saying that Black people experience less pain. That is false. Everyone experiences pain the same. However, this study showed that more than 50% of the people that participated in the study believed that Black people experienced less pain than their white counterparts and had different nerve endings that allowed them to feel less pain. And then the second half, they were given clinical cases, and 20% of the people who believed that Black people experience less pain gave inaccurate medical advice. How does that translate? Well, these same people, these are up and coming medical professionals. Granted, the study was done 6 years ago. These are people that are going to be in practice, and if they believe that certain ethnic groups experience things differently, they're less likely to give the adequate treatment, whether that's pain or medication for long-term conditions. So my project, the goal was to create a curriculum that addressed especially the implicit biases in medicine and how to address them to help with patient care. The ultimate goal is justice. So there's equality where everyone receives the same support and benefits, which, as you can see in this first depiction, there's still a disadvantage here. The next step would be equity, which is everyone gets the support that they need to be able to reap the benefits. So as you can see, our shorter individual gets a little bit more help, and then our medium individual gets enough help, enough to where they all have the same view. But the ultimate goal is justice, where we dismantle all of the factors that contribute to inequality, taking them down so that everyone can enjoy. So the methods for my study, initially it was a survey to assess the potential gaps in knowledge as far as the healthcare disparities, and then lectures that were given over the span of 6 to 8 months to address these disparities, and then a survey at the end to see how much the knowledge had improved from prior. So as I said, the initial survey was measuring knowledge and comfortability discussing disparities in medicine. So as far as the initial study, so 67% of residents completed this study, and it was evenly distributed between the PGY1, PGY2, and PGY3 classes, about 30%. And the demographics, so the majority of the residents in this program identify as white European, followed by Middle Eastern, Asian, Latinx, and then African American. So for our first question was, I have been on the receiving end of discrimination in the fields of medicine. Majority said no, about almost 60%, compared to the 42% that have said yes, they have been on the receiving end of discrimination. The next question in our survey was, I feel like my work environment is supportive towards people of color. About 50% preferred not to say. 40% said yes, they feel that the work environment is supportive, followed by 13% that said no, they feel that their work environment is not supportive. The next question was, I feel comfortable discussing racial inequality in healthcare with my peers. So 60%, a good amount, said that they do feel comfortable, followed by 30% that say they don't have enough experience to say whether or not they would feel comfortable, followed by about 7% of individuals that said no. Lastly, the question was, my institution is genuinely committed to improve relations between people of different ethnic groups. About 30% said yes, 20% said no, and 53% said not enough experience to say. Granted, this was given at the beginning before any of the lectures were given. So like I stated previously, lectures were given within the span of 8 months with 1 to 2 months between lectures. Some examples of presentations given were Making All Lives Matter in Medicine, which really focused on health disparities in medicine specifically and how that affects the outcomes of our disadvantaged groups long term. Another one was Health Disparities in Maternal Care. For those who don't know, women that are of lower socioeconomic class and racial minorities experience 3 to 4 times more adverse outcomes compared to their white counterparts. So that lecture was given knowledge to the residents on how so, as I stated previously, lectures were given within the span of 8 months, with 1 to 2 months between lectures. Some lectures focused more on implicit biases, others focused more on just general knowledge as far as the disadvantage between our communities of color, and others were more focused, such as our lecture here on health disparities in maternal care, which focused solely on showing how our communities of color have adverse outcomes, especially when it comes to childbirth. So after the string of lectures were given, there was a post-lecture questionnaire, which was given to assess the growth of knowledge and how prevalent these healthcare disparities are and how they affect healthcare. So for our first question, I feel like my work environment is supportive towards people of color. 40% of individuals said yes in our study before the lectures were administered. That was increased by 30% to almost 70% of people saying that yes, they feel like their work environment is supportive towards people of color. The almost 50% that say they prefer not to say was reduced to almost 10%. And then for the people that said no, they believe that their work environment is not supportive, that did slightly increase to 25% of people saying no. For our next question, I feel comfortable discussing racial inequality in healthcare with peers. Previously, 60% of people who took the survey felt comfortable, 33% said they did not feel comfortable saying with the lack of experience, and 7% said no. That was increased to 100% of people saying that they felt comfortable discussing racial inequality with their peers. For our question, my institution is genuinely committed to improve relations between people of different ethnic groups. So 26% said yes, 20% said no, 53%, little more than half, said that they did not have enough experience to say. In our post-lecture survey, our yes was increased to 45%, saying that they feel that the institution is genuinely committed to improve relations. The not enough experience to say was reduced to a little less than 20%, and our no was increased a little bit to 36%. So for this question that was given solely post-lectures, do you find lectures on healthcare disparities and implicit bias help to improve your practice? About 81% said yes, they felt that it did. And my experiences since coming to this institution have made me understand more about the ethnic differences and how to navigate them. About 80% said yes. So ways to improve on this project is teamwork. Instead of having one person, there could be a cohort, so one person per class, to create a cultural competency class group where lectures are given once every month, maybe once every 2 weeks, so that it doesn't all fall on one person on different topics. Having a journal club as well with articles such as these that talk about disparities in the physician workforce and with patient care, but also having clinical cases where we have cases that we work through that talk about biases in medicine and how to tackle them, because a lot of people are aware that there are disparities in medicine, but taking it to the next step as far as figuring out tangible ways to improve, become more self-aware. So some limitations is that there was only one person, myself, doing these lectures. I think going forward, if this were to be a curriculum that is adopted, it could have one person per class creating a group so that the lectures can be more consistent, whether that's every 2 weeks to every month consistently, as well as adopting a journal club where we can discuss articles such as these on the right that talk about diversity in the physician workforce, implicit biases, talking more about statistics as far as adverse health outcomes in our marginalized communities. Also having a clinical case workshop where we can discuss clinical cases that have actually occurred, talking about where implicit biases may have arisen, and discussing ways to tackle that going forward if this is something that were to happen to our practice. I find that a lot of people are aware of the healthcare disparities that marginalized and our minority communities face, especially with all of the news outlets and social media, like I said previously. But the next step is coming up with tangible ways to combat this to improve patient care. And that concludes my presentation. Thank you.
More things. Hi, I'm Maria Teresa Sanchez.
And I'm Dacia Ortega.
Yeah. And today we're going to talk about an educational tool to improve diabetes self-care and management. So, as you guys all know, diabetes among U.S. adults has been steadily increasing since 1999. Adults in the U.S. with less than a high school education were 1, more likely to be diagnosed with diabetes, and 2, were less likely to use preventative care practices. That includes the annual foot exam, eye exam, hemoglobin A1C testing, and self-care education. So this is from the CDC. We kind of reviewed some data, and it looks like in 2018, Hispanics were 1.3 times more likely than non-Hispanic whites to die from diabetes. In addition, Hispanic adults are 70% more likely than non-Hispanic white adults to be diagnosed with diabetes by a physician. In 2017, Hispanics were twice as likely to be hospitalized for treatment of end-stage renal disease related to diabetes than non-Hispanic whites. In addition, Hispanics were 1.5 times more likely to have a vision impairment related to diabetes than non-Hispanic whites. So as you know, there's a lot of barriers to improve diabetes outcomes, one of which is the healthcare systems. So healthcare systems in general are driven by volume, designed for fee-for-service reimbursement, have limited allocated office visit time, and limited access to PCP. In addition, the other barriers for diabetes care is language barriers, limited educational background, cultural-based dietary habits, religion, health, and illness views, access to diabetes education and classes, hurdles to healthy food access, such as costs, quality, transportation if you're living in a food desert. So typically, a diabetes appointment is about 15 minutes every 3 to 6 months. And during that time, you have to pretty much tackle quite a bit. So some of the things you do during that 15-minute time slot is you access and examine the patient's physical health, You review relevant labs such as hemoglobin A1C, lipid panel, CBC, CMP, urine microalbumin, creatinine. You also want to confirm that the patient's up to date on vaccinations, annual foot exam, eye exam, review any documentations from their specialist. You want to discuss their home glucose values if they're taking it. You want to review the medications, adherence, and adverse effects. And then lastly, if you have time, you do want to provide some health promotion and preventative education. But of course, that's if you have time. And then you want to document all relevant data into the EMR. So really, how much time do you think the PCP is allocating to diabetes self-management education, diabetes self-management support, and diabetes medical nutrition therapy? So that's how we decided to kind of go about establishing our goals for this project. What we realized is we had, Daisha and I had a lot of patients with diabetes, and we had very little time to actually talk to them about their, what is diabetes and explain things to them, and also go through the jargon as well as nutritional information. So we decided to design a booklet, and we'll pass those out right now. But that's to provide extensive diabetes education and encourage health promotion and empowerment through the following measures. We wanted to discuss the pathophysiology of diabetes, the associated complications, the current medications, and the impact on mental health. We wanted to increase teaching time of the diabetes language jargon. We wanted to provide nutritional information and recommendations, demonstrate how to read a food label and count carbs, discuss the benefits and goals of physical activity, highlight the importance of vaccinations and screening exams, and also provide a logbook for personal medical records. So what we found is a lot, especially because most of our residency, the COVID pandemic has been really impacting our patients. A lot of the diabetes education classes weren't being offered, or you had to have a computer to access them. So we decided to try to kind of help our patients with their diabetes education by providing some education ourselves and having them come in specifically just for this education. So this is the educational tool. We'll go ahead and pass that out. So you'll see in that booklet, we had education on type 2 diabetes, the medications, methods to achieve a healthy diet, exercise goals, and the effects of diabetes on mental health. We also had this personal record. And basically, that had a section for past hemoglobin A1C values, the dates of relevant vaccinations, the last foot and eye exams, and then home blood pressure, sugars, and home blood pressure, and also home blood sugars. We specifically wrote this book at a 5th grade reading level. It's available in both English and Spanish, and we did use some grant money to print the booklets and offered it for free to our patients. So here's the cover. And then here you'll see that here it just talks about what is diabetes. We used some photos and simplified it to help explain it to our patients. We also put it in a food label, and it kind of explained what carbs are and how to, count their carbs and to understand what they're eating. And then lastly, here's a picture of just some information on medications they might be taking. Here's an example of the personal care record. So we had a 30-minute visit to go through the booklet. We spent most of the time just kind of explaining things, answering questions. We obtained a hemoglobin A1C prior to this visit, and then 3 to 6 months after, we got a second hemoglobin A1C to see if this intervention helped at all reduce their hemoglobin A1C. And then we we basically stratified our patients based on their diabetes status, which we'll discuss further. And then we did a paired t-test to compare pre and post hemoglobin A1C. So initially, using the pre-intervention hemoglobin A1C values, patients were divided to based on their diabetes status. So that's either uncontrolled or controlled. Well, what does that mean? It was based on patient factors, age, life expectancy, comorbidities, personal diabetes history, and diabetes severity. In general, the younger patients without the comorbidities, we had wanted tighter control. So a hemoglobin A1C less than 7 was considered controlled. And then for our elderly patients, those with more long, complex history, looser glycemic control with a hemoglobin between 7 and 8 was considered controlled. Then using the post-intervention hemoglobin A1C values, we further divided our patients, and I'll go through it. So either if they were controlled, did they remain controlled? Or if they're controlled, did they become uncontrolled? Then if they were initially uncontrolled, did they become controlled? If they were uncontrolled, did they improve but still weren't necessarily controlled or at goal? And then lastly, were they uncontrolled and did they get worse?
And for our results of our participants, and these are all A1Cs specific to the patient, we had 13% that were already controlled and remained controlled at the end of our intervention. 6% were controlled and then their A1C worsened to uncontrolled. 33%, the majority, were uncontrolled to start and actually had a more controlled at goal hemoglobin A1C. 27% were uncontrolled and had an improvement in their A1C, but still considered uncontrolled. And then we didn't actually have any that were uncontrolled that had a worsening A1C. And then this is the information I just mentioned in the first graph on the left. So the blue line is the pre-intervention, the green line is our post-intervention, and at the bottom we have the number of participants. And you can see basically the blue line pre-intervention and then their A1C after intervention. The graph on the right shows the average hemoglobin A1Cs pre and post-intervention, and we actually had a significant reduction in their A1Cs.
So in general, our intervention did have a positive outcome. Overall, 73% of patients experienced an improvement in their hemoglobin A1C. And as we followed them through our study, remained on target with their preventative screening. Many patients were very appreciative of our time, our education, and the handbook. So some limitations, we did lose some to follow up. So we had a pretty small sample size, just 14 patients. Time constraints. So even though we got the 30 minutes, it still didn't seem like it was enough. We could have definitely used more time to go through the booklet and answer questions. So compensation for visit. In general, for most insurances, they'll pay for one diabetes education visit for a year. So if we wanted to bring them back just for educational purposes, we would have to probably address something else. And then the frequent follow-up. So because it required lab work before and then 3 to 6 months after, as well as the visit for education, it did require several visits, and that was limiting. And then lastly, medication changes. In general, we didn't change medications for the patients, but we didn't necessarily make it firm that we did not change medication, so that could have definitely impacted our results. And that's it. Thank you. Yeah.
Hello, I'm Dr. Molly Wilkerson. I'm a third-year family medicine resident at Glendale Adventist, and I'm going to be talking about my project, which is about improving family medicine residents' nursing home experiences through time slips creative techniques. Maybe not that button. Okay, so an overview of what I'm going to talk to you about. First, I'm going to do an introduction to give you a little bit of context and background for this presentation, then tell you exactly what time slips is, because I'm assuming most of you or all of you have never heard of it, and then go into the details of my project, the results, and then next steps. So a very, very brief overview of dementia. Generally, when we think of dementia, we think of loss of cognitive function. There's a great deal of focus on what is lost. In medicine, we have so many different ways to test people with dementia, to diagnose them, and to tell them, oh, you can't do this, and you can't do that, and you can't do that. And often what ends up happening is that we focus a great deal on what is lost and not what still remains. And this can actually be harmful to patients, contributing to isolation, contributing to stigma, and leaving people feeling like they're helpless. In response to this, many different groups and organizations have sort of come up with, what can we do? One of them was created by Dr. Ann Basting. She was actually a MacArthur Genius Grant Award winner. She is a theater professor in the University of Wisconsin, Milwaukee, and she created Time Slips, which is this creative engagement program
focused on how to better incorporate people with dementia into society through creative engagement. There have been many studies about the type of research that she does, and it's been shown that the time slips engagement programs have been associated with improved quality of life, as well as greater social connectedness in people with dementia. Time slips involves a great variety of things, and I just took one element and incorporated it into my project. So typical questions that I'm sure if you're in the medical field and you've ever encountered anybody with dementia that we love to ask them what year it is, what's your name, what's my name, what's your name. All of these questions rely on memory, and they have one correct answer. This can be very difficult if you have dementia. So in time slips, one component is this thing called beautiful questions. Some examples of a beautiful question include, what is something that brings you strength? What is a beautiful sound? What is something you could teach someone? What is something that brings you joy? These questions, as opposed to the questions that we typically ask people with dementia, rely on creativity as opposed to memory. And they have many possible answers, and they can be engaging to you even if you have dementia. So for my project, my objective was to see what effect incorporating one of the creative engagement time slips techniques, specifically the beautiful questions, into skilled nursing home patient visits has on family medicine residents at Adventist Health Glendale. What I specifically did was I took a study population of 15 second and third year Adventist Health Glendale family medicine residents from fall 2020 to spring of 2021. First, I did an introduction about time slips, a little bit more thorough than what I just did, told them about the various things, beautiful questions, and then I asked each resident, who every second and third year resident has at least 2 nursing home patients that they visit on a monthly basis. And so I asked them to ask their nursing home patients at least one of these beautiful questions during every visit. And then at the end of the academic year, I gave them an anonymous survey about the project and their experience to get some qualitative data about how they think it went. So results, 14 out of the 15 residents responded to the survey and 11 participated in the project. I'm very appreciative of the ones who didn't participate in the project but did fill out the survey. I appreciate the data. So I asked them if they didn't participate, why not? And the reasons were they either didn't have time during their visits, they didn't think it would help their patients, or almost all the ones who didn't participate said that their patients were nonverbal and so they didn't see the point. So the rest of the data is from the 11 who did participate. The first question I asked was, how do you think this project affected your nursing home patients? And 45% of them felt that it positively affected their patients. These are some of the answers that they gave. They said it allowed one of them to reflect a little bit about their life. They felt they were being given importance and time. One would just giggle, which I think is a positive, and one patient enjoyed talking about her answer. The other 55% of participants either had sort of like, it was sort of good, sort of neutral, or it was just completely neutral. Some things they said was that some days it was a happy response, some days it was a sad response, and then one person said they were unsure. Sometimes the patients would get confused, sometimes they'd get happy and smile and share a story. The next question I asked was, overall, what was your attitude toward seeing your SNF patients every single month prior to the project? And then how did you feel about it after the project? So I have looked at these graphs for extended amounts of time. So I will tell you that there is nothing worse than neutral, and the very positive and the positive don't change, but there was a slight change from the neutral group to the somewhat positive group. I asked a few other questions. 3 of the 11 who participated said that this project actually increased their interest in geriatrics. 55% of them overall said that they felt it had a positive effect on themselves, and 45% said it had a neutral effect. Nobody said they were harmed by the project. Some of the feedback that they gave was that the project gave them a different perspective. It reminded me to think more empathically about my SNF patients, and it helped me to have multiple approaches about my patients. I have more positive feedback. It felt good to connect with my patients on another level. I enjoyed having conversations with my patients outside of a medical context. I feel it created a better connection and allowed us to converse about other aspects of her life that are important to her and have a more personal connection to my patients, whereas before, visiting the nursing home patients was just another thing I had to do every month. So overall, most residents did participate, and most of those who participated felt that it had a positive effect on them. And many residents reported such things as improved empathy and also improved attitudes towards seeing SNF patients. And some even reported some increased interest in geriatrics. Discussion highlights. Overall, it was really well received. They said they had better connections with patients. They said they enjoyed having creative tools to use in their SNF visits. There were some limitations. The main limitation is that I knew all the people I was surveying. You'll notice there was no answer worse than neutral. There were no negative answers. The worst somebody said was, a neutral thing. It could be just because that's true. There's not a great deal of harm in, being kind of fun with your patients, but it also may be because they know me and they didn't want to hurt my feelings. Also, the other thing is that the data come from a retrospective survey done at the end of the project. For logistical reasons, I did not ask the residents at the beginning, what are your opinions about seeing SNF patients and about geriatrics? And then again at the end, I didn't do that because just honestly, I didn't think I would get them to do 2 surveys. And so I just did one at the end. Next step, so I will be staying on as faculty at Adventist Health Glendale, and so my plan is to continue to encourage incorporation of creative techniques, time slips, and other strategies that the future classes can use both with patients with dementia, nursing home patients, and just patients in general. I had originally hoped to do group activities as my project, and then the pandemic happened. So hopefully the pandemic is getting better, and maybe in the future we'll be able to do some other aspects of time slips and group activities with people with dementia, COVID allowing. And then Glendale also has a senior program called Live Well that we may be able to get involved with as well. And then for all of you, if you have any personal or professional interests in learning more about creative engagement to use with people with dementia or just people who are socially isolated, I would highly recommend going to timeslips.org. There's a whole lot more than just beautiful questions, and I recommend you check it out. Thank you.
Adventist Health Glendale Nursing. Jenny is the Chief Nursing Officer at Adventist Health Glendale, and Heidi is the Cath Lab Charge Nurse.
Thank you. Good afternoon. My name is Heidi Ziegler, and I'm a clinical nurse in the Cath Lab at Adventist Health Glendale. I'd like to start off by recognizing our entire research team. I have Ms. Jinhee Nguyen, Patient Care Executive and CNO, Marnie Dodson, Interim Magnet Program Director, Sarin Kurdian, who is our Magnet Program Manager, and Dr. Catherine Brewer, who's the Associate Professor at Towson University in Maryland. Our first nursing research study is titled Relationships of Organizational Factors with Nurse Well-Being Among Nurses Practicing in a Faith-Based Hospital. The COVID-19 pandemic has exacerbated the already fragile state of clinician well-being, resulting in a wave of resignations and turnover among nurses. This reality has intensified the need for research to mitigate this problem among health systems. Burnout is a big threat to hospital operations, as it can negatively impact workforce stability, retention, and collective competency level. Downstream, the workforce issues lead to detriments of patient care quality and satisfaction. But beyond the operational aspects, the overall health, which includes the physical, emotional, and spiritual domains of the individual clinician, is at risk. As highlighted by the death of Dr. Lorna Breen in 2020, the clinician suicide stemming from workplace stress is a real concern. Though much of the literature has focused on the negative aspects of clinician well-being, such as burnout, there are positive manifestations of well-being. These manifestations, including compassion satisfaction, are the increasing area of focus of descriptive and intervention research. This offers positive slant for research. A research gap exists for studies on the aspects of organizational culture. These aspects, such as leadership and perception of organizational mission, may also relate to clinician well-being and create more holistic conceptual framework of studying it. This is an area for research exploration and can offer evidence towards systems interventions which can stem the tide of burnout and resignations. Our aim was to examine relationships among the organizational factors and the nurse well-being factor. Consistent with the socio-ecological framework, relationships are thought to exist between environment in which nurses practice and their overall emotional workplace well-being. Certainly, there are individual factors that influence well-being, such as family life and personality. However, the organization is also a likely factor and one that is underexplored thus far in the literature. To achieve our study aim, we develop a cross-sectional correlational study to measure key study variables, including organizational culture, leadership, and professional quality of life. We conducted an online survey among registered nurses working at Adventist Health Glendale. The survey was conducted over 3 weeks in January 2022. We selected registered nurses as the target population because of the recognized relationship between nurses and their work environment and employers, as articulated in the Code of Ethics for Nurses. We used several validated instruments to collect data. These included the Authentic Leadership Questionnaire and the Professional Quality of Life Scale. The Authentic Leadership Questionnaire measures certain behaviors of leaders, including moral authority and transparency. In this study, Authentic Leadership Questionnaire scores were used as independent variables. The Professional Quality of Life Scale measures certain aspects of emotional well-being and connectedness, including burnout, compassion satisfaction, and secondary traumatic stress. We use pro-QOL scores as outcomes measures for the study. Both these scales are used extensively in the literature. We achieve good reliability for the scales in the study. Organizational culture and values were measured using single item reflecting organizational culture. For all scales and single questions, higher scores indicated higher likelihood of the trait. Pro-QOL cut scores are published, giving us a little more description of what the scores mean in terms of well-being, that is high, moderate, and low levels of the trait. In our analysis, we did use each scale as continuous measure for statistical analysis. However, we reported the pro-QOL cut scores for clearer description of well-being among our sample. Now I would like to introduce Jinhee Nguyen, who will discuss the findings of the study.
Thank you, Heidi. So I'd like to go over our findings, starting with nurse well-being. We had 147 responses to the survey, and of those, majority were female, more than 10 years of experience, and were in direct care role. There are a fair number of fair racial diversity in our group, 43% white, 25% Asian, 1.4% Black, with 13.6 indicating other, and the mean age was around 43. On our well-being outcomes measures, the means, the percentages within low, moderate, high categories are seen on this table below on the slide. The majority of nurses in our sample had high level of compassion satisfaction, and almost all had moderate or high level. Only 2% had experienced very low level. For negative well-being, burnout, and the secondary traumatic stress, almost half of all nurses had low level, only 2 had high level. So what this says to us is that when compared to some of the other published studies, our means and category distributions were higher for compassion satisfaction and lower for burnout and secondary traumatic stress. So next, we used Pearson's correlation analysis to determine the association among organization culture characteristics and nurse well-being outcomes for both the full Authentic Leadership Questionnaire scales and the 4 subscales were used: transparency, moral ethical behavior, balanced processing, and self-awareness. We found a significant small correlation among most of the study variables, including subscales of the authentic leadership and overall perceived organizational mission. Consistent with the conceptual framework, that there were negative association with the leadership and organizational factors with burnout and secondary traumatic stress. meaning the higher the leadership score, the lower the burnout and the stress scores. On a theoretical level, this explained to us that compassion satisfaction had directional relationship with organizational measures. Finally, we used multiple linear regression model to further identify predictive associations among variables. The total authentic leadership questionnaire scores and organizational mission scores were used as predictors, as well as any significant demographic factors impacting the outcomes variables. Separate models were conducted for each aspect of well-being measured by professional quality of life scales. From our study, we found that authentic leadership was not a significant predictor of any of the aspects of well-being, though it was included in the same multivariate model as an organization culture. However, organizational culture was a significant predictor, showing significant relationship with burnout and compassion satisfaction. These relationships indicate higher level of perceived organizational culture predicted less burnout and more compassionate satisfaction. So in summary, some takeaways from our study are that indications that organizational culture related to burnout and compassion satisfaction in our study. Our study indicates that the organizations promoting an ethical and authentic culture, one where employees sense and experience the mission being lived out, might deal with less burnout and greater work engagement. Leadership is likely a contributor to well-being as well, although authentic leadership was not a significant predictor in the multivariable model, that it was significant when associated with well-being in a bivariate analysis. Leadership is certainly an important part of our organizational culture, so efforts should continue to cultivate good leaders who can build and nourish organizational culture. We also noted that our study samples reported high level of compassion satisfaction and lower level of burnout and secondary traumatic stress as compared to other studies of nurses. This could mean that our faith-based organization could contribute to a lower level of negative well-being as well. So in conclusion, our study marks the very first nursing research study conducted at Adventist Health Glendale, where we are the first to measure well-being specifically among nurses working in a faith-based organization. And this opens the door for many exciting future studies to explore this relationship further. So I want to thank all of you for giving us the opportunity to share our findings. I want to also give a credit to our Magnet team and our nurses who participated in the study during the COVID surge in January. So it was remarkable to learn how our staff were behaving during this time. Thank you so much.
Okay, next we have Nicholas Garcia. Nick is from Azusa Pacific University, and he will be presenting on exploring the health beliefs of Hispanic men regarding CVD risk and their willingness to participate in health promotion behaviors or programs.
All right, hey guys. I actually just presented this last Friday and defended my dissertation, so I'm really just riding that high. Okay, so thank you so much, guys. So again, I did this exploring the health beliefs of Hispanic men regarding cardiovascular disease risk and their willingness to participate in health promotion programs. How did I come in contact with Adventist Health White Memorial? The Community Information Center, as well as the Boyle Heights Clinic, they offer a couple programs, living with diabetes, as well as a healthy eating lifestyle program called HELP that they offered to adults. The majority of the population here is Hispanic, obviously over 85% Hispanic, and they realized that they can't get Hispanic men to participate in these health promotion programs. So they said, help us design or help us make a more male-centric program, or help us with recruitment efforts. And I was like, okay, let's see what they have on recruitment efforts. So I did a little background and realized that Hispanic men are at a greater risk of cardiovascular disease risk compared to their female counterparts. Hispanic men are Hispanic men age 20 years of age and older are already affected by cardiovascular disease risk. And when I say that, I'm primarily speaking of atherosclerotic CVD, because there's PVD, peripheral vascular disease, stroke, other various forms of CVD. However, I'm primarily speaking of atherosclerotic CVD. So already more than 48% of Hispanic men 20 age and older are already affected in some way by CVD. There's an abundance of literature that advocates that generally culturally sensitive health promotion programs are effective in mitigating the CVD risk. However, when I reviewed the literature, I realized that there's an evident gender bias, that it's about greater than 70% female representation amongst those participants, even when there was concerted efforts to recruit males and females, equally. So this phenomenon, as I just kind of mentioned to you guys, is already manifesting here at Adventist Health White Memorial, and it's a problem because one, Medicare is about to run out in 2026, right? And two, we're largely a tertiary model, even though we don't want to admit that as a country. We're largely a tertiary model. We wait till you get sick, and then we treat you, as opposed to putting more emphasis on preventative measures. When there's 38 million Hispanics in California, 38 million residents in California, and almost half of those are Hispanic, this is going to be a problem, right? So this is going to be a problem when these men that aren't investing in these prevention programs, and then they all have this high prevalence of the metabolic risk factors that are highly predictive of CVD, like diabetes, like our colleagues just said, diabetes, high cholesterol, obesity, sedentary lifestyle. These are all highly predictive, and the more that you have, you're eventually going to meet metabolic syndrome, criteria. And so long story short, the background is 1 in every 6 healthcare dollars is being spent on CVD right now, and that's only getting worse, right? And so what we had to do was look to the literature to see if there's evidence-based practice recruitment practices to kind of apply here at Adventist Health White Memorial. Realize there's a paucity of literature as it pertains to addressing that issue. The literature is just not there. So what we do is, the first thing we do whenever we go into a community is first ask the community. So that really signaled the need for this first step of inquiry, which was, what do you believe as it pertains to cardiovascular disease risk? And I utilized the tenets of the health belief model to do this. I don't know if you're familiar with the health belief model. Well, first, let me just say that led to the step of inquiry, and that was merely to explore the health beliefs of Hispanic men as it pertains to cardiovascular disease risk, and compare that to those answers, or those responses, to that of women. And then, of course, this is one of the first projects to explore those health beliefs, to address the paucity that exists in the literature that advocates that generally these health promotion programs are effective in mitigating that cardiovascular disease risk. And that led to my PICO question, or my research question, which is, how do the health beliefs of Hispanic men regarding cardiovascular disease risk influence their willingness to participate in health promotion programs compared to that of women? So because there was such a paucity of literature, or such a lack of literature as it pertains to those evidence-based practices, or that literature that really was seeking to address that paucity of male participation in these programs, I had to utilize the lit review to really edify the need for my step of inquiry. And I asked, okay, well, first of all, can culturally sensitive health promotion lifestyle programs be effective in mitigating that risk? And then 2, is there a paucity of Hispanic males in this literature? And I wanted to ask that. Why? Because if females were at a greater risk for developing cardiovascular disease risk compared to males, well, then we should just let this trajectory ensue and just let the females get taken care of, because they're at a higher risk. But that wasn't the case at all. And let's see. And which aspects of health beliefs are effective motivators for moving people to action? Now, I asked that because I was utilizing the health belief model. So what I did was, I took the health belief model and really used that as a guide to establish do Hispanic men have augmented health beliefs as it pertains to the four major constructs of the model, which means they have a perception of susceptibility. Do they believe that they're susceptible to cardiovascular disease? 2, do they think that cardiovascular disease is severe if they did develop it? And 3, do they translate the benefits to engaging in these health promotion behaviors to be of greater value than the barriers that are keeping them from participating in those behaviors or programs? So those 4 major constructs are there, and I had to use the health belief model as a lens to see, okay, first let's establish, do men have augmented health beliefs similar to that of females? So I was able to establish that, and do they translate the benefits to outweigh the barriers? And if they were there, then I had to ask myself, well, why aren't they moving to action then? Because this model would say, it rests on the tenets that these health beliefs will potentiate someone to action. But if they're not there, then we can use further subconstructs such as cues to action. Cues to action, which are these external stimuli to kind of those people that are sitting on the edge going, yeah, I think I would participate. Yeah, I kind of feel like CVD is bad news if I do develop it. Well, if you already have those augmented health beliefs, let us help with external cues to action. So what I was able to do was take my data assessment tools. Well, I took my data assessment tools and I started to disaggregate individual items and run frequencies and really see where males and females differ as it pertains to health beliefs regarding cardiovascular disease risk. I used a purely descriptive study. It wasn't very sexy. It was very, I just went in. I didn't manipulate any variables. It was very appropriate. I use a convenient sampling. I said whoever would come, especially with the social distancing protocols, it ended up being phone interviews, which is really hard to do. Luckily, they allowed me to use an empty office here with the landline to make those calls. And of course, if you have cell phones and you're using a landline to call them, it usually pops up there as Adventist Health White Memorial, so they're more apt to take my calls, which was awesome. Also, I incentivized it a little bit by giving a $20 gift card to a local grocery store at Food for Less, as well as Vallarta's right here. And those are 2.5 miles away. So that really, and it being November, really helped because they wanted to get that turkey, right? So the inclusion criteria just, they just had to be 18 years old and older, Hispanic males or females, and have access to a phone. That's all I needed. Again, I use descriptive studies. I use descriptive statistics as well as frequencies, cross tabulations. I was also looking for correlational relationships between demographic information and health beliefs and willingness to participate, etc. So results overall, there was no statistical evidence right now, or no correlational relationship between the participants' current health beliefs and their willingness to participate. However, the study did demonstrate that Hispanic men within the sample had similarly augmented health beliefs as it pertains to cardiovascular disease risk that were on par with the females. And when disarticulated, when I took out those individual items, I was able to see that, oh yeah, you guys do have different ideas about cardiovascular disease risk compared to your female counterparts, which are going to be used for cues to action that hopefully we can implement in the very near future. So here's just a simple illustration of this is the perceived susceptibility to ZVD, perceived severity, perceived benefits over barriers, and so this was a 4-point Likert scale. So obviously it was strongly disagree to strongly agree. So any score greater than 2.5 was considered augmented, and anything closer to 3 or 4 was considered highly augmented, right? So as you can see, they even feel they're more susceptible to CVD than their female counterparts. That they have a perception of severity if they did do it. Develop it, as well as the benefits to engaging in those behaviors would far outweigh the barriers that are keeping them from that. All right, so then I was able to find out, I realized that, yeah, you guys do have augmented health beliefs, but you're still not moving to action like your female counterparts. So then I took out little, I disaggregated individual items on the health belief related to cardiovascular disease risk scale questionnaire, and I realized that men have a higher perception of susceptibility as it pertains to developing CVD in the near future compared to their female counterparts. They also had a little bit more of a perception of severity as it pertains to sexual health and the results of that due to a major cardiac event. And then, of course, they were able to identify that there was some sort of connection between diet and exercise and how that could mitigate, even though they didn't fully understand what that was. So also there was a positive Pearson's correlation between negative Pearson's correlations between lower levels of education and perception of susceptibility. So the lower educated felt they were more at risk. And then if I did cross tabulations and realized that those that were lower education were the foreign-born, primarily Spanish-speaking, which ended up being over 60% of my sample. So, you know, who do we start with? It might be too industrious to say, let's get all Hispanic males in general, but we might start to identify these high-risk individuals, which are the primarily English, Spanish-speaking, foreign-born residents. There was also a positive correlation between age and perceived susceptibility. This was beneficial because over 60%, 65% of my sample size were 45 years of age and older. So again, this is you know, things that money in the bank, things that we can use and readily use them to identify a population, a subsegment of that population, who to begin efforts on. And then, of course, the unexpected findings. I just want to touch on this because it's super important to kind of demonstrate that the males are denoted in blue and females in orange here, that over 60% were overweight or obese. Yet 60% do not consider themselves overweight or obese. So there's this disconnect. There's this knowledge deficit as it pertains to ideal weight. And man, I went down a rabbit hole on this thing because, you know, that starts in infancy where Latina mothers are, if you gave them a whole mess of photos and they were to identify which baby is of an ideal weight, they would almost always choose the overweight or obese baby. Mexico is the highest consumer of Coca-Cola in the world. You know, there's all these like different, like it's so multifactorial. It's so, there's so many variables that could explain this, but they grew up with this skewed self-image. Also, there's the ones that have more metabolic diseases, and if I put at least one metabolic disease, it would be over 60%. Yet, over 60%, almost over 70% consider themselves healthy. So again, there's this knowledge deficit as it pertains to what constitutes health, and we really have to drive that home. But the possibilities and recommendations. So how do we take these individual items and how do we augment fears ethically? How do we like amplify concern ethically? Well, one of those ways is to assign them an atherosclerotic CVD score, 10-year risk score. Now, it isn't the most accurate, especially as it pertains to Mexican and Mexican Americans. However, in a couple studies, I found that there was a positive correlation between a patient's awareness of ASCVD score and depressive symptoms. Not to say we're trying to elicit depression with this thing, but we are trying to augment health beliefs to be that external stimuli to say, hey, if you're on the fence about participating in that health promotion program, let me help you out by saying, here's a predictor about you having a major cardiac event in the next 10 years. You know, so assigning them that was a big deal. There was also another study that found amongst their participants that not only did they find a health checkup as being a positive experience, but they also interpreted that their ASCVD, even if they didn't know what it was, caused them to make life adjustments and behavior adjustments. And so I'm out of time. I want to respect you guys' time. There's a lot of healthcare market recruitment strategies that have to do with making things more male-centric, using simplified language, like some of our colleagues with that diabetic education guide, et cetera. And going out to the public, it was over 50% of my participants of the sample all attend a local church within 5 miles. You know, partnering with the local diocese and local faith-based groups and taking these efforts to them to recruit and say, hey, come get a health check with us. Let's do an ASCVD score. You don't need to fast. We'll just do a non-fasting lipid, $80 handheld device, take some anthropomorphic measures, and really augment your health beliefs. Obviously, there were strengths and weaknesses. Some of the strengths were, community engagement with Adventist Health, using them as a trusted leader in the community, addressing the gender bias that is so prevalent in the literature, and then adding new knowledge about health beliefs regarding men and cardiovascular disease risk perception. Some of the weaknesses obviously were the COVID-19 protocols, the social distancing. I wasn't allowed on the grounds for like a year. So it put a damper in my project. The single locale, obviously, so I can't really speak to generalizability. This is just a single locale with the convenient sampling. And that's pretty much it, guys. Yeah. Sorry, I'm sorry, guys. I know I went over like 4 minutes, 5 minutes, 10 minutes. All right.
Yeah.
We have one more. Now Dr. Kajani and Dr. Ma will be presenting on viral myocarditis in a COVID-19 patient. They'll be presenting a case report.
Hello again, everyone. Just waiting for the slides to come up, but appreciate all your time and waiting for us to do this last final presentation. All right, thank you guys for waiting. So my name is Rahul Kajani. I'm one of the third-year internal medicine residents here at White Memorial. I'm here today with Dr. Frank Ma. He's one of our first-year internal medicine residents. So today we're going to be discussing this viral myocarditis case in a COVID-19 patient that was done with Dr. Kiramijian. So just as an overview of our presentation, we're going to talk a little bit about viral myocarditis and COVID, go into the case, and then finish with our discussion and questions at that point. And so just starting off with our introduction, when we think of COVID-19, typically we think about the pulmonary manifestations, shortness of breath, multi-lobar pneumonia. But COVID, as we've come to learn over the past 2 years, can affect multiple systems in the body, including the heart. Some of the cardiological manifestations of COVID-19 include myocardial infarction, arrhythmias, as well as myocardial injury, like in a myocarditis. Although there's no definitive evidence yet of the SARS-CoV-2 virus causing viral myocarditis, there have been several cases that meet the criteria for clinically suspected myocarditis. And so we have one of those cases here. So just a little bit more background about COVID and viral myocarditis. As you can see, the CDC collected data from March 2020 to January 2021, which is all that period before vaccinations were available. And as you can see, myocarditis, or inflammation of the heart muscles, occurs much more frequently in patients who have COVID-19. As you can see, almost a 16% higher risk. And if we look at the data a little bit more closely, you can see that people who are aged less than 16 or older than 50 tend to be more affected by this, whereas people aged 25 to 39 years and higher, or sorry, 25 to 39 years old had a very low risk compared to the other populations. Now, just going into our case, we have this 36-year-old female with no significant past medical history. In fact, the only real piece of significant history on her history of present illness was that she worked in this meatpacking facility. Close contact, difficulty keeping the mask on, and again, during the midst of the pandemic, but no known sick contexts otherwise. And so just going over the hospital course, so she initially presented to the ED 3 days after having fevers, difficulty breathing, mild dyspnea on exertion, and some headache. While she was in the ED, she was actually hemodynamically stable, saturating 99% on room air, no white blood cell count, only just had a UA that showed some pyuria. The patient also had a right lower lobe infiltrate at that time. Because of her hemodynamic stability and her respiratory status, she was discharged home with a course of azithromycin and Keflex to cover both the UTI and a possible pneumonia. At this point, the patient had already been sick for 3 days. Two days later, 5 days into her symptomatic illness, she comes back to the ED, this time with abdominal pain and diarrhea. Again, satting 99% on room air, no real pulmonary manifestations. However, she's a little bit hypotensive at this time, concerning that the diarrhea is what's causing this. However, the patient was not be able to have the blood pressure improved with fluid resuscitation, and ultimately required a dopamine drip due to this concern of possible cardiac injury due to the COVID. In fact, the patient was taken to the ICU immediately, and her condition deteriorated over the next 16 hours. On presentation for that second ED visit, again, no electrolyte, no abnormalities. Troponins were negative at that time. The only real significant abnormality on vitals was a little bit of bradycardia to 55. However, over those next 16 hours, she became very hypotensive, and attempts were made to take the patient to the cath lab. However, the patient was never on attempts to go to the cath lab. The patient would code and ultimately had multiple episodes of PEA arrest. And unfortunately had passed away at that time. Autopsy would later show that the patient did have clean coronary arteries or non-obstructive coronary artery disease. And so looking back at the workup prior to the patient passing away, a bedside echo was done, and she was found to have 16% ejection fraction, which is severely, severely depressed, as well as global hypokinesis, so indicating this was affecting the whole heart. And so going into discussion, we'll have Dr. Ma take over.
Yes. So yes, hi everybody. I'm Dr. Ma. So given this presentation that we have for this patient, all this evidence, including the new onset dyspnea exertion, cardiogenic shock with a very low ejection fraction, and the recurrent multiple PE arrests, and then subsequently an elevated troponin afterwards, she has a lot of criteria that meets the clinical criteria for clinically suspected myocarditis, which is what we diagnosed her with. And again, like Dr. Kajani had mentioned, identification of patients with COVID-19 who are at risk for suffering a severe cardiac event is important, but can be difficult. In one study that was done before, and just like in our case, minority of these patients actually present with cardiac symptoms. However, determining the patient's risk level and exposure help identify these high-risk patients. Even though it might be hard in certain emergent circumstances like our patient, it would be kind of hard to get an MR study or a cath. We can kind of get history from the patient to kind of clue us into this. So identifying these high-risk patients, associated with higher levels of viral load, we can kind of correlate it with that. For our patient specifically, she has a notable history for working at a meat processing warehouse, which the CDC had previously identified as a high-risk setting for COVID-19 transmission. And although she passed away, there have been many more studies of coronavirus fulminant myocarditis that have successfully been treated with glucocorticoids and human immunoglobulin. Even then, the link between COVID-19 and viral myocarditis needs to be further studied in order to better identify and treat COVID-19 patients at risk for severe cardiac risk. Going into a little bit more, proof that COVID-19 is a cause of viral myocarditis requires histological findings, which we don't have, unfortunately, for this patient. And that will require identification of the genome or viral particles in the heart tissue and exclusion of other cardiotropic viruses in the tissue. Despite the lack of definitive link between COVID and viral myocarditis, there has been mounting evidence of this. Studies examining some autopsies of dying patients with COVID-19 have previously shown lymphocytic infiltrate in the myocardium and the presence of the genome as well as particles in the tissue. And then just kind of going through, ever since COVID has been studied, there have been a number of syndromes associated with it now that we know of, like MIS-A, MIS-C, and post-COVID syndrome. We can kind of compare this patient who was seen in 2020 with now this newly made syndrome that we have, a multi-system inflammatory syndrome in adults. And we can see she fits the criteria for having fevers before coming in, having a primary clinical criteria with severe cardiac illness, as well as shock and abdominal GI symptoms like nausea and diarrhea, as well as obviously the COVID-19 test that was positive in her case. The only thing that was missing for her case was the elevated inflammatory markers. But as we may know, it might be hard to trend inflammatory markers if they have already been pro-inflammatory before coming in, which may have been in her case because her initial ED visit had fevers, but her subsequent one did not. And so in conclusion, the etiologies of cardiac manifestations due to COVID-19 remains unclear. Although more commonly attributed to SIRS or a cytokine storm reaction, we can't really exclude other etiologies like myocarditis. Although unknown if the incidence of severely acute COVID-19 manifestations will increase again in future with the evolving variants, preventative measures still remain kind of the mainstay to prevent the burden and severity of COVID-19, as well as developing new treatment regimens for the acute setting. And again, just kind of summarizing again, the importance of the studies mainly kind of highlights the cardiac manifestations from clinically suspected myocarditis in a relatively young patient without known risk factors presenting with extra cardiac symptoms. And that's it for our presentation. Thank you for having us.
And we can open it up to questions if anyone has one. If not, thank you guys again for your time. All right. Sure. Thanks. Okay.
Good afternoon, everybody. I'm Patrick Takahashi, medical officer here at Adventist Health White Memorial. It's truly a special day, and I wanted to go ahead and congratulate and thank all the presenters for a job well done. It's special to go ahead and see so many people come across the continuum of Adventist Health to make something happen. It's special to see them come from all walks of Adventist Health to go ahead and make something happen. So that's truly something to go ahead and celebrate. I want to go ahead and thank all of the people that made this possible today. Obviously, we have our communication team with Grace Hauser, as well as our GME department who've worked tirelessly to go ahead and put this on today. I know that Denise Miyagawa is not here today and want to go ahead and acknowledge all of the work that she's done to go ahead and make this a success as well. And I'd be remiss if I didn't mention Michael Jordan, who had a passion to go ahead and really make sure that this was put on in a way that we would all be proud of. I know that this was something that was dear to his heart, and I wanted to go ahead and acknowledge the work that he had done in this space. But on that note, it's my honor and privilege to go ahead and close the event today. And I look forward to going ahead and hearing all of the stories going forward into another successful event next year. Thank you all.